of you must have come across, all the seniors here, the chronic subdural hematoma, the subdural hygroma, and the venous EDH. Well, we know about chronic subdural hematoma, that the incidence is rising due to aging population and antithrombotic treatment. It may occur bilaterally in 9 to 22% cases. Recurrence remains the principal complication in this. 9 to 33% is the recurrence rate, and it is highest in multi-layered chronic subdural hematoma. And the risk factors for recurrence are both old age and bilateral chronic subdural hematoma. Well, the most important causes can be head injury, usually a trivial one, then defective coagulation, CSF leak, which can be spontaneous, and post-trauma as well. I will run fast because I have to concentrate more on other things. The conservative treatment can be with tranexamic acid, steroid, blood patch, then surgery can be there, and nowadays middle meningeal artery embolization. So we all have dealt with this. I will directly come to treatment. Asymptomatic treatment you can just stop the anticoagulants, antiplatelets, or start with tranexamic acid with steroid. The symptomatic ones may need surgery or MMA artery embolization. Surgeries can be of various types. So the predictors of recurrence are important because the midline shift is more than 5 mm or more is the predictor. Diabetes mellitus, pre-op seizures, pre-op width of chronic subdural hematoma 20 mm or more. Recurrence is less in homogeneous and trabecular type, but it is much more in laminar multi-layered subdural hematomas. So for multi-layered subdural hematoma, you have to do either a CT scan with contrast or an MRI scan is far superior tool. We have published first time in world this technique, the membrane tucking technique for the various membranes, and it has been published already, and this is how it is done. Each layer is opened individually, the blood products are washed away, we put actually the fibrillary into that, and we take all these layers and tuck them to dura and close the dura, and this is how it goes, and the results have been very good actually in comparison to the earlier results. It works well, but obviously it is only for limited number of cases where recurrence is very high in multi-layered chronic subdural hematomas, not otherwise for every case. Now this is the most naughty of these three, the subdural hygroma. One of the most innocent looking problem, but believe me, it can cause havoc sometimes. We all know what subdural hygroma is. The thing you have to remember is that it can happen due to infection, sudden decrease in ventricular pressure due to placement of catheters or removal of intraventricular tumors. Head injury, infection, we all know those. The signs and symptoms, I will not really go into all this. The treatment, most of them don't need treatment, but some may need a simple burr hole. Sometimes a drain for 24 to 48 hours may be needed. Many times a subdural drain or a persistent ones may need subduroperitoneal shunt. And craniotomy may be needed very rarely. I've done craniotomy in one case, I had to. And this sheep turning into a wolf is a very uncommon, but at times it may lead to death even. Infection usually remains the cause of death. I would like to show you this video. This is a child, a kid neonate with intraventricular large tumor. And you see, now what I wanted to show you was this, that look at the space, the tumor is removed, and look at the space which is there outside the brain. I think this got away fast, otherwise I would like to show you this. If you don't place this balloon, you can see the space above here. A huge space is there. If you don't fill it with this sort of a device, then obviously this patient will develop a huge subdural hygroma with all added complications. So we have published this. This has been published and patented. This was published in Journal of Neurosurgery, use of inflatable balloon in a catheter, on a catheter to prevent subdural fluid collections after intraventricular tumor surgery. Post-infections equally also as a subdural hygroma can present with the hydrocephalus. Now, it creates a havoc. You know, both of them, they interplay and create problem. Sometimes it is very easy. You can just, drain it. But not all the time you're so lucky. Here it's okay. There's a child with a hydrocephalus, you put a shunt and the baby develops subdural hygroma. And then the game goes on between subdural hygroma and the ventricle and hydrocephalus. So either you have to use programmable shunts or shunt with the anti-siphon devices, but sometimes it becomes very tedious job to balance these two situations. Then post-surgery, lesions which were excised, particularly ependymoma, can be sometimes naughty. Epidermoid cyst of middle cranial fossa in temporal lobe. Twice I have gone through the problem. It is one of those cases. We excised it started filling, created pressure problems. We drained it. Again that happened. We put a shunt. In spite of that, it kept on increasing. Then fourth ventricle started dilating. Both became separate. They took a discharge. Then somebody tried to put a shunt through the fourth ventricle also. So multiple tubes were put. And this patient died at some other hospital because of the infection. And another problem is delayed venous EDH. It is easily missed because the patient sometimes presents only headache. And we feel that he has just, had head injury, multiple trauma he has suffered with, and pain is bound to be there. And we really don't try to listen to the family also sometimes. When family would like to tell you that his behavior is slightly abnormal, but sometimes we can miss those. And the venous EDH can keep on enlarging in size, and they can cause serious problems, including death. So these are the types of venous EDH. You can see the various areas where sutures are there or fracture lines are there, the venous EDH can get collected. Surgery is required only when it is too large. Otherwise, it can be treated conservatively. The only thing is you have to be careful. You have to remember that venous EDH is an entity and it can be dangerous. So good number of patients can be treated conservatively, but the most important point is to suspect formation of delayed venous EDH in cases of linear fractures with persistent headache. If patient says there's something wrong with him, believe him and investigate. The patient's gut may be more correct than surgeon's brain at times. So the take-home message from these all three sheeps, which have a potential to get converted into wolf, is for youngsters basically who are conspicuous by absence here. The neurosurgery is a serious branch. Nothing should be taken for granted or in trivial manner. The cost may be prolonged misery with lot of expenses or even the loss of life. With family and patient suffering as a primary victim, the doctor also suffers as a second victim. We also go through a lot of problems. If such patient dies in our hand or suffers a lot, then this can be a very bad situation for both the parties. So a sheep can easily turn into a wolf in neurosurgery, my dear friends. Hence, be alert, be wise, be mindful. Albert Einstein has said that a clever person solves a problem, but a wise person avoids it. Thanks a lot. Thank you very much.
Thank you, Dr. Singh, for your talk. Next, I would like to invite Dr. L.N. Tripathi for his talk on supratentorial intraventricular tumors, approaches and complications.
Good morning. Thank you, Dr. Ghosh, Dr. Pandey again. So, thank you. I thought of discussing this very interesting topic, and I will try to limit my talk to the supratentorial compartment because posterior fossa is a different ballgame for approach and for the complications. So this talk is basically intended for trainees, but I gather, I understand that all of us are trainees. We learn from each other's good ideas, mistakes. So let's go through this presentation. The common supratentorial intraventricular tumors are ependymomas, subependymal giant cell astrocytoma or SEGA, colloid cysts, central neurocytoma, choroid plexus papilloma or rarely carcinomas, meningiomas, mostly trigonal but can be anywhere else, metastasis, neurocystosarcosis, and interestingly, many juxtaventricular tumors can grow into the ventricle. Ventricle is a extensive space. If you imagine, it's a lovely space created by nature to absorb some mass, because many times we see patients with intraventricular tumors present quite late in their clinical presentation. So a giant multi-compartment pituitary adenoma, a pineal tumor growing into the third ventricle from the back, and adjacent gliomas from thalamus and nearby subependymal structures. Now these are pediatric intraventricular tumor distribution. As you can see that fourth ventricular tumors, especially medulloblastomas, ependymomas, can grow into the ventricle and cause hydrocephalus, and that's how they present most of the time. Kids with vomiting and of course sixth nerve and ataxia. Now the common approaches to the intraventricular tumors, lateral and third ventricular, open or microscopic approach and endoscopic approach. And the workhorse, the two workhorses of the open approaches or microscopic approaches are interhemispheric transcallosal and middle frontal gyrus or transcortical transventricular approach. And the other approaches for specific pathologies like a trigonal approach for meningiomas, subtemporal transcollateral sulcus for temporal meningiomas, translaminar terminalis for anterior third ventricle tumors with extension, and of course the supracerebellar infratentorial midline lateral approach for the posterior third ventricular extension of the tumors into the ventricle. Now endoscopic approaches are essentially transcortical or extended transforaminal. We saw beautiful extended endoscopic approaches yesterday and day before. So these are the diagrammatic representation of the various approaches to the ventricle. We will take case examples and one by one, and we'll discuss the interesting approaches and the complications. Now this young girl, she was 10 years old. She was having headaches and she presented to emergency and coning. She so suddenly had convulsions in the early morning and presented to the emergency while the left pupil was already dilated and fixed, and she was ventilated immediately on arrival. And in fact, we had no time to go for MRI. So this CT scan showed a large meningioma in the left side, and it was looking like intraventricular, but a part of the tumor looked like as if it was going out. Which the large intraventricular tumors can fill up the ventricle and sometimes can give this kind of appearance. It was multilobulated. So we took out the whole tumor. This is post-operative scan, and this girl has grown. This was quite a few years back. She's grown and got married and had children now. And she had no recurrence so far to my follow-up. This young man had also similarly presented with headaches, mostly headaches, and on the CT scan, he also presented in emergency, so we had to remove the tumor, and this is the post-operative patient, and this is the post-operative CT scan. There was some bleeding in the tumor cavity or the ventricle, but he remained well, and he had a recurrence after 1 year because it was an anaplastic ependymoma, and with radiotherapy, he remained disease-free for quite some time. Subependymomas are varieties, sort of low-grade variety or grade 1 tumors. They say the part of the ependymoma group, grade 1 tumors, and these are very interesting tumors because taken out, it can be 100% cure for most patients, but they are rarer than ependymomas, as you know. So this is one such example with a sizable ependymoma in the lateral ventricle, and this is a pre and post-operative MRI, and this is a naive-looking, uniformly benign-looking tumor. And so this is what, so these are this is a transcallosal approach. So the standard points that we do take the bore hole on the right side for right side approach. And this is, so the interesting thing is that putting the bore holes on the sinus or away from the sinus, you got to go to the midline, and sometimes the interhemispheric adhesions can be a little tricky to remove, separate and find the interhemispheric fissure. But slowly, carefully draining the CSF patiently, and try avoiding going through major veins. Fortunately, there were no major veins. So this is one important complications which can happen in interhemispheric approach, the sinus injuries or the big draining vein damage. And the other thing which is also quite tricky is retraction. So retraction has to be dynamic to start with, and once you drain the ventricles, you can hold with the retractor the right frontal lobe by just lifting it up rather than pushing it out. So going down slowly, and once you go to the corpus callosum, unmistakable corpus callosum, and then the pericallosal arteries. Now sometimes it is difficult to know which one is left, which is right, but once you get the true picture or clear picture of the corpus callosum, the CSF coming out, and then once you go there, you see the corpus callosum, unmistakable, white, and try to make small opening, and that's 1 centimeter opening into the ventricle, and you can see the tumor already. The tumor was subependymoma and was pretty benign looking and very, very low vascularity, hardly any vascularity. So intraventricular bleeding is one problem if you get a vascular tumor like a meningioma. There, of course, you have the standard microsurgical techniques. So slowly going in and removing the tumor, with this was quite shockable. Part of it was little firm. At times you encounter a little bit of bleeding, and then using the CUSA to reduce the size. So go around the tumor, sucking out tumor, the standard microsurgical technique, nothing different. But the main thing here was the approach, your sighting of the bore holes, the sighting of the craniotomy. The size of the craniotomy may not be more than 5 centimeters. And usually we go across the coronal suture, either half and half or 1/3 behind and 2/3 in front, so that you can get a direct access in the direction of the corpus callosum's angle. So the tumor was excised in total, and at the end you have to look for the important veins there. In the large tumors, sometimes it's difficult to know. I will show you one complication from internal cerebral vein thrombosis. Smaller tumors, usually once you take the tumor out, you get space. So as I said earlier, that the ventricle gives a natural space for you to work around the tumors, and especially when the ventricles are dilated, we elect to go transfrontally. But by and large, most of our intraventricular tumors, we went interhemispheric, transcallosal. So tumor was taken out, and then the hemostasis is very important at the end, making sure there's absolute hemostasis, and usually we leave the external ventricular drain for 48 hours for any collections. So that was the patient post-op, and he in fact is a staff in our hospital, and is back to work, and post-op follow-up MRI, no recurrence so far. This is about 2 years now. So they are nice tumors, and nice means low-grade tumors, and also good results. So colored cysts are 2% of all brain tumors, 20% of all intraventricular tumors, 99% they are in the roof of the third ventricle. Interesting thing about colored cysts is when to operate, what size. So there is a risk score, colored cyst risk score. So these are the 5 points. Age, if age is younger than 65, of course, it will grow bigger. And headaches, so headaches and vertigo, many patients will come with a vertigo. That classical presentation of severe headache and coma can happen, especially in younger age group. And so one of the girls presented, like she kind of came almost brought dead because of a large colored cyst. We had no time to operate. She was being treated by a psychiatrist. These are the risk areas, high risk areas, near the foramen Monroe and near the aqueductal opening, this is less risk. So this is risk over prediction. This is the standard opening I mentioned about, and these are the frontal, transfrontal approach, middle frontal gyrus, seeking the ventricle. You may use navigation, and then once you go into the ventricle, once you get the carotid plexus. Now here, this particular case, the cyst was little bit behind the roof of the third ventricle, so I had to do a septostomy. Once you do a septostomy, the other ventricles also drain, because as you understand that the collar cyst will have biventricular hydrocephalus. So once you do a septostomy, then you can see the septostomy is done, and you can see the cyst more clearly, and remove the cyst in total. And so transfrontal on the left and transcallosal, the similar approach for the collar cyst as well. And this collar cyst was very inspissated. It felt like an epidermoid. It was so the T2 flare, high intensity, shows that this cyst cannot be aspirated by stereotactic aspirations, or of course endoscopy can be used in all these cases to take this collar cyst out. So that is pre-CT scan, very unmistakable finding, CT scan. So I think I'll just stop here because of the time. Central neurocytomas. This lady had a big tumor intraventricular, and here you see I was telling you the internal cerebral veins. Both the veins were way pushed down to the right side, and while operating, of course, we did not see the vein, but something must have happened to the veins, and so it looked like a aggressive tumor, because this is not like a ependymoma. It was sort of more anaplastic, and that is how the internal cerebral veins are pushed to the right side, and going into the ventricle, and the high choline peak in the spectro. So this is what essentially intrahemispheric approach, and big tumor. It was quite vascular compared to the subependymoma I showed you. So initially we thought it was a subependymoma, but it was anaplastic ependymoma. So the problem was the venous injury, parenchymal injuries, and retraction injuries, pharyngeal injuries. We discussed about it earlier. Intraventricular hematoma, ventriculitis, hydrocephalus, and sometimes optic pathway injuries. So this is a post-op scan, and there was, although we did not encounter any big veins, but there was still venous infarct in the right frontal lobe, and also, so this is the last scan. So what I was trying to show is that there is obviously some injury to the internal cerebral deep veins, because we see this is external ventricular drain. There was no tumor left, but there was damage done. So these are the complications. How do we advise? How do we avoid complications? They are the standard points: the proper positioning of the patient, positioning of the craniotomy, handling the brain, handling the sinus, draining veins, intraventricular, internal cerebral vein, thalamosteroid vein, fornix. So these are the important things of intraventricular tumor. I thought I'll just mention it for the trainees' interest, and of course all of us must also remember this. So thank you very much. Thanks very much for the time.
Thank you, Dr. Tripathi, for your talk. We will now have an early talk by Dr. Manjul Tripathi on microsurgical skip DREZ for post-brachial plexopathic neuralgia.
Thank you and good morning to all of you. Sorry for intruding in between, sir. So many times I keep wondering, why does a patient come to the hospital? And across the specialties, the only problem is actually the pain. Either it's because of a broken heart or there is ICP, whatever it is. So that's the main reason the patients come to the hospital, and your role. I think the neurosurgeons are the most underrated pain physicians. Our primary complaint is pain. So for this talk, I'm going to speak on dorsal root antizone lesioning for the brachial causalgia. And I started reading and learning and doing it about once I encountered these patients in my OPD. And sincere thanks to Professor B. Indra Devi. She was the first who introduced me to this. And then Professor Deepak Agrawal, who has a very good series of work over it, apart from Marcus India, who started it, and the Kimberkel. So this is one thing which is heavily encroached in neurosurgery. Pain physicians, anesthetists, plastic surgeons, everybody tries to intrude it, but this is a concept which needs to be inculcated during your routine neurosurgical practice and the philosophy. So you should learn it, otherwise it would fascinate you or frighten you with a biased opinion. So if any one of you have encountered these sorts of patients who have suffered a brachial causalgia because of a brachial plexus injury, so he was having a pain in his upper limb. Both these patients were daily wage workers. During their work time, they suffered an accident. Then they started feeling a pain which was areflexic, completely flaccid, but extremely painful. So somebody told them, you are having a pain in the limb, remove the limb. So first they went in below elbow amputation, then they went in above elbow amputation, and then they were advised a 4/4 amputation. And meanwhile, I came into picture, so I found that probably the amputation is not an answer here, and that may further worsen this situation. A brachial plexus avulsion pain syndrome usually happens in helmeted motorcycles. It's an hyperextension injury when the head is pushed to one side, limb is extended to the other side, and then the roots get avulsed from the spinal cord. Usually it's a preganglionic injury. It avulses sometimes ventral roots, mostly the dorsal roots. And it may extend to complete whole of the upper brachial plexus. It may involve a T1 root as well. Then the patient would be suffering from other complex entities like the CRPS and the sympathetic nerve root plexus injuries. If you find these patients, it's a completely flaccid limb, areflexic limb, involving T1. You may have CRPS-like syndromes. If you go with EMG, there is a widespread acute denervation, but surprisingly, the NCV usually comes normal because the peripheral nerve is okay and it's a preganglionic injury. In the intraoperative findings, if you go, you will find some paroxysmal activity in the dorsal root ganglion because those cells whose afferent has been avulsed, they become overtly hyperexcitable. It's a very characteristic imaging finding, if I can get a pointer over there. So you get a pseudo-meningocele over there. At the time of the avulsion, the root gets avulsed and you develop a pseudo-meningocele. Sometimes it's not necessary to be at every place, depending on the extent of the injury you will get. Sometimes you get a sucked up root, and this is a very negative prognostic factor. That means the complete dorsal ganglion has been avulsed and the injury had been so severe. With this, because you do not have an afferent now, the spinal cord also gets atrophied and it may be pushed to the opposite side because the opposite side is normal. So there might be a pull and you will get an atrophied spinal cord. In the coronal section, you can see such kind of pseudo-meningoceles. On the opposite side, it's completely normal. This usually is a depiction which you find intraoperatively. There might be some normal roots above and down, and in between, there might be a complete plugged up spinal dorsal roots. On the opposite side, you can see it a very normal one. So if you go into the posterior lateral sulcus, intraoperatively, you can find that there is a clear-cut difference. This patient had an injury. You can see there is a shifting of the spinal cord because the opposite side is pulling and at the same side you are getting a pseudo-meningocele. The concept in the DREZ is to make actually skip lesions in this posterior lateral sulcus, which has become an hyperexcitable zone now. You can go with a continuous lesioning and there are various ways. On the right, we are seeing a microsurgical DREZotomy. On the left, we are seeing a radiofrequency. There are various ways to have it and there are specific complications and outcome of those ones. The rationale is that we are in the rex lamina, especially the WDR cells, which are the hyperexcitable cells after this injury, they become paroxysmally overactive and that leads to the pain. Once this avulsion injury happens, with the dorsal root, the 1, 2, 3 are usually pulled up with the root, and the hyperexcitable zone is in the zone 4 and 5, and now this becomes a very tight zone. It has become a little atrophic. On the medially, you get the posterior columns, which is a dangerous zone. On the laterally, you get a corticospinal tract. So while doing it, you actually need to enter in close to around 4 millimeter in this tight zone. And then you need to destruct this local fibers so that the circuitry is disrupted and you get a pain relief in these patients. Surgical procedure is relatively straightforward. You can see that the patient is in the pre-op situation is also in so much pain. You just put the patient in a prone position, get an exposure from C2 to T1. Ideally, it should be only a hemilaminectomy, but once I was starting, I was not sure whether I would be able to identify on both the sides. So initially, 2 cases I went with a wide laminectomy and then the laminoplasty, then the durotomy and DREZ lesioning. This is the usual picture which you get in drop. So on the opposite side, you can see the beautiful nerves in the continuity But on the right side, you get a completely avulsed structure. Once this happens, there is a severe arachnoiditis in that area, and there is a new vascularization, a pile neovascularization over the posterior lateral sulcus. If you further zoom up, you will find the pitting defect, because once the root gets plugged, there is a pitting defect in that posterior lateral sulcus wherever it happens. So with a high zoom, you can easily identify this area, and this comes as a dip over there. There are two ways. You can go with a continuous DREZotomy, but I do not like going continuous DREZotomy. The reason, it becomes an open book. You do not want to go more than 4 millimeter. Once it becomes an open book, so your depth perception is lost, and you may actually go deeper than you really intended to, and that may create a complication. That's why I do a skip DREZotomy. Skip DREZotomy means you make DREZ lesioning with 1 centimeter and then leaving 2 millimeter cuff in between that you take in the last, so that it doesn't become an open book and you do not inadvertently enter there. So that's the usual picture you get. There's no scroller here. And the way you can see here, the pitting defect and the continuous sulcus. After that, you need to do a thorough opening of the arachnoid. You need to take care of the blood vessels, which become really hypervascular in that area because of the pile parasitization. And then once you identify the posterior lateral sulcus, you need to enter over there. This entering depends, the angulation for this entering is very important. In the cervical spine, this is close to around 30 to 35 degree. In the thoracic spine, it becomes 45 degree. And in the lumbar spine, it becomes around 55 to 60 degree. Once you enter over there, you need to go, either you should have a specifically made instrument with a 2 to 3 millimeter tip, or you mark your micro scissor with a 2 to 3 millimeter tip, so you do not go more than that. Do at this particular angle. This angle is very important, because if your angle is too large, you are bound to create an injury to the posterior column. If the angle is too acute, you are going to create an injury to the corticospinal tract. So the zone is really tight, and that's why it should always be under the neuromonitoring. Do not be overconfident here, because many times once the cord gets atrophic, this angulation also changes, and then you may create a trouble. This is, you can see the change in the angulation in the cervical, dorsal, lumbar, and the sacral spine. Once this is done, I think the video is not running. Once this is done and you have made skip DREZ, you should actually take a bipolar cautery and keep it at the minimum of 1 to 5. Can you please help? This video is not running. And then just go up to 2 to 3 millimeter, and with copious irrigation, you should. Okay. You should do this DREZ bipolar cautery over there, as you can see here. It's running now. It's running now. Okay. Okay. Just a minute. Can you give just. Anyway, it's running there. It's a heavy file probably, that's why it's not running, but anyway. So just making a 2 to 3 millimeter depth of the micro cautery, you just do it at strength 1, and under copious irrigation. Once you have done a complete DREZ, then the skip part you separately coagulate. Just do not go beyond 2 to 3 millimeter, and that's the answer here. Once it is done, do a watertight dural closure, and this provides a long-term pain relief for around 10 years, 75 to 80% patients get a very good pain relief. There are certain prognostic factors once you decide this particular procedure. It should be a segmental pain. If the patient is having CRPS components or they are having an infralesional pain, then the pain control is probably not that good. The pain characteristic might be a continuous pain in majority of the patients. Some patients just have paroxysmal episodes of pains, and around 30% patients have both these categories of the pains. The pains which are having a paroxysmal ones, they are actually slightly better responding. The MR signature of the sucked up dorsal root ganglion, that's a poor prognostic factor. If that is there, then probably the patient's pain relief is not going to last that long. An accurate identification of your target is very important. Go for a DREZ from the normal root to normal root. So the exposure needs to be pretty good, and identify the posterior lateral sulcus with the proper angulation in those cases. Most of the results in the literature are actually with the microsurgery. So microsurgery, initially people were doing a coagulation. Some people are just doing the micro scissor DREZotomy. They are not using the coagulation because if the coagulation goes haywire, there is a high chance of injury to the medial or the lateral cords. And some people have started doing a radiofrequency ablation. The problem with the radiofrequency ablation is that you create a spherical lesion, and that comes at a cost of injury to the posterior column. There have been recent techniques of doing an ultrasonic aspiration of the dorsal root ganglion. That doesn't provide you that long pain relief. CO2 laser have also been used, but the best results so far have been achieved only with the microcisor and use of the cautery. I got inspired by it by Doda Mani and Dr. Deepak Agrawal, who started it, and once I was doing these initial cases, I asked these two people to guide me how to do it, and their help really helped the patients and in gaining a further experience for me. Other options are definitely spinal cord stimulation, but in cases of these brachial plexus neuralgias, they hardly give much long-term benefit. You can go with an intrathecal baclofen pump or the morphine pump, but the problem is that the arachnoid is so much scarred and the CSF circulation is so much hampered that these things do not help in the long term. So probably this simple procedure using your routine microsurgical techniques can provide a long-term pain relief to these patients. And this is actually, these patients are actually in a miserable situation, and you can definitely help them. Thank you so much.
Thank you, Dr. Tripathi, for your talk. Next, I would like to invite Dr. Adil Chakla for his talk on surgery of orbital tumors.
A very good morning to all. We'll try and save as much time as we can. And I'm grateful to all the people who were here early in the morning after a fantastic gala last night. At the very outset, I'd like to thank Dr. Ghosh for having included me in this fabulous program. And to be honest, it's been one of the best meetings that I've attended. Not to say that the venue has been marvelous as well. So we're going to talk about orbital tumors. Talking about the orbit and space, lots of things have been happening in the space in the recent past, and it's quite mind-boggling. So, are we on? So I am presently at Naya Hospital. I used to be at KM for nearly 30 years. I'd like to say that these tumors are rare. They have a wide histological variance. They're benign for the most part, and they pose surgical challenges even today. I'd like to just mention that there's a safe access from the cranium. Multiple specialties deal with them, and neurosurgeons I would like to put on the top. How should we tackle these tumors? They're devastating sometimes and often cause blindness as well. So this is the data bank. And I'd like to put this slide only to tell you the type of histology that we deal with. So you have neurofibromas, meningiomas, hemangiomas, lymphangiomas, lacrimal gland tumors, etc., etc. So pretty much the entire gamut of tumors. And also, in the malignant variety, pretty much the entire gamut of skull-based tumors. Now, this is a question I pose often, but even in this case, for example, and this is after surgery, you have normal vision and normal eye movements. How do we achieve this? To achieve this, you must know the past. If you don't, then you're condemned to repeat it. And you can see almost 140 years ago, you have lateral orbitotomy described. Dandy, who we addressed this meeting for, described what is known as the subfrontal technique, which is also used today. We must know the anatomy. 7 bones make up the orbit. We realize that the orbit is cone-shaped, and the advantage of operating at the base of the cone allows us to dissect and get these results. The apex, the orbital fissures, the vascular supply. You must have dissections in the lab. And I'd like to dwell on this slide. You can see that the medial wall of the orbit is almost in the direction of the sagittal suture. So that's the direction in which you should use your micro instruments so that you don't cause any injury to any of the structures. And as you come lateral, or you're lateral to the optic nerve, you're 45 degrees lateral, and that's the direction of your dissections. Imaging studies, we'll go through a few. I always like to get plain X-rays. You can see the orbital fissure, the roof of the orbit, and so many other structures. The CT scan tells you a lot about the bone as well, and it shows you the different types of enhancement patterns and how vascular the tumor is sometimes as well. So you can see that there's a optic sheath meningioma, there's a orbital meningioma arising from the periorbita, you have a cavernoma, you have neurofibroma. So the MRI tells you a lot more. You can see how the tumor is being compressing the optic nerve. You can know the displacements of the optic nerve. This is an epidermoid, a hemangioma. So the MRI definitely tells you a lot more, and it's important for us to have the MRI as well. You can see the nerve displacements, and this actually tells you how to attack the orbit, whether to come from lateral, come from below. And often, if there's an indication of a very large tumor with increased vascularity, then I do a DSA and even a pre-op embolization. The surgical approaches are the lateral orbitotomy, which is the mainstay, and then you have the subfrontal approach as well. There are other approaches that are not as common, but you must know them because you might have to use them accordingly. So let's dwell on the microlateral orbitotomy. So this is the bone work from within, and from outside, you have this shown to you. You can see that this is where the burrow goes, and I take the skin always in the hairline, so you can't see the incision at the end of the case. Now this burrow, this marking is of course also to show you the subfrontal approach. I'll skip the video in the interest of time. You can see the subfrontal bone work in this image, and this is how we do it at the time of surgery, protecting the nerve as well. This is the bone flap that is elevated. You can see we've retained the roof of the orbit so you don't get a pulsatile orbit at the end of the surgery. This is the superior lateral, so you're actually just going a little more lateral. And again, the same. A single burrow will do the trick. So this is the bony exposure. You can see the periorbita. There's a small rent there, and you can see a bit of orbital fat jutting out. I use the bone dust to reconstruct whatever deficits in the bone or cosmesis is required, and I layer it with Surgicel. Now, this is a superior lateral orbitotomy. I can suture the bone back with just simple sutures. Of course, some can use plates as well. Now, you can see that these are larger exposures for larger tumors and more complex cases. So this is the bone work from within. And here's one such case in which I had to use this approach. This is the skin flap incision again. This is slightly larger skin flap incision. And here you can see the bone work. What I do is I put petties in the key burr hole so that protects the dura when I do the osteotomies from below. This is the exposure once the bone is out, and you can see the tumor surfacing there. And then you can excise the tumor, and this is the reconstruction again with all cosmesis. So again, using just simple sutures is enough. This is with the entire proptosis disappearing immediately post-op. So this is another approach. You can flap the muscle so that, again, you can get a good cosmesis. Simple instruments that are on a routine neurosurgical trolley are used. Again, this is a complex case of a capillary hemangioma, which required this kind of an approach. Medial orbitotomy for very few cases when the tumor is in the cone and on the surface, not too much at the depth, we can use this. I don't like to use this again because there's a scar on the face. So this is a medial orbitotomy. You can see that a small incision, quick surgery, significant tumor debulking or excision is possible. These are the results. Results are important, but for each case, it's almost 100%. So I guess one has to be honest in his opinion of what he's going to achieve for a patient. And this is the classification: total, subtotal, partial, and exenteration for malignant cases. So I'll take you to some of the cases that I've done pre and post-op scans. You can see the pre on the left and the post-op scan with the total excision on the right. Dermoid cysts are obviously the best, but you can leave a capsule and they will have a recurrence. So that has to be done well as well. Total excision in the meningioma, sometimes difficult, and very difficult when it involves the optic sheath. So this is, again, a pre- and post-op scan with total excision. Subtotal, when sometimes in neurofibromas also you can have the tumor adherent to the optic nerve or other important structures, then there is a small residue, and there is a small risk of a recurrence. You can see partial excision in the capillary hemangioma. So let's quickly run through some of the cases with how we position, how we do this. So you can see the proptosis in this young girl. I take an eyelid stitch so that there is no chance of any further proptosis during the surgery or handling. And here you can see the tumor. You can see what the result is when we remove the sutures, which is on day 10. There's a bit of edema. There's a bit of lack of movement to the side. And this is the pre-op and post-op scan results. And you can see this young girl with normal vision and normal eye movements. This is another case of a hemangiopericytoma. You can see there's a tumor which is actually pushing the globe right outside, almost as if the globe is, the eyeball is hanging outside the face. And this is an early post-op image, and you can see that this is the result that we got. In fact, the ophthalmic doctors wanted to take the eye out. I put this slide out because you can see that there is a scar on this girl's face, which is here. You can see that it is lighter than her complexion. And imagine if this scar was across the face here, like Nafziger's incision or an eyebrow incision. So I preferred to take a little more time and effort to make the incisions in the hairline. You can see that there's no deficit with the frontalis branch of the facial as well. These are neurofibromas. These are good tumors if they are completely disconnected from the eye, from the optic nerve. And a micro lateral orbitotomy is just enough. In fact, even the rim of the orbit is not excised. Here's the pre- and post-op results. And here's the patient in the early follow-up. And this is the lady after 3 months. This is the cavernous hemangioma, slightly more complex compared to the neurofibroma. Again, micro-orbitotomy, the lateral orbitotomy. 10-day post-op and the suture is out. There is a bit of restriction in the lateral movement. In 3 months, the patient has all the movement, no proptosis, normal eye vision as well. A little more complex, this is the capillary hemangioma. You can see the capillary hemangioma even on the surface of the skin. This is more elaborate, a slightly larger excision. The tumor is on the medial side of the orbit as well. You can see the pre- and post-op images here. A more challenging case, no doubt. You can see the post-op result, and you can see that she has pretty good function 3 weeks later, and see how she is 3 months later. So these are some of the cases which are more challenging and should be done with a little more caution. This is an optic optic nerve glioma. Excised, she was blind, of course. This is a cancer patient, an elderly lady. Again, excised, a simple plate used to buttress and reconstruct the lateral wall of the orbit. So there are some differences between the pediatrics and the adults, like the shallow orbit, proptosis. Large craniotomies are probably necessary in the pediatric age group. Blood loss may be an issue. And of course, the poor developed air sinus can be a plus or a minus. Complications or concerns. I don't like to use the word complications. It's like a batsman going to say that I'm going to get out on the next ball. So I look at probable problems that the patient might encounter, and I discuss that with the patient's relatives. Recurrence is a problem, and we must be aware of that. So unlike a drug company, neurosurgeons are bound to use the word complications. Who would ever use the word side effect for treatment? So you have a deterioration in patients with an optic sheath meningioma, of course, optic nerve glioma. I had one of a cavernoma where there was spasm of the vessel that supplies the eye, the retinal artery, and the vision wouldn't come back. You might get the vessel coming back, but vision will not come back. So no mortalities. Recurrences were there in the cases listed above. And these are the do's and don'ts. I like to use sharp dissection most of the time when there's an eloquent structure in the vicinity. And of course, avoid using extensive cautery, even bipolar. So these are some of the do's and don'ts. Mini plates not to be used in pediatric age group. And the conclusion is successful surgery can always be attained. Safe excision is the aim, and excellent results with just simple standard microsurgical principles. Thank you.
Thank you, Dr. Jagla, for your talk. Next, I would like to invite Dr. Survendra Rai for his talk on brain tumor interface dissection techniques.
Good morning, everybody. First of all, I would like to thank Siddharth Ghosh sir and Anil Pandey sir for giving an opportunity to present my work on brain tumor interface dissection technique with surgical blade from laboratory to the neurosurgical operating room. We all have seen these kind of lesion. This is a post-radiation induced meningoma. And following a surgery for fourth ventricular astrocytoma, she received radiation and she developed this radiation-induced meningoma 15 years back, and she was being followed up because of the motress. It was a motress strip, so it was followed up. And later on, her papa started to deteriorate, so she needed surgery, and of course, she was operated, and immediate post-op also, her power was near normal, means as pre-op. Then again, I operated about 3 weeks back. This is this person is a writer and husband of actress. And this patient had been operated in 2019, and he came to us with this extensive lesion, and he told my head of department that, doctor, please remove only tumor, not my sense of humor. And with this kind of lesion, we know what could be the outcome. So this is the subdural hematoma. I know there is some many form treatment. But of course, through burhole, it can't come. So what I did in this case was complete excision of the membrane, both even the lying over the pia. So like everybody has to introspect. I will not ask what would be the outcome in these cases. One has to introspect. And this was the case post-op. He was grade 1 down post-operatively, but eventually he became, as is seen, and there's a small remnant near the pericallosal area. This is a vestibular schwannoma, and this is a. So, if we have success once, it may be by chance. If we have twice, it may be like coincidence, and if we have third time, it may extremely rarely. It may be we may be extremely lucky, but if we can have success every time, that means we need to have some techniques to replicate the process every time and now again. Of course, it is with the image, the visualization. We have got a good MRI machines. So we have fiber tracking and DTI imaging, all these new things coming up. So we think that the good result is just because of the intraoperative neuromonitoring or the best CUSA that is available around the corner. So let's analyze what we do conventionally, what we do, and what we can do with the scalpel, the simple, inexpensive equipment. These are the instruments that we use now currently to remove any lesion. It may be a single instrument or combination of many of those. So the most important part of the act in removing tumor is the brain, working at the brain-tumor interface. So what is the thing that comes in the action? It's the tip of the instrument. So for me, it's the most important thing. So let's analyze that in the brain-tumor interface, this is the brain-tumor interface. And these are the equipments that we routinely use. And most of these equipments, they are more than a millimeter size. However, the interface is not millimeter, it is in micrometers. So, and there are very few equipments. So this is a brain-tumor interface. If we imagine that 1 millimeter is equal to 1000 micrometers. But then the brain tumor interface will be in micrometers. It will not be in millimeters. And so it is like 1 millimeter divided into 1,000 parts. So it's a very small, narrow zone that we need to work in. So currently whatever suction we have available, the least size is 3 French, which is about a millimeter in length, millimeter in diameter. The micro scissors, what the sharpest tip is about 1.1 millimeter. And if you think about KUSA, the best equipment and all the neurosurgical institutes have, the tip diameter, the least you have is 1.14 millimeter. And that also vibrates 308 to 355 micrometer. So, and plus you can't use in contact with directly with the contact with the cranial nerves. That's another issue. And you have a latest KUSA where they have modified these settings and that vibrates in less than about 180 micrometers. So this is the latest equipment and this is the data. And so what the outer diameter is still 1.45 millimeter and plus it has to carry out a vibration of 180 micrometer. Now you can use water jet dissection to separate some tumors. But mind well that the smallest size needle which you can have is 30 and the outer diameter is 0.305 mm. So, but that small size you can't use practically while the time of removing tumor because it is very difficult to push fluid and for that large size lesion. And what is the optimal pressure that you can go is maximum is 60 to 40 bars. And this is the type of blades that are available currently in the market. But for us working under microscope, under high magnification, the most suited one is a 15 number blade. However, you can use 11 number, but the tip is very sharp and it's very difficult to control the edge. So this is the different types. And there have been studies on this blade, like improving the quality of surgical scalpel. So if you make a scalpel out of metal, it can go up till maximum up to more than 10 micrometers. But with ceramic blades, you can go down up to 1 micrometer. So they have an important implication as far as when you transact any structure. So there are studies published like if you have the scalpel's roughness definitely affects the post-transaction peripheral nerve regeneration. So you can see that the edge, upper portion edge, they have a roughness of 400 nanometers and down 400 micrometers and down you have a roughness of roughly 25. So the roughness also affects the healing capacity and the regeneration of the neurons. Now this is the evaluation of skin wounds with the scalpel. Like with wound with 0.8 micron scalpel heals better with 12.5 microns. Now this is an obsidian surgical steel scalpel. The obsidian is a material which is naturally occurring and earlier times they used to use for cutting. Now this is so sharp that it can cut a cell into half and you can have an edge of 3 nanometers. Now we have a microscope, this objective of various size and with the eyepiece you can have a maximum magnification of 2.9 to 62 times. Now with this kind of magnification, see whatever we see under microscope, we are seeing everything, imagining DTI, imaging everything in a micro. But when we comes to operate, we are working with the macro instruments. So there is a discrepancy in what we see, think, understand and act. Because our act is at the interface level. And so everything, whatever equipment we count, that is has to have some implication at the interface level. Now, this arachnoid layer is about 35 to 40 micrometer thick. So if we have to separate, we have to enter in the perfect and precise surgical plane. So we resect the tumor completely and preserve the tissue. For this, we have to enter in the interface. So how do we manipulate it? And how we can understand that to what extent we are able to resect or dissect. And what is the objective method to verify this? So we developed a simulation with this copper pod leaf, which is 120 micrometer thin. And there are other leaves, like you can see the bougainvillea plant, or you can even use the cotton, tomatoes, but they are very thick. So with bougainvillea, it's more thinner than this. And you can try dissecting it into half. So I have labeled the 1 millimeter, and this is the 120 micrometers. This is so thin. And this, under microscope, you can try to dissect the upper half so that the other half remains. And this was done in the microscope in our laboratory. And this is the 20 zeta optical microscopy. We analyze these leaves under microscope, non-contact microscope. There you can see the clear-cut, the edge, cutting edge difference. And we were able to dissect up till the level of 17 to 80 micrometer. So our arachnoid layer is 35 to 40 micrometer. So with practice, it is able to preserve the all structure. If we can preserve arachnoid, all structures are lying underneath are preserved. We need not to worry about what is beneath it. And if the arachnoid is breached, then we can still stay as close to the tumor as possible. So we minimize normal tissue damage and we preserve function as far as possible. This is some of the published photographs. And see, we preserve the arachnoid, and this, when I published, it was less than 10 cases, but now over years, I have done more than 60 cases, which were lying mostly over the eloquent area. One case had this hematoma, required removal of that, and all the cases, I had no nerve deficit. And these are large size tumor, and this is the video. So this is the leaf, which is being dissected with the sharp edge, and we can dissect, preserve the other half, and this is how we can come to know objectively to what extent we can go dissecting with our scalpel. And these are the two tumors. The lower one, right lower one is a primary meningioma, and the left side upper one is radiation-induced meningioma. You can see that the radiation-induced meningioma, there is no clear-cut definable plane, and we have to make sharp cut at the interface. But while in case of this primary meningioma, we have a clear-cut defined arachnoid layer, and we can preserve arachnoid, we can cut the tumor. The lower one is the vestibular, they say a collision tumor, meningioma plus schwannoma of the posterior fossa. It is getting operated under this in sitting position. And you can see that I am not using retractor, but I am trying to dissect, I'm trying to debulk the meningioma now. And you can see that with knife, I am able to separate small vessels, and which is normally wouldn't have been possible. And this is like plain, simple cut, without devoid of any heating effects or any vibration. And it's really thin. We can go wherever we want. We need not to, and we can go anywhere we want. And plus, it can be used near any critical structure. We can go near nerves. We can freely dissect. And we can not only dissect, but we can at times retract also with the flat portion. So it can have, you can see on that the meningioma part in the posterior fossa, I am trying to preserve the thin layer. I know exactly that I have reached the edge of the meningioma, and it's all with the sharp dissection. And I am preserving every layer and peeling off the tumor. So it is possible to do these cases without. And this is the upper one. You can see the image. That is the meningioma that I showed you, difficult one. And you can see that while I am dissecting, they are all veins which are lying underneath, and all the structures are getting preserved. And I am trying to resect tumor. There is only resection of the tumor, but we need one assistant who can suction, and a continuous irrigation is required to wash off the blood, because it is not possible to make any sharp cut without having clear-cut vision. And we go on resecting the tumor and preserving whatever is there. But still, in these situations, some minor amount of injury is bound to happen to some cortical structures. But we were able to resect the tumor completely, leaving a small portion near the pericallosal area. And you can see that the tumor, this meningioma, they also are stuck at some places. They are free at some places. So if you are able to remove meningioma completely without any deficit, it may be the tumor itself is favoring you because it was not adherent. But once it is really adherent, you have to really make a good dissection to remove the tumor without any deficit. Like you can see on the upper corner, how it is adherent, and it is like almost invasive. It's basically in-plaque type of meningioma, infiltrating, invading everywhere. And you can see that how the tumor is getting separated. Yeah, just a second. I just, And the down, again, one vestibular schwannoma we are operating where the maximum, about 70% of the work is done by the knife, this. And this is how so I'm just, for want of time, I will just, so you can see that the even facial nerve is seen here. Down, yeah. And it could be, the tumor can be radically resected. And this is a post-op patient. Yeah. So, in conclusion, with sharp tool, you can achieve whatever you want, and you can really go down dissecting to the level of 18 to 55 micrometer. It is superior to all existing technique. And apart from superficial tumors, you can go for the deep-seated lesion also. This is our publication. And this is, the best things in life are free. Second best things are very, very expensive. Like, you don't pay for oxygen. Oxygen is freely available. And reality isn't the way we wish things to be, nor the way they appear to be, but they are actually are. And I recommend young people to use more knife. Don't fear. Thank you.
Thank you, Dr. Rai, for your talk. Next, I would like to invite Dr. Vikram Pujari for his talk on Transsulcal approach for resection of deep intraaxial lesions in eloquent brain areas.
इसको स्क्रीन बड़ा करना, इधर बड़ा करो जरा, इधर बड़ा कर देना, इधर बड़ा करना, इधर फुल डिस्प्ले चाहिए मुझे. Good morning, my friends, dear colleagues and seniors. Here I am presenting Transsulcal approach for the resection of the deep intraaxial lesions in the eloquent brain areas. As you know, resection of the intraaxial tumors in eloquent brain regions risk major post-operative neurological deficits. Awake craniotomy with neurophysiologic mapping is often used to navigate these areas. This technique is time-consuming. Some patients are ineligible for awake procedures. Extent of resection for lesion positively correlates with the improved patient's outcome. A variety of techniques are necessary to increase access to the lesions hidden within the eloquent tissues. The Transsulcal approach was introduced to reduce the parenchymal trauma during the tumor resection, offer an alternative method for preserving eloquent cortex without the need of awake mapping. The Transsulcal approach preserves the projection fibers of the cortex at the expense of the short associating fibers. Projection fibers are the white fibers that are perpendicular to the cortical surface. The fibers often traverse across the hemispheres as well as within the tracts to and from the peripheral nervous system and the deep brain structures. Short association fibers, also referred to as U fibers or arcuate fibers, are short white fibers that lie at the floor of the sulci and serve as the cortical connection between neuronal gyri. This approach is technically straightforward, does not require the use of intraoperative monitoring or awake craniotomy, and avoids dissection through the important white matter tracts. This is the sulcal anatomy. You can see that sulcus at the floor of the sulcus, deep-seated lesion is there, projection fibers you can see, and the projection fibers are not damaged when you go through the transsulcal route. On the arcuate fibers at the floor, they are damaged in this approach. Anatomy for the eloquent area, as you know, all of you, so we are not going through the details of it. Eloquent regions are very defined as the bilateral pericentral gyri, bilateral postcentral gyri, left frontal operculum, left superior temporal gyrus, and bilateral visual cortex. This image shows the spatial relationship between the eloquent fiber tracts and cortical areas, arcuate fasciculus, central sulcus, external capsule, precentral gyrus, postcentral gyrus, superior longitudinal fasciculus, then temporal horn, the left temporal loop of the optic radiations, and uncinate fasciculus. This image shows the arcuate fasciculus, claustrum, corona radiata, external capsulus, superior longitudinal fasciculus. The cingulum gyrus, the C-shaped fiber tract is the longest association fiber system in the medial side. Cingulum, corpus callosum, and body of the fornix, you can see it. Here is a case report of 47 years female patient with history of 2 episodes of convulsions, gradual onset of weakness in the right side of the body, for grade 3 by 5 in upper and lower limbs. Radiology, you can see the left-sided parietal lesion is there. A preoperative assessment of all patients, including contrast-enhanced MRI and CT for the lesion evaluation, approach planning, target selection, DTI tractography, and fMRI were used when deemed necessary to map important white matter tracts and assure the transsulcal approach would not cross them. All procedures were performed under general anesthesia. Neuronavigation or CT scan can be used to outline the craniotomy overlying the target sulcus. The dura was opened and the target sulcus was identified. Microsurgical dissection of the overlying arachnoid was followed by the blunt dissection of the sulcal artery and veins, which were then padded with cotonettes for the protection until the floor of the sulcus was reached. At the floor of the sulcus, small corticectomy over the lesion was performed and the lesion was visualized. Tumor debulking and resection was performed utilizing both bipolar corticoid and suction or cavity ultrasonic surgical aspirator. Infiltrated lesions such as gliomas were excised using supramarginal resection. Dynamic retraction with surgical instruments and cotonette was used on the sulcal walls. Patient was transferred to the neuro for a recovery for surgery. These are the CT scan images, what we do for the tumor marking for the craniotomy. We can go see that we have done a CT scan for this is a marking of the tumor for the craniotomy. This is a short video I will like to show. This is the arachnoidal or the sulcus, which we can dissect it. Once the arachnoid is dissected, you can see around 3 to 4 centimeter of the length of the sulcus can be opened very widely without damaging the gyres. And so once you widely open this sulcus, you reach at the floor of the sulcus. Very minimal. You can reach up to depth of around 4 to 5 centimeter also. So the sulcus pave the way to the depth of the sulcus. And once you reach at the floor, you will find the lesion. And very minimal retraction has been done for this. And once you find the lesion, you can start debulking the tumor. So tumor debulking was done. Sorry, I was doing. So this was a big lesion, subcortical, and we have removed almost total excision of the tumor was been done. I'll run through the video. And once the tumor is removed, achieve hemostasis. And this is the gyres, which are very well preserved, and there is no edema of the gyres. We do ultrasound to see any residual is there. So you can see the bed of the craniotomy where gyres are well preserved. There is no edema, there is no inflammation. So wide sulcus opening is important here. So this is a post-operative immediate third recovery day of the patient. Patient is well preserved, and even the power was improved in this patient. So in conclusion, the transsulcal approach is a viable alternative for the lesions in eloquent regions of the brain when patients are unable to tolerate awake craniotomies. This approach causes gyral cortex and the projecting fibers of the white matter, reducing the post-operative neurological deficits and minimize the post-operative morbidity. Wide dissection using transsulcal approach enables enhanced visualization of the lesion margins. Ancillary techniques including IOS, 5LA can be employed to improve resection of the lesion. Gross total resection of the deep intraaxial lesions can be achieved without damaging the adjacent eloquent structures. So wide opening of the sulcus is the thing which you have to do, and you can preserve the total cortex, and the less morbidity and damage to the cortical gyri can be achieved. Thank you very much.
Thank you, Dr. Pujari, for your talk. We now have an early talk by Dr. Tandapani on MIS for high-grade listhesis and complex injuries.
Thank you, Professor Go sir and Dr. Pandey sir, for making my presentation early because I had to go to Mangalore. So I'll try to. Can you reset the timer? Thank you. So I'll be talking on MIS reduction in high-grade listhesis and complex dorsolumbar spine injuries. So sometimes the questions comes, what are the limits of minimally invasive spine surgery in the form of percutaneous pedicle screw fixation? There are kind of proponents as well as there are lots of critics. So the concept of minimally invasive spine surgery is whenever the spine is already unstable and supporting on bare minimum structures, then it doesn't make sense to disturb those structures and make it more unstable. So the most important concept in spine is there is a posterior ligamentous tension band. So in most of the open surgeries, you disturb that and you destroy that. So you tend to do more aggressive implant fixation because you are making it more unstable and then trying to stabilize it. So the minimally invasive surgery is you try to do whatever is needed without disturbing the posterior tension band. So that is the biggest advantage. The minimally invasiveness, less blood loss, lesser pain, early mobilization, lower infection. So all these things are there, but philosophically, the most important thing is you preserve the muscles, you preserve the ligamentous tension band. So whenever we used to do these things using C-arm, we have to measure all these things, the length, diameter of screws, medial angulation, skin entry points and all those things. But nowadays, we are doing it with O-arm fluoroscopy navigation. So in which we are able to get an axial images and able to achieve bicortical purchase. So C-arm based percutaneous pedicle screw fixation, what you see is what you get. But when you are doing navigation in an unstable spine, you can be grossly wrong because kind of compared to cranial navigation in an unstable spine, it is not rigid immobilization. So there may be intraoperative shift of structures, so you'll have to be careful. Degenerative spine, not much shift, but whenever you are operating on unstable spine, you have to include that there is a possibility of shift. And the biggest advantage of O-arm navigation is you are able to achieve a bicortical purchase. So because you are able to put a larger screw, longer screw, bicortical purchase, the conventional teaching that you have to do long segment fixation in unstable spine doesn't hold true anymore. So when we talk about listhesis, so I'll skip these techniques. These are well known to all of us. So the key thing is whenever there is an instability at a particular level, there is listhesis. And as a disclaimer, we don't operate on any asymptomatic listhesis. Even we don't operate on patients with just discogenic radicular pain. It has to be a symptomatic listhesis like low back pain or severe claudication which is necessitating facetectomy. So whenever there is a severe listhesis, we have to make sure that that part is fixed and fusion should take place. So the cage has to be placed here. So if you have to reduce the upper segment, you'll have to, we usually go 2 levels up and 1 level below, and so that when we try to reduce, the forces are tremendous, that it is divided between the 4 screws, so that the force will be only 25%. But if the forces are too much and only 1 level is included in the fixation, then 50% of the force will be in each screw. Sometimes the screw pull out may happen. So, so kind of conventionally, we go 2 level up and 1 level below, and then we try to put in screw in such a way that the direction of the screw is the actual displacement, it is the actual intended direction of displacement. So we try to go as vertical as possible, but you'll have to include as maximum purchase as possible. So you'll have to have a balance between the both. We use warm and we use navigation for all these cases. So these are some of the cases. As you see, this is the degree of listhesis. 2 level up, and we try to get maximum purchase. When we try to reduce, sometimes in osteoporotic spine, there may be little bit of screw pull out, that has to be accounted for whenever we do such cases. So these are some of the examples how there is too much instability, and we have tried to correct them. And these are some of the examples of high-grade listhesis being corrected. The aim is not a perfect radiological reduction. The aim is to reduce as much as possible, but we always try less than the perfect, so that the forces are not too much. And the cage placement is very important. Very rarely, if there is no place, you can put in bone chips. Otherwise, we try to achieve a good cage placement, will distract the space, and the foramen will become widened, so any foraminal stenosis also will be taken care of. And so these are some of the cases. I'll just, so we try to, when we want to reduce, sometimes the curve, if you make it too much curve, the reduction doesn't take place. But when you make it straight, you can achieve reduction, but it is very difficult in simple Indian made implants, it is very difficult to reduce. So we'll have to make a balance. For a good reduction, it has to be as straight as possible, so that the screw will be pulling the vertebrae posteriorly in the direction we want. And not always we are able to achieve a good reduction. Sometimes, despite your best efforts, you may not achieve a good reduction, but as long as patient is symptomatically better, and that is okay. Sometimes we use perforated screws whenever there is severe osteoporosis to have a good. And whenever there is a good mobility, it is not necessary to include 2 levels up, because when there is good mobility, you can just with 4 screws try to reduce and bring them in good alignment. So these are some of the cases in which we have done just using 4 screws. So very rarely we get cases in which there is retrolisthesis, for which we have to do fixation. So the video I'll skip, there is nothing unique. And now we will come to complex injuries. So the criticism of minimally invasive surgery in complex injury is inadequate decompression, and cage placement is not done, and not focusing on bone grafts and fusion, and lack of crossbar, and long segment constructs are usually thought needed to prevent long-term deformity. But when we had published this some time back, this was a patient of a complete traumatic spondylosis with intact neurology, and I just sent it to some of the spine WhatsApp groups. I was kind of badly criticized that it is a very improper technique. But then I had to clarify that a complete traumatic spondylosis with intact neurology is very, very rare, and there is no report of a good reduction even with an open surgery. And because if there is no report at all, it means that anybody who has tried to achieve a reduction must have led to deterioration, and that's why there is no literature at all. So the only successful management reported are till now just in situ fixation. But this is the first case in the world literature of an MIS in situ fixation for. So it is not necessary that you have to achieve good reduction radiologically. As long as patient is asymptomatic, you need to only make it stable, so that in the long run patient doesn't even have any kyphotic deformity. So, but conventional teaching is that longer segment fixation is necessary in dorsolateral junction injuries. So we always try to do as long segment as possible when we had started doing. As you see, this is the end result of this, and whenever possible we include the fractured area. So index screw is needed whenever it is feasible, so that will act like the center of the fixation. And direct decompression and cage placement, is it really needed? These are some of the illustrations in which we have just done an MIS percutaneous pedicle screw and ligamentotaxis. And as you see, the canal is opening up. That this is causing indirect distraction and decompression. So we have not done any laminectomy in any of these patients. Just a distraction and fixation. As you see, the canal is widely opening it up, and patients long term, those who are in B, C, D, they improve a lot. And you can look at the MRI also, how the cord compression is getting relieved in the long run. And even short run, we have seen many patients, just after surgery when we do CT scan, the canal, the diameter is getting widened. These are some of the few illustrative cases. So this indicates that you don't need to do a kind of corpectomy, cage placement, because this is a fractured normal bone. So if you give them adequate space, they go back to their original place and the canal becomes wide. So ligamentotaxis and osteosynthesis works, no need for decompression and cage placement. Sometimes for achieve a long segment, you can do different levels in right and left. So, and we have even seen that sometimes when we had to do short segment fixation, still the results are not bad. And if you look at these cases, the canal is opening up, the vertebral fracture is getting, the configuration is becoming normal. So it is possible that bicortical purchase makes short segment fixation effective. So these are some of the cases in which we have done using just 4 screws and the results are quite good. So not necessarily that every case we have to reduce. So when we analyze the results, these are well known: duration of surgery, blood loss, hospital stay, and the pain also is better. And the pedicle violation, because we are doing it with navigation, it is almost 0%. And radiation is better compared to open surgery with C-arm. The radiation dose is significantly less. And long-term outcome, the screw migration is significantly less in percutaneous pedicle screw fixation compared to open method. This is the screw migration index. And corpse angle maintenance is 74% in percutaneous pedicle screw compared to open surgery. And even the disability and the skim score, they are all significant, they are all very kind of close to significance, it's better. So in dorsolumbar fractures, we do reduction and stabilization. We aim to achieve osteosynthesis, and in listhesis we reduce as much as possible and do interbody fusion, stabilization and foraminotomy, as that's the aim. Very rarely we do for refractory chronic severe low back pain, stabilization and foraminotomy. So MIS is effective in complex listhesis and dorsolumbar spine injuries. They have a better outcome. And the OAM navigated percutaneous pedicle screw is more precise and it has better results than C-arm based method, and very long segment fixation and crossbar and the bone removal cages are not necessary. Thank you.
Thank you, Dr. Dandapani, for your talk. We now have an early talk by Dr. Sushil Patkar on innovation of craniovertebral fixation. This is the last talk of the session.
Good morning. At the outset, I'm grateful to Professor Ghosh and Dr. Pandey for once again inviting me and for this opportunity to put forth my work and to the Dandy Foundation. This is where I've done most of my work, and I work still now at the Pune Hospital. I've stopped working at the medical college. So craniovertebral junction, for the people behind, is like this. When you start, you feel you know everything. Then suddenly the complications set in, and then gradually you start, I've still not reached on top. My mentor, no disclosures, my mentor and my lovely wife who has been my anesthesist for many years. So it all began like this, from behind, because orthopedic surgeons were the pioneers of craniovertebral junction. William Galley, but all this was like this, trying to control the horse from behind by catching its tail. The predominant movement at C1, C2 is rotation. Any technique that stops rotation fixes the joint. So it was the work of Megal, where the first innovation, where he passed the screw across the joint and stopped the movement. This was the beginning of craniovertebral surgery. It had 100% fusion rates, was a fantastic operation, the best technique still to stop rotation. However, the vertebral artery. The vertebral artery did not read the textbooks. It comes in various kind of courses and can be really treacherous, and therefore this operation cannot be done more than 30 to 40% of the times. Again, like this, sometimes it is dorsally, and finding a new solution, necessity is the mother of invention. You have to keep on thinking how you can simplify it. What is innovation? Innovation is nothing else but trying to make it simpler. And it was Dr. Goel and Dr. Lahiri in 1994 who described this technique of plating for C1, C2, and then Harms, but for a long time it was called Harms technique. Now this was Goel's technique, which consisted on, still is this technique, where Jesco makes these plates, but these are not locking plates. And his entry is the PARS entry. This is described in various articles. And then Harms came with a technique where he claimed that the incidence of vertebral artery will be lesser, and he used the polyaxial screw rod construct, which became more popular, and most people now follow the polyaxial screw rod construct. But we have to remember that there is a lot of vascular structures over there, the C2 root. Necessity is the mother of invention. Research is search again. So if you study the course of the vertebral artery, there are various articles. There is a fallacy because most of us study the CT scan in axial plane, but actually if you do the 3D CT scan, there is dense bone irrespective of the vertebral artery under the facet. So this was the entry point described by me, where we pass this screw just under the facet, there is no vertebral artery over there. So if you study the coronal scans, then you'll always find that in almost every case, there is bone under the facet. And mind you, the densest bone is under the facet. So the most rigid fixation is possible if you pass the screw under the facet. This was published way back in 2016 by me as a new entry point. Edward Benzel was one of the reviewers, and I had said no chance of injury, and he was, very obsessive. He said that you write significantly reducing because not ready to accept. It's all right. Then it got published at various other places. So this was the problem with the plate screw described by Dr. Goel. So I went on to devise another thing, that is the VSP plate, which was similar to the one which is used in the lumbar spine. And the advantage was that you could manipulate the C1, C2 joint in the Steffi plate, because in the Steffi plate there's a variable screw placement, so you can reduce. If you open the joint, you can reduce any AAD properly by making use of this technique. Then this was published at the American Association of Neurosurgeons. And then I went on to devise this technique of, making the screws better. And finally, the concept was similar to what is described in lumbar spine. I will skip this video for want of time. So the technique was very simple, where you pass the screws as I have described, and this was the VSP plate in which you could manipulate the C1, C2 joint and reduce it. This got published, of course, in Journal of Neurosurgery, and the video is available for the youngsters who want to read this, and this implant is made by Jeon. You can write to them and they'll send you. Of course, it depends upon who wants to. They make it. And then recently there's been a resurgence in this technique, because this technique is biomechanically superior, because the divergent screws are superior to convergent or parallel screws. And this was studied in 2020 and published from China, where they evaluated. They found that this is the most rigid technique. And again, in our Indian literature, in the Dr. Goel's journal, it was published by Deepak Singh, where he studied the technique, and he has also propagated this technique of subfacetal screws. Now, cervical spinal surgery essentially was popularized by orthopedic surgeons, and therefore, most of them were non-microsurgeons, and unfortunately, we all continued following them from behind, and we let go of the opportunity to do anterior surgery, because anterior surgery requires a microscope. Most of the weight is transmitted anteriorly. So if you see that in most patients, if the mandible is going above the C2 through disc, it is possible to approach the joints from one side, and you can treat most patients from the front. No, not this one. So you see the amount of muscle dissection from behind versus muscle dissection from the front. Everybody talks about muscle injury. The most important thing of anterior surgery is that the muscle injury is negligible. There's almost no muscle injury. The fixation is along the line of weight transmission, and the quality of bone is in the front. There's no vertebral artery. The technique is, after a few dissections, the last guy sitting behind who is finished his neurosurgery can start doing it. There's a lot of bone. What has always kind of plagued doing C1, C2 surgery is the bleeding, the vertebral artery, the spinal cord, the venous plexus, the C2 root, which are not in your way at all if you do anterior surgery. I don't know why people didn't, because we just kept on following the orthopedic surgeons. Now there was a biomechanical analysis in which they proved that anterior screws are superior to any kind of fixation, And in recent literature, there has been 2020, this study which says that bilateral anterior transarticular screws are superior to odontoid screws. Obviously, the joint is fixed in the same sitting. Then over the years, you see literature is with so many papers coming up. And then my work was analyzed in an editorial by our friend Vinu Gopal. And see, there are no instruments required. This is all the instruments that are required. And these are some examples you can see. The end point is to get fusion across the joint. And it does not compromise the neck movements because the posterior tension band is completely intact. When you dissect all the muscle, put implants, and then close the muscle, then the muscles never fall back. But see this the technique through hairline incision, just like anterior cervical fusion, nothing more than that. So these are examples. You should get this at the end of 6 months. If you don't get this, that the joint has fused, then you have wasted your time and you're trying to believe that you have done a good operation. If you don't get this, then that's not a good operation. This is way back in 2013, I had described that unilateral approach can be used to fix both the atlantoaxial joints with plates. This was the first time in literature. And then subsequently, there are many people who are doing it. This is for basilar invagination. Of course, Dr. Goel was the pioneer. And then came Dr. Sarat Chandra with his DCR technique, which is not so easy for everybody. And then I described this technique where you can just push the cage from, and a wedge-shaped cage from pushed from the front will push the atlas upwards and backwards. These are examples. These were again devised by Jeon. I have no financial relationship with Jeon, but they do what I want. And these are examples. You can see long-term fusion across the joint and the reduced joint. So anterior facetal realignment. Forget all lines. The new line is the Grab-Oaks line, which decides how much, it is the tilt of the odontoid, which decides how much neurological. You can see so many patients with basilar invagination in adulthood without any symptoms. It is the tilt and angulation that you need to correct. So this is called Grab-Oaks realignment. So these are examples. You can see the odontoid can be brought down. The realignment of the odontoid is what is important. This was again published by me in 2016, anterior facetal realignment. Subsequently, Neurospine had invited an article demystifying surgery for basilar invagination. But still, there is a lot of reluctance for neurosurgeons to go from the front because they're all prodded by what they learned before. So these are the techniques, that is Goel's technique, that is Sarat Chandra, and this is my technique from the front, which is the simplest of all the techniques in most of the cases. I will not waste time on videos. This is the latest thing that I've developed, kind of spacer to fix the joint. And those who are interested can read this. And this is the new solution for patients with basilar invagination, where I've devised a plate which was again made by Jeon and is now undergoing some kind of evaluation, but I've done many cases, and you can see how the odontoid can be brought down and the joint can be refashioned and aligned by putting bone grafts inside. And this also got published, obviously. And this was a new technique which I have transferred the weight of the skull anteriorly to the spine, where there's a fibrous dysplasia. There's nothing to hold. There's no C1, C2. So the weight of the skull is transferred to the spine. And this is now more than 4 years. I've done a couple of cases. And this was published way back. A new technique of craniovertebral fixation. So the technique is very simple. I've got 1 minute. It is just an anterior cervical fusion where you dissect and go lateral. Lateral to the transverse processes, there is nothing. There is nothing lateral to the transverse processes. There is no important structure at C2-3. So if you go, these are the modified rods which are made, which are bent at two angles, pushed into backwards without any fear of anything getting injured, and then you fix them to the vertebral body in the front, and then the plates are fixed with the cross connector, so they are not going to move, and then you can see the rods are jutting behind. Turn the patient prone, and once the patient is prone, there is no need to expose the entire occipital bone. Just take 2 vertical incisions to expose the occipital, depending on the CT scan, where the skull is thickest, and then you fit these plates. So again, the posterior tension band is kept intact. No disruption of muscles from the C2 spinous process. And this is a domino connector where you can take an incision by feeling the rod. And then the rod is pushed through the muscles and realign the head. And you can get the correction of, because there is no, so these are cases where the C1, C2 have been destroyed. This is the final construct. This is pre-op. pre-op, and this is how the construct looks post-op. And this was followed up, and of course it was published. So the truth is more important than the facts, my dear friends. The facts are what you see. The truth is what really exists. Search for the truth. The task is not so much to see what no one has seen yet, but to think what nobody has thought about yet, and about which everybody has already seen. Thank you very much, my dear friends.
Thank you, Dr. Patkar, for your talk. I'd like to invite the moderator, Dr. Keki Turel, for his insights on the brain uncharted, and Dr. Sumit Sinha for his insights on the spine talks.
Thank you. So this is quite a task. A number of papers on very heterogeneous papers, none of them. So I don't even know whether the presenters are around, all of them. So am I talking only on the brain cases? That's what you said? Okay. So we started with one second. Yes, we started with the sheep and the wolf and so on. So is Dr. Lokendra Singh around? No, he's left. Okay, so he talked about three very interesting conditions: chronic subdural hematoma, subdural hygroma, and delayed venous extradural hematoma. These are the three conditions which are so-called minor problems, appearing to be minor problems. And these are complications which we see very frequently. You must have seen in the past that we have been talking about on our webinars and in our complications conferences, major complications after so-called minor surgeries, and how to anticipate them, how to prevent them. So we had Dr. Lokendra Singh talking about his technique for membrane tucking for multi-layered chronic subdural hematoma, which prevents it from getting refilled or recurrent. And he laid down some kind of predictors of recurrence, and that was one of them. For subdural hygroma, he had a unique technique of putting it happens because the ventricles suddenly collapse after evacuation of a large intraventricular lesion. And in order to keep that brain up, he suggested putting in a balloon so that the brain doesn't collapse and there's no unduly large subdural space to accommodate that subdural hygroma. So then, and he also showed a case which really went through numerous complications. And this is a problem. When you have these small little cases, especially those where we have tubes and implants inside, once a kind of a complication starts, it's like a cascade of events. And these complications just don't seem to stop. Delayed epidural hematoma from the veins. So this was also a case which he showed. Dr. Intraventricular tumors. Dr. Tripathi spoke about them. And yes, actually the ventricles are some buffer zones provided by nature, as I would put it, which helps to actually, that is why you see these intraventricular tumors assuming very large proportions before they become actually symptomatic. And when they become symptomatic sometimes, they suddenly occlude foramen Monro and produce a catastrophic herniation or even brain death. So we saw some very good approaches. See, the interhemispheric approach is an excellent approach because you really don't go to the brain. But then you have to be careful about so you must know where your midline is. And you must know what the cortical venous pattern is, which means you need to have an MRI, and which means you also need to have navigation to stay very close to the midline. Otherwise, your interhemispheric approach doesn't work. In that case, whenever you are in doubt, when there is too much of crowding of veins or you're not on the midline, it's much better to go transcortical, and you can get an equally good amount of space there. Colloid cysts are very often missed, and there's a very long controversy on when to operate, whom to operate, and whether endoscopically or microscopically, and so on. So it's too short a time to discuss all that, but must know that colloid cysts can suddenly present with acute hydrocephalus, and this can be a emergency which requires immediate attention, even if it is in the middle of the night. Yes, you have to be cautious when you are operating inside the ventricle. The veins are a problem. Veins are a problem on the top, and the veins are a problem inside the ventricular cavity. And if you sacrifice some important veins, you can have very severe central brain damage, and this can be even fatal. It's a good idea to leave a drain after intraventricular operations so that you can have whatever collection happens can be drained out. And you showed some case of a venous infarct due to a colloid cyst. Is DREZ my specialty, or Sumit, you're going to talk on DREZ? Because I have some good experience on DREZ many years ago when we were in Hanover. And we actually published a lot of literature on that because brachial plexus avulsion injuries was very common in Hanover. Professor Sami used to deal with them. And we have had a long series of DREZ lesions at that time. And I must commend you for whatever you've done, Dr. Manjul. So you have a very nice series, and so I will leave it to Sumit to talk about it if you... So shall I go ahead? Okay. So yes, skip myelotomy is a good idea. You make several small incisions on the myelon so that you don't lose your bearings with regard to your depth and the angulation of your instrumentation. So it's a good idea. What you said is to use ideal angle of approach as it changes from cervical to dorsal to lumbar. And you suggested that MR is a very good, of course, way of doing it. But we have done CT myelograms in the past, and they have also given very good information. In fact, sometimes more authentic than. So DREZ normal. So from one normal route you can go to route. But what you pointed out was using micro scissors and bipolar. Is that correct? So. And avoiding radio frequency lesion, because some people have actually recommended that for the spherical effect that it produces. Yes, but this is of course a tremendous advantage to the patients because these people are really in great misery. This pain of root avulsion syndrome is something that is unbearable. Patients can commit suicide because of this pain. And you'll be surprised that the sensory system is normal because all these injuries are preganglionic and peripheral nerves are intact. So even your nerve conduction studies may be normal. So don't get fooled by that. Ultimately, what you get a diagnosis is on history and then on your MRI or CT myelo, where you see the pseudomeningocele. Yes, orbital tumors is he around? Chagla, Adil? No. Yeah, he showed a wide variety of lesions, wide variety of approaches, and the straightforward cases of orbital tumors, CT, MRI, and everything. Unfortunately, he's not there. Otherwise, I would have asked him. A very good way of going into the orbit is endoscopic. And I think there's been no mention made of that. Maybe it's because once we get used to a certain process, he is mainly talked about lateral orbitotomy, and that is, it may be probably the best approach, and he prefers to do it behind the hairline for cosmetic reasons. But then there are many people who have done from a shorter route, from just outside the lateral orbit, and it also is not very cosmetically ugly. In some occasions, of course, orbital tumor, like if there is a rhabdomyosarcoma, then of course you have to remove the entire globe. All right. Suvendra Rai talked about some very good... Actually, I should stop over here because I have to give some time to Sumit, isn't it? Okay. So, yes, you have some very unusual and very innovative idea of going by this interface between the lesion and the tumor. And you've given some very important data with regard to the sizes of the blades and so on. So yes, your point is very well taken, that you use a very sharp dissection, but it's admirable the way you have conducted your cases, preventing all the important structures, veins included, by just very deft handling of them by your scalpel blade. Transsulcal approach, Vikrant. The most important thing you forgot to mention is that it was Yashakil who talked about it right at the beginning, Transsulcal approach. And then we were very soon to follow, almost simultaneously. We also produced a lot of data, had a lot of data by Transsulcal route. But of course, now we have more information about the white fiber tracts by the amazing work that has been done in the last few years. So it is a fact that you will be working within the projection fibers by going through the sulcus by a sharp dissection of the arachnoid. So you preserve the vessels also because they are supplying it, and you go through a relatively non-traumatic zone deep inside the tumor. So therefore you have to use not only for eloquent areas as you talked. This is supposed to be a standard of care for every operation which is intraaxial. Every brain attempt, every attempt made to go intraaxially should be done through a sulcus, irrespective. Sometimes you may have to take a little longer route, but we always prefer to go through a sulcus so that you don't damage the cortex. And the principles of microsurgery are the same. That means you go atraumatically using of course, those people who are using through the cortex or even through a sulcus, you can put in a tube retractor, which can be very useful. And I would suggest that you could try the tube retractors. They can be very good. Okay, the bell is ringing, so I should stop here, because then there comes a whole spine, gamut of spine, which includes what Dandapani talked about, the limitations of MISS and so on, and the screw fixation. So please, Sumit, thank you very much for me.
Thank you, Dr. Turrell, for sharing your insights.
So I shall be very quick, 1 minute for everyone, because Professor Mahapatra is waiting for his oration, I know that. So first thing first, I think Dr. Manjul spoke about DREZotomy. I mean, a wonderful experience of so many cases with beautiful outcomes, and one or two things I would want to, from my experience, because we have been doing DREZotomies from the time of, since I was in trauma center and did quite a few cases with good outcomes, and still doing that. First of all, the prognostic factors. I mean, one of the important prognostic factors is the quality of the pain that the patient has. So there are two types of pain in these type of injuries. One is a mechanical pain, severe wrenching type of pain, which the patient experiences and explains. And the other pain is the burning type of pain. So out of these two pains, in my experience, and it has been mentioned in the literature as well, the mechanical type of pain responds much, much better to these operative procedures. So this is in my experience as far as I am concerned. Secondly, the duration of the injury. So the longer the injury, not longer the injury, I mean, this operation is most beneficial when it is done after 2 years. But at the same time, if it is done greater than 5 years, the results then again further decline. So the best time window is 2 to 5 years. That is what the literature says, and my experience as well, because in more than 5 years, the pain receptors, they sort of, they get resistant to whatever you do. They don't respond. So anyway, but and the third thing which I want to tell to the resident sitting out here is that there are a couple of techniques in making the lesioning. I'm talking about the microsurgical techniques. So what Manjul told about is the lesioning made by the microsurgical Caesar, which is a wonderful technique. What I do is, and what I have read in the literature and what I have graduated over the years, is that I do a small suctioning also in that groove of 2 to 3 millimeters that I create. And that has maybe helped me in, to increase the pain response after the surgery. So maybe, I don't know, but there are reports in the literature regarding the suction decompression technique in the DREZotomy lesioning, and which I also incorporate in my practice. So great, Manjul. Coming to Dr. Dandapani, I don't think he's here around. Oh, yes. Oh, yeah. Please sit. A wonderful experience. I mean, I should congratulate you for taking this minimally invasive into the domain of, unthinkable injuries you did by this minimally invasive thing. My only this thing, 2 cents is, reduction, you told, is not so much of a great importance. Yes, agreed. In high-grade listhesis, you can do an in situ fusion that is very well accepted, and which is the indicated desired thing as well in high-grade listhesis for obvious reasons, because if you completely reduces the chances of neurologic injury, they are very, very high. But in certain fractures which you showed, what I would have done was reduction, especially in the burst fractures. The burst element of that vertebral body should have been inside. The idea is to push it inside the vertebral body by doing a ligamentotexis. So number one. Number two is you very rightly mentioned that yes, the minimally invasive techniques, there is a question of bony fusion. It's very difficult to do a bony fusion actually in these minimally invasive techniques. Yes, you can do an intra-body, but what about the posterolateral fusion that should augment the, this is a very, very concerning thing about minimally invasive. And the proponents of open surgeries, they always argue about this. I don't know about the long-term results of these minimally invasive techniques, but yes, I mean, this is a topic is still open for the debates. And lastly, but not the most easy thing, Professor Patkar, I don't think he's here. Oh, yes, okay. So wonderful, excellent, magnanimous, fabulous. What can I say? I mean, your technique, you have been propounding this for maybe from the times when we were residents. I mean, there is no question that, I mean, your enormous experience and all that you are doing these techniques. I only wonder this question I asked you last time when we were in Delhi as well. The quality and the, what should I say, the quality of the technique, of the surgical technique, is judged by how many of the peer surgeons are adopting this technique into their surgical practice. So for example, the Clover technique, the anterior ACDF, it was a fabulous technique. I mean, in 1965, Clover and Smith invented it, and it immediately came into recognition. And many people across the world, they are still using it after more than 70 years, 75 years. But this anterior technique, I mean, although it looks like fabulous and very easy technique, I still wonder as to why people, and especially neurosurgeons, they don't adopt it on a larger scale. I mean, I don't know the answer of this, but maybe one day I'm quite sure that people will adopt it. And my second question to you is, my personal question is that you showed a C2 body tumor, and there is a construct which is going from anteriorly to the posterior, and then posteriorly you fixed it, making it an atlanto-occipital fixation. I mean occipital cervical fixation. So how robust this implant is according to your experience, and where can we get this implant from? I mean, you mentioned Xeon, so this implant is also from Xeon, am I correct? And what about the biomechanical integrity of this implant, the stabilization that you did? Because it looked very sleek, because there is only 2 screws, 2 anchor points anteriorly, and only 1 anchor point posteriorly that you can take actually in this implant. So, I mean, would it be sufficient to hold the weight of the head in the longer run, or I mean, you are concerned about this? So, I mean, I was concerned about because it takes about 2 to 3 months and maybe longer in the osteoporotic patients. So, I mean, would it be sufficient enough for the implant to hold on till the time the bone heals? Sure, okay, right. Okay, so, yes, Dandapani, you were saying something.
Sir, I wanted to clarify, there was some kind of miscommunication. What I meant was the mid-dorsal spondylosis with intact neurology. There is not a single report of successful reduction. But there are lots of cases of dorsolumbar kind of translation injuries which are successfully reduced. So that was the miscommunication. And
Okay.
mid-dorsal, there is not
Okay. Okay, so in the interest of time, I think I should end it here, and thank you all the speakers and for their wonderful deliberations. Thank you so much.
Thank you, Dr. Sinha, for sharing your insights.
I would just request Professor B.K. Misra to come and just say a few things for the students here who are present here.
Thank you, Dr. Ghosh. This was a remarkable, is still a remarkable meeting which you organized. The planning and has been meticulous. Besides the gala dinner and the hospitality is, and the location you choose is always something which is remarkable. I always admire how you manage to do that. And I understand from you and the organizers that you have supported about 120 young neurosurgeons and students. And just a plea, when you are supported by an organization, please do come. In the morning, 8 o'clock, only the people who are at their retirement time, they were here. None of the non in capitals of young neurosurgeons were here. And that's not good. You know, they have put their time, effort, I mean, they're all busy, very busy neurosurgeons, and the money, effort, the organizations, and there is a bus waiting for you. So please don't do this. This does not reflect good on your a way of looking at it. Neurosurgery is a tough branch, and this reflects how you'll do it in the future. So don't give this wrong impression to the organizers that it was not worth their effort to support you. So my plea to young neurosurgeons, there's a lot of possibility today. India is recognized as a neurosurgery, we are very well recognized in the world today. Over a period of last 30 years, many of us have worked very hard to take neurosurgery where it is today. India is recognized very high up in the world neurosurgery calendar. And the next generation, you have to take it forward. But that is the way, see, the only one of the things which this meeting was different, was they started in time. And 20 years back, 15 years back, we would start a meeting at 8 o'clock and we started at 9 o'clock. And people used to laugh at us. You know, we used to get I've been involved in world neurosurgery for a long time, so I would invite faculty and they will be there before time and none of the audience is there. That's a very bad reflection on our society. You have to change it. And I'm sorry, I'm being very blunt, but you have to take it forward. So please don't do this again. Thank you very much.
Thank you. Thank you, Dr. Misra, for sharing your thoughts. We will now have the oration of Professor Sandeep Chatterjee. I would like to invite Dr. Anil Pandey to deliver his tribute.
India was united forever by Sankaracharya in the 7th century, that the four corners of the country were represented so that everybody participated. So when Dr. Ghosh and me thought of this idea of dandy, we thought of how to get a representation, and the representative should be a surgeon par excellence, and he should be a teacher par excellence. There are brilliant surgeons who may not be able to convey. And we settled upon Professor Sandeep Chatterjee from Eastern India because of his great skill, his command of language. He was a debater par excellence, a teacher par excellence. Of those who have heard his talks on spinal dysraphism, he was the world's best. Such a complex topic, and if you have heard his talk, it is something you have heard from the best in the world. So he was with us for a long period of time, and due to his busy schedules, probably he was not as involved with the society, but yeah, he was there all the time, and from the very inception, he was a great support and sort of formed a cohesive educational society, which this has become. Indian neurosurgery is probably at the apex, and he was one of the persons who represented pediatric neurosurgery at the very apex. So with these words, I not only remember him, but I request all of you to, for a 30-second silence, standing in silence, to respect him. Thank you so much.
Thank you, Dr. Pandey, for the wonderful tribute. We now have a brief introduction about the orator by Dr. Manjul Tripathi.
Jai Jagannath and God bless you all. This is the first message I get from Professor Mahapatra in the morning practically every day, and it's been a big honor. I'm really overwhelmed today because this honor was actually reserved for Dr. Deepak Gupta. Every time he got this honor to introduce Professor A.K. Mahapatra, and this time I borrowed his slides, some of his slides, but I am really honored to have this honor to introduce the teacher of teachers, Padma Shri Professor Ashok Kumar Mahapatra, sir. So this all started with a very humble beginning. Born in an independent India in 1952 in Puri, Jagannath. His father actually served in police forces in the British era, but his gentle nature was not in sync with the brute force of the police. So I just got it through one of your interviews. So he left his job and started doing the coconut farming, which was actually a cash crop at that time. And with this, he encouraged other farmers in his community, and this went a long way, not only in the social reform, in the economic reform, and teaching them. This is just a brief overview of his illustrious, meritorious career. He joined MBBS when the Sholay and Diwar was released and India got an emergency. That was the same 1975. And his whole life was actually linked to these three logos. The most important is All India Institute of Medical Sciences. After his MBBS, he got an opportunity at three centers, AIMS, New Delhi, PGI, Chandigarh, and in his state. And AIMS, the temple of the education, his terrace with AIMS started in that era, and he served there till 42 years. It's been a very long journey, 42 years journey. Apart from his busy clinical practice, he was bestowed with multiple administrative and executive responsibilities throughout his life. Because of his sincere, resilient, and resolute nature, he performed all those responsibilities with due honesty, responsibility. He has been director of major teaching institutions of India, including SGPGI, and then in 2018 to 2020, he practically built AIMS Bhubaneswar. Currently, he is still actively working both in the clinical administrative practice and in teaching people in the Shiksha or Anusandhan that is in Bhubaneswar. These are busy slides, and the time allotted to me is only 5 minutes. It's practically impossible for me to do justice in 5 minutes reading all this. This is just to have a look, whatever the society, executive responsibilities given by the government of India in clinical research, administration, everything, he has done it with an utmost honesty, responsibility, and those positions were actually honored by his presence. He believes in Bahujan Hitaya, Bahujan Sukhaya, and that's why, apart from developing some avant-garde research and approaches like targeted gene therapies, doTARA techniques, he principled in head injuries, pediatric neurosciences, nosocomial infections, gliomas, which actually become the bulk of the neurosurgery. He was instrumental in bringing the international trials to India for the first time, which included the evoked potential trials and the optic nerve injury trials, 17 international trials. He is still running three international trials on the pediatric neurosurgery. He just turned 60. Yes, he retired at 65, I know. He just turned 60 because his H index is 60, and which is practically a dream for the researchers in the world. These achievements can make any overzealous neurosurgeon or a researcher jealous of his achievements. He has been continuously in the top 2% top researchers throughout the world in the Stanford University list. His principal clinical interests have been pediatric neurosurgery, head injury, skull base. He has written 875 articles, and when I was a resident, I used to come in the conferences, and I was surprised the way he remembered the year, the content of the article, and he can quote it on the fingers. That's his remarkable ability to remember, recall, learn, and quote them. He is considered to be the pediatric neurosurgery of country. He is globally recognized for his contribution over here.
Again, this is a very busy slide. You can keep looking at these. These have been given by his universities, local governments, civilian awards. I can just read in 2 minutes, but the important ones are the B.C. Roy National Award, which is given to the eminent teachers of the teachers who have made a sea change in the training in India. Apart from it, UP Ratan Award, and recently he has been awarded by a very prestigious civilian award by the Government of India, Padma Shri, for which he deserves a big round of applause, which he has brought a big credit to the Neurosurgery Society. He has been the regional editor for the child nervous system. He has practically served all the major editorial boards. You can call him Mr. President because you name the society and the society has been benefited because of his presence. The Pediatric Neurosurgery Society is now 40 years old. He has been working over it for last 3 to 4 decades. He has more than 125 publications actually on pediatric neurosurgery and is still running 3 international trials over it. He works with the giants of the neurosurgery in the world. And he's a very, outside the OR and outside the department, if you meet him, you will get some beautiful moments to cherish with him. He's a very fun-loving guy. At work, he is serious. He is a strict disciplinarian. That's why you need to be disciplined, because you are dealing with the most sensitive and unforgiving organ of the body. But outside it, he is a fun person to connect with. This is one extra quality which I remember. He is very empathic towards the nature. He is very sensitive towards using the resources carefully so that you can give them to the next generation in the way you inherited from your ancestors. And that's what has been promoted in AIMS and in SUPGI. Such a long journey cannot be lived without a very compassionate, loving and understanding partner. And sir has been blessed to be married to Mrs. Suparna Mahapatra. She has been practically a Guru Mata to the whole neurosurgery department in AIMS for a very long generation. The couple has been blessed with a very meritorious scholar daughter who is currently in Frankfurt. He is primarily married to neurosurgery, rest all is his extended family. He listens to his teachers because we all stand on the shoulders of our giants. You can see here Professor Banerjee, Dr. Katoch, and you better listen to him whenever he speaks, because once he speaks, it's a wealth of knowledge and experience over there. These are some of the lighter moments which he always shares with his residents, because he has a unique ability to connect with the person who is right from the 4th class in the hospital to the President of India. And the life has come to a full circle. Recently, I was invited as an examiner for his students in his university, and he was my examiner when I was taking my MCH examination, so I am sincerely thankful to you. आज से लगभग 2500 वर्ष पूर्व तक्षशिला के आचार्य विष्णुगुप्त ने सम्राट घनानंद की सभा में घोषणा की थी कि शिक्षक कभी साधारण नहीं होता घनानंद, प्रलय और निर्माण उसकी गोद में खेला करते हैं, और अगर मेरे ज्ञान में सामर्थ्य हुई तो अपना पोषण करने योग्य सम्राटों का निर्माण मैं स्वयं कर लूँगा। इन शिक्षकों की हमारे समाज को हमेशा से ज़रूरत रही है, और मैं इन सभी चीज़ों के लिए डॉक्टर महापात्रा का हमेशा आभारी रहूँगा। Welcome a gentleman neurosurgeon, Professor A.K. Mahapatra.
Thank you, Dr. Tripathi, for the inspiring introduction. Now I would like to invite the orator, Professor A.K. Mahapatra, for his talk on current status of management of optic nerve injury.
Good morning, friends and the audience, Dr. Ghosh, Dr. Anil Pandey, and all the great neurosurgeons of India. I think it's a great pleasure to talk about Sandeep. I always believe he was like younger brother and 10 years younger to me. And I've not forgotten when he got married to one of our Chitra Sarkar students. So he's doubly that one like younger brother and married to one of our students. So it was really an emotional moment when he talked about Sandeep Chatterjee. And he was very good. I used to go to Park Clinic, talk to his father who was a pediatric surgeon. He's 97 years old or 98 years old. He's one of the greatest pediatric surgeon of India, Dr. Subir Chatterjee. So anyway, today we are talking about optic nerve injury. As I was telling Dr. Mishra, I was telling, Shraddhavan lavate jnanam. If you don't interest, you will not learn. And new education policy of 2020 say the education is quality education, innovation and research. Third pillar is holistic development and spiritual aspect. So first thing is quality education, holistic development, innovation, research and creativity and spiritual. That makes 4 pillars of education. Education is just not certificate, package and wealth. So always we say that it is a lifelong learning. If you don't learn, you have aged at age 35, because we always thought becoming a faculty in institute is end of the learning. So I will tell that we should learn, keep on learning, because when we finished MBBS, I appeared 1975, 4 December, internship 75, hardly small books. I think when I joined neurosurgery, I purchased first edition of Northfield and Human. There is no second edition. And first edition 70, and I joined in 80. So 10 years, I think second edition of Human came in 2000, I think 1983. So next slide, please. Okay. So we are talking about Sandeep Chatterjee. We heard about him, we know him. He is our beloved person of the society and a great teacher and a great orator. So I think you all know Lord Jagannath, the greatest deity of Hinduism. We always pray him because it's very important to know what we have done. So I think when you talk of optic nerve injury, it's a very, very less talk subject, because if you imagine life is the greatest gift of humanity by the God, then vision is second gift. Without vision, can you believe that suddenly somebody accident is blind? So then you realize what is the meaning of vision for a person. Otherwise, it is not possible to know. That is started, first report was Hippocrates. He said, anybody is going to lose vision, he has to have some injury in front of the forehead, just above the eye. That means he understood the eyebrow is the long axis of the orbit. So that when it is an injury over the eyebrow, it will have an axial force going through the long axis of orbit. That is what he said. But in early 17th century, they have found that it can happen in animals. Cage animals like tiger and lions, when they have kept in a small cage, they jump, they hit their forehead, and after that they found when they put food, they will not see it. So when the animal can get injury by repeated injury to the forehead. So forehead injury can lead to optic nerve injury. And it occurs in closed head injury. If you have direct open injury to orbit, there could be a globe injury and along with the optic nerve injury. But by and large, when we talk about optic nerve injury, we are talking of indirect optic nerve injury or ischemic optic neuropathy. The second name is ischemic optic neuropathy. That means it is not direct injury to the cord of the optic nerve, it is the vascular supply to the optic nerve which get jeopardized, because optic nerve has a very delicate vascular supply. It has 3 types of vessels. One is the direct of the retinal artery, central artery of retina, which pierces the optic nerve 15 millimeters behind the globes. Then if we go to optic canal, it is supplied by a chain of radial arteries, which is called plexus of arteries. And when the optic nerve is fixed to the periosteum and nerve moved, that small artery less than 0.5 mm get ruptured and get thrombosed. So the thrombosis lead to ischemic neuropathy in optic canal, which is otherwise called optic foramen. So it happens almost about 1% or more in case of closed head injury. The pathogenesis, like any head injury, any nerve injury, primary injury can be cut, avulsion, or even intertumoral or intraneural clot, contusion. They are primary injury, like brain injury. Or there could be secondary injury, which is edema, ischemia, necrosis, and atrophy. So the entire process, if a acute injury which is a clot or a avulsion or a sharp cut, he will be immediately blind. If it is a ischemic injury, which takes 24 to 48 hours, it will thrombose the vessels and the pathogenic process goes on for some time. That is how a patient gets secondary injury, because edema, ischemia, and avulsion. So what can happen? Immediate, late, unilateral, bilateral, primary secondary injury, or secondary injury. That I was telling. Then 4 types of injury described. It is just at the glove's junction. That's the anterior marginal injury, the junction of optic nerve with a glove. Then second is posterior intraglobal injury, posterior 10 millimeter or 15 millimeter behind the glove, that is part of the orbit. The total length of the optic nerve is 4 centimeter and about 25 millimeter in the orbit. So posterior part is intraorbital or intracranial or intracranial. We have all seen optic nerve in the when it comes out from the optic foramen and going to the cranium. That can also happen. I just told the shearing strain, rupture vessels, microvascular thrombosis, ischemia. These are all seen in experimental animal also. This is one of temple at Bhubaneswar. So we have a lot of cases published in the literature. Unfortunately, not many people have spoken about this from India. I started the first case on, I think, November 1983, when I saw a patient from Kerala who fell down from a DT's bus, and he was concussed, and when he regained consciousness, he was blind in one eye. He came to casualty, we admitted in neurosurgery, and I got a evoked potential done. The evoked potential was very flat. Next day his vision improved and evoked potential became normal. This was November 1983. And when I told Dr. Tondon, he said, I think it's very interesting. How did it happen? From that time, I developed interest in optic nerve injury and doing evoked potential. So there could be associated injury, PNS fracture, there could be opacity of PNS and hematoma in the orbit. So if you do X-ray, that can happen. So evoked potential is very important investigation. Whether you do a CT scan or MRI of the orbit doesn't happen, because in 1983 we didn't have MRI. We have first MRI at AIMS in 1992. So we used to do CT scan and see what has happened. Whether hematoma, clot, fracture piece, because then we thought that we should have 3 phases. This all study have done. First phase, we did not operate anybody. Second phase, we operated some and randomized about 30 patients. Some operated, some did not get operated. Then I decided not to operate, because when you do 100 cases, we found operation has not much meaning if the nerve is damaged. So if you look at the literature, we saw Japanese publication. They found that operated, these are the series for the evoked potential. So field defect, there could be a lot of field defect. Usually the nasal fibers are get caught because tumor is very thin bone. So temporal field defect is very common. So classical temporal field defect is only in 50% cases, but there could be quadrantic defect, upper nasal, upper temporal, lower temporal, or even constricted vision. So we have large number of cases where you can see the field defect. This we have all written in textbooks on neurosurgery by Ramurthy and Tondon. This is a field defect. Evoked potential normal. If they are normal evoked potential, very good. If they are diminished evoked potential, likely to improve. If there is a repeated no evoked potential, repeated, what I used to do, day 1 or day 2, day 7, day 15, day 23. So 3 weeks we do 4 cases, 4 times or 5 times. So this was factors which influence optic nerve injury. You can tell what are the factors. Complete loss or partial loss, very important. VP positive, VP negative, very important. Optic nerve fracture or not fracture, because optic nerve fracture can induce microvascular thrombosis. Ophthalmoplegia, this also matters, because whether there is complete injury or incomplete other nerves are injured. Unilateral or bilateral, they are also significant. Because if bilateral and forehead injury, the forces goes to both orbit. So I have injury in forehead in the midline. The force goes to both eyes. So X amount of force is divided by 2, half X go to each eye. But I have a supracellular just here, then entire X amount of force go to one eye and the damage more. So unilateral injury worse than bilateral injury. What are the factual switching area? Children has less improvement. Adult have better improvement. Unilateral is better than bilateral. And controversies. Most important is when is the vision involved? We used to do the evopotential in coma patient because most of our residents diagnose third nerve palsy. They never use what is called Marcus on pupil. Because if you only using one pupil dilator, they say one pupil dilator. They don't do contralateral. If you put light opposite side and contracts, that's called Marcus gone pupil. That direct pupillary recept absent, indirect is present. So if you put a light on opposite side, that will constrict. So that's very, very important. What people don't do, they will. Most of the residents will do see one eye, see other eye. This is third nerve palsy, not correct. They may have second and third nerve palsy, but most commonly they miss it in coma patient because they don't complain of visual deterioration and they put light here and light here, that's the end. So very important to understand that. Question is, should you do MRI or not MRI? We have not found any difference because it's a pathological and physiological condition and radiological condition. So radiology, I don't think it's very important. So I don't believe in doing MRI in optic nerve injury. Second thing, role of steroid. We did an international study in 91 to 95, which was done by the I think Harvard Medical School, and there was 32 centers in the world, and 150 cases are randomized over a period of 2 years. Because the randomization criteria was so strict, it should be 24 hours. The patient not on steroid, he must not diabetic, he must not have any other problems. So we could only randomize 140 cases in 32 countries and only one center from India, that's our center, and we contributed out of 140 cases. So we know that there are a lot of people do not join in multinational studies. So multinational study helps you to get your data compared with others and you get recognized for your work when you do multinational study. Lot of us done a lot of study which are international should be competitive, but because you do not collaborate with international collaborator, our study never gets recognized by other people. So my point is that if you have an opportunity, collaborate with the top people in the world so that you have a comparative data. Because whenever you send a paper, first suspicion is it correct? Is data is cooked? When we first told that we have more than 300 cases of split cord, Pang said it is not possible. He wrote split cord malformation in 10 cases. When he had published in 1991's Journal of Neurosurgery, yes, in 10 cases. By that time, we have operated 100 cases. When I saw my data, he was not believing. Then we called him to AIMS twice. One for Dr. P.N. Tandon oration, one for Cervical oration. We show him the data. He believed that is true. Because when 2005 international conference, he told me it's not correct. I emailed him all the patients which are operated in split cord malformation. So how you convince people? Don't argue with them. Just send your data, patient, photo, and MRI. So we had collected about 900 cases. Then I gave up because I left AIMS and other places very difficult. So what I did, I put down some criteria called Mahapatra's criteria. All were managed with steroid. Because we do not know steroid is helpful in spinal cord injury, brain injury, or this injury. But our international study came to a doubtful conclusion, if possible, give steroid, because even if not statistically significant, in an individual patient, we will not be able to tell it's going to help or not. So that 140 cases done in 32 centers of the world, last conclusion published in Archive of Ophthalmology says that if possible, give steroid. Now the question is oral steroid if the patient conscious, or IV steroid or methylprednisolone. They will not categorically say methylprednisolone is better than oral or intravenous dexamethasone. So if you have opportunity to get a patient like that, the patient is conscious eating food, give oral steroid, there is no problem. Then operate or not operate. Data never showed, I think 140 cases, but if you look at Japanese data, what I showed, they operated 300 cases and they operated in 3 weeks and 3 months. Results are statistically similar. One can argue, how can we operate after 3 months and get a result? we have not been able to, if we depend on the pathogenesis of microvascular ischemia, how do they improve after 3 months? That question has not been answered. So many things are still not answered. So question is that when we analyze large number, we found 90% are immediate. Immediate means within, as soon as patient regain consciousness, we found him either blind or vision is down, and 85% unilateral. So a small percent can be bilateral, where the injury is just in the midline of the forehead. Improvement occurs if its VP is repeatedly normal. If the VP is repeatedly normal, then a chance of improvement is 100%. If the VP is abnormal, then chance of improvement is 80%. If VP is absent, the chance of recovery is 0%. Repeatedly absence, because electrophysiology is not 100% correct. That is why you have to do 4 or 5 times in first 3 weeks to say he is PL negative or VP negative. These are 2 patients. Those who have, this patient who have can see the black eyes, so front injury around the lateral aspect of the orbit. Complete recovery occurs only 10%. So once a person has lost vision or has deterioration, complete recovery only 10%. Our study shows role of VEP. That is ideal. And second thing is role of CT MRI, not important in management of optic nerve injury. And decompression is still doubtful, even though we had done 130 cases of decompression out of about 970 cases. We don't know it's really useful or not. What we have gained? We gained over 3 decades that established the role of VEP. CT scan is useful, not MRI. We put out our criteria, what could be criteria, when to operate, when not to operate, establish the pathogenesis of bilateral injury. We also found causal injury. I have published 2 or 3 papers on causal injury, and we have also published 10 cases of delayed. Why should they recover if we operate after 3 months and delayed recovery? Role of optic canal decompression. We don't know, but it has helped as per the Japanese and Korean data, and our international study is silent that optic canal decompression is necessary or not necessary. Larger studies, that recommendation, larger studies is required. So what is available in the literature? Some consensus, usefulness of steroid, usefulness of VEP, and slightly indication of surgery if there is a delayed and fracture of the optic canal. That controversy nobody resolved. If you see a fractured bone piece in the optic canal, you will not have confidence to leave that like that. You will go and remove that. So large number of conservative studies where the improvement occurred between 29% and 100%, and large number of surgical series where the improvement is 37% to 100%. So you cannot choose between surgery or not surgery. This is one of the paper published in 1981 from Japan, Fukado. He said less than 70 days, 54 cases, 43% recovery. After 91 days, 39% recovery. If you do a statistical analysis, there is no significant difference whether you operate within 7 days or after 3 months. And the question I asked, what is the pathogenesis? There is no difference, you operate immediate or late. Then why should have a immediate? You should do late and give for a natural recovery. If a person can have natural recovery, why should operate? That is the reason we don't operate anybody before 4 weeks. Children have a less recovery, adults have better recovery. Unilateral injury is worse than bilateral injury, because bilateral injury means both eye have taken equal force, the force is divided to half. Unilateral injury means entire force has gone to one orbit and made somebody blind. So this is last 97 cases. I have some cases in optic canal fracture, not very common, 10% cases. Ophthalmoplegia, very short number of cases. Children, poor recovery, adults. Factor influencing outcome. Significant factor, presence of vision, partial, VP normal. Negative VP is very, very predictive of negative and negative results. The significant type of injury, optic canal fracture, X-ray finding are not significant. So age, some age pediatrics are better, but other factors, hybridin, optical fracture, X-ray finding, MRI finding, not significant. Role of steroid helpful, but we don't know dexamethasone, methylprednisolone, no advantage, megadose. Our protocol, clinical evaluation, VEP, CT scan, IV steroid, followed by oral steroid for 3 to 4 weeks. Results, 10% complete recovery, 45% partial recovery, no recovery around 40 to 45%. So usual recovery occurs within 3 weeks. If a person doesn't recover within 3 weeks, chance is about 5% that he will have improved after 3 weeks. Factor of significance, nobody with PL negative improved. That's very important. Your VEP is negative, PL is negative, and patient has not shown improvement in 3 weeks, his chance of recovery is less than 5%. You can confidently say. Operated 130 cases, indication of surgery, partial recovery and then not improving. When the patient has partial recovery from no PL, you know that optic nerve is not completely damaged, you can still go ahead and operate and give some better chance. Patient with had not delayed vision. I had a friend who was an army officer, lieutenant colonel. He was traveling to Jorhat to some other place. He hit his forehead, sitting in the front back, the brake, he hit the forehead. After 2 days, he became blind in 1988. He came to AIMS, we give steroid. He has complete recovery. He is a medical specialist, retired as a lieutenant colonel. Possible. Our approach, trans-sigmoid approach. We are initially doing transfrontal approach to operate canal decompression. Now, my student and friend, Atul what is it? Devashish Tandon and Alok Thakur, they have done trans-sigmoid endoscopic decompression of optic nerve. Now the Alok Thakur, 52 to 58% improvement. This is International Optic Nerve Trauma Study that have IONTS 91 to 94. This is the policy steroid, no improvement, no VP, no nothing. Steroid improvement, continue steroid, partial recovery or worsen, then go for surgery. AIMS study. I was in Bhubaneswar. We don't see so many cases. In some hospital where I work now, it's a university hospital with 1,700 beds, and I have seen only 6 patients in the last 2.5 years. Either they go to ophthalmologist, not refer to us, or the ophthalmologists don't read. Even though I am a member of Indian Ophthalmic Society, I have given a lot of lecture on this, still then they don't send it. So I don't know. In conclusion, I think vision is the greatest gift to humanity by God, and once we lose vision, that is a misery of life. So if somebody has lost vision after injury, we should be very careful to analyze him, study him, do the VP, and get the prognostic factor whether he merits an operation or not. Unless we sincerely, carefully, diligently look after him, he is going to be neglected. And that is why it has not been picked up in India. We have 2 million accidents in India, and roughly about 30,000 will have optic nerve injury. Where do they go? If none of us operate, none of us treat, where do they go? There are busy centers. I was asking Dwarka. We are having now 30,000 seen. We see about 30,000 head injury at trauma center. Admit about 2,000, 1,000 get to some other hospital. But when I talk to our Deepak and Deepak, they don't see it. So that is why I say what mind doesn't know, I cannot see. What Bhagavad Gita says, Shraddhavan lavate jnanam. Without interest you can learn. Next sentence says, Tadidhi pranipatena, prasena sebaya, upadesyan se jnanam, jnaninam tattvadarsan. Meaning say, you should prostrate and ask question to teacher, not to test his knowledge, but to learn. And if they are happy and kind to you, they will get jnana to you, which they have learned with experience. Tadidhi pranipatena, pariprasnena sebaya, upadesyan se jnanam, jnaninam tattvadarshana. Jnani and experience, knowledge and experience. So a teacher is much experience. Our students think they are brilliant, but teachers have experience. So a best student cannot be compared to worst teacher. Worst teacher is always better. So we say the Gurunku namani manda. Don't never think the teachers are ordinary human being. They shape your life, shape your career, make your future. Always they are respectable and they are like God like you, and you should always respect your teacher. We are here today because of Dr. Tandon, Dr. Banerjee, and great teacher. We are fortunate to be taught by our great teacher. Thank you very much.
Thank you, Professor Mahapatra, for your talk. Now we will move on to the next session on cerebral revascularization, which will be moderated by Dr. Matthew Abraham. I would like to invite Dr. Patuk Diora for his talk on carotid endarterectomy.
Good morning, everyone. Thank you, Professor Ghosh and Dr. Anil, for the talk. I'm going to talk about the carotid endarterectomy, one of the important surgical procedure for the cerebral revascularization. If you see the carotid endarterectomy, it means like carotid artery is not an end artery, but the meaning of endarterectomy means the removal of the intima of the internal carotid artery to remove the atheromatous plaque that is responsible for the stroke. If you see the history, the actual history is not very much clear, in the sense like it was in 1953 Michael DeBakey has performed the first carotid surgery. However, he published his work in 1975, and it was Denton Cooley. He performed the first carotid surgery in 1956, and he also credited with a intravascular shunt placement during the surgical procedure. So the carotid endarterectomy is being performed for the carotid stenosis, and that is one of the important reasons for the cerebral stroke, that is diagnosed mainly on the basis of clinical history along with the radiological imaging that mainly includes the ultrasonogram, MRI images, CT angio, and many a times digital subtraction angiography. The procedure involves exposure of the internal carotid artery, common carotid artery, and external carotid artery in the neck, having a complete control, opening of the artery, removal of the plaque, and again the closure of the artery. So this procedure is mainly, as I mentioned, for the carotid stenosis, and that is the narrowing of the blockage of the carotid artery because of the plaque. It leads to increase the risk of cerebrovascular stroke, and that is significant cause of morbidity and mortality. In many of the series, it is almost 30% responsible for the ischemic stroke. If we classify the stenosis, it is classified into 3: mild, moderate, and severe, depending on the stenosis percentage. And this stenosis percentage increases with the age. And this stenosis can be either a symptomatic or asymptomatic. Symptomatic stenosis, usually patient present with a TIA, stroke, or sometimes visual symptoms, while there are 2 to 6% chance of asymptomatic carotid stenosis progress with the ischemic stroke. So we all know NASCAD study has clearly mentioned about the degree of stenosis and the risk of stroke, and that increase as the percentage of stenosis increase from 19% to 33%. And there were several trials, randomized trials, that compared the medical management with the carotid surgery in both the symptomatic and asymptomatic patients. We found there was a significant benefit of a carotid surgery in compared to the best medical treatment. So the CU was superior to the medical therapy for the stroke prevention. However, the carotid artery stenting was pioneered in 1990, and as this less invasive revascularization technique evolved,
Then the pivotal trials were performed to obtain the FDA approval, and head-to-head comparison with the CE was performed. So there are various trials we know about the carotid artery stenting and carotid endarterectomy, and the overall cumulative evidence demonstrated the similar outcome between the both the intervention. Many guidelines published in the literature, but they were very vary in their recommendation in both the symptomatic and asymptomatic carotid stenosis. However, the most of these guidelines suggested that the role of a surgical procedure in a symptomatic patient and sort of a observation in many cases in an asymptomatic patient. So this was the guidelines published in 2017, and there was a class 1 level A evidence role of carotid endarterectomy whenever there is a carotid stenosis about 70 to 99%. When there is a high risk cases, there is no class 1 evidence, but there was class 2B evidence, the role of carotid stenting, same as when the stenosis around 50 to 69%. However, in case of the asymptomatic stenosis, there was a clear indication about the role of carotid surgery, again class 2AB evidence. However, over a period of time, as I mentioned about the carotid stenting procedure evolved, and there were high risk carotid endarterectomy factors, both medical and anatomical factors. In those cases, the surgical procedure was with a high risk. In these patients, carotid stenting is being performed. That is a percutaneous procedure via femoral puncture. The Berlin angioplasty is done, and then the carotid stent is placed in the neck. There is no doubt about the role of carotid endarterectomy in the symptomatic patients. However, in asymptomatic patient, nowadays there is a debate about the best treatment options, because we have now the improvement in the antiplatelets agents, lowering anti-lipid lowering agents, as well as stringent control of the glucose and the blood pressure management. And that decline the stroke risk in the patient with the asymptomatic carotid stenosis treated with the best medical treatment, and therefore limit the applicability of the prior landmark intervention trials. So, however, we are looking forward to the results of CREZ-2 trial early next year, and EC2S trial that will give an idea about the role of intervention in the asymptomatic patients. So, we all know carotid bifurcate at the level of C3 to C4. Sometimes it bifurcate very high or sometimes very low. And this is the anatomical, this picture depicts the anatomy around this region, where one has to be very careful about the anatomical orientation, mainly about this jugular veins, carotid artery and the bifurcations, and the hypoglossal nerve and the ansa cervicalis. Procedure can be performed under most of the time under general anesthesia, but many perform under local anesthesia, and usually in the supine position with the head turns slightly towards the opposite side of the stenosis with the bolster under the shoulder. So surgical steps include the vertical incision at the anterior border of the sternocleidomastoid, dissection of the venous structure, and ultimately identification of the common carotid artery and both its branches, of course saving of the hypoglossal nerve and ansa cervicalis. Control after giving the heparin, control of the arteries in a sequential manner, ECA, CCA and the ECA. And subsequently opening of the arteries, removal of the plaque, and again the closure of the artery in a watertight manner. So I'm just showing the surgical video, like how the procedure being performed. So the neck incision, one has to be very careful about, because these patients are usually on the antiplatelets medications. Usually many times patient on a double, but before the surgery we stop the clopidogrel, and patient always on the antiplatelets, that is aspirin. So once you dissect the plane, create a plane between just antibody of the sternocleidomastoid, identify the carotid sheath, and dissect the first common carotid artery, and have a control over the common carotid artery. You can see here there is a umbilical tap is being passed around the common carotid artery. Then you maybe some crossing veins required. Most of the time it's a common facial vein. And one has to be very careful about this. You can see here, you can see the hypoglossal nerve here, and one has to be very careful, otherwise we'll end up with a hypoglossal nerve injury. So this external carotid control was taken, again like the clear dissection of the internal carotid artery and passing the umbilical tap around it. So once they have a complete control of all the three vessels, we usually give a 5,000 unit of heparin, and then the arteriotomy is made. We often use a Doppler as well as the intraoperative ICG for that will guide us many times. So the first internal carotid artery clamp, then the external carotid, then the common carotid, and then the internal carotid artery clamp. And one can see there are many approaches to open the artery. Like I usually open with a 50 number knife. Many people use a Potts scissor also. So it's a gentle vertical incision over the artery and identify. One can see the plaque visually, and this is the most important thing. You have to have identify the proper plane of cleavage between the media and the intima. Actually, it's a removal of the intima of the internal common carotid internal carotid artery. And many times plaques extend into the internal external carotid artery. No, there is no need to chase that. Whatever possible it comes, you have to remove. And if you are in a proper plane, it can be easily separated from the media. Here one can see the plaque was dissected from all around. Many times the small bit of plaque that remains inside the artery that can be easily removed with the help of the micro scissors. So here the plaque dissection, and there are many times small the plaques that is adherent and placed loosely that has to be removed. Here I am just cutting the plaque that is extending into the external carotid artery, and then again like reflected downwards. Many times the small part of the plaque that remains that can be easily cut with the micro scissors again, and small plaque that was easily removed without any traction. And one has to be very flush and remove the all small the material that is lying inside the open vessel. And many times we check the flow. This was the carotid clamp was open here, and then again like the closure start with the 6-0 proline. Usually start from the distally and progressively go down. So before putting a final stitch, one has to always open open the internal carotid artery clamp and de-air the things, and then the final closure always the removal of the clamp in the same direction, like ECA first, then the common carotid, and finally there will be always some back bleeding that can be easily controlled by the pressure. And we always put a drain and check with the Doppler the flow patency, and the final this thing. So post-operative care, one has to be keeping the patient in the ICU for a close monitoring, and there are complications associated. One has to be careful about these problems associated with the surgical procedure. We had experience about the surgical carotid surgery as well as stent in our publication, and we had problems in around 2.9 patients with the carotid endarterectomy. So regarding the timing of the surgery, many people mention about within 2 weeks, but best time is within 3 to 7 days. Use of the patch, there is no clear-cut data about this thing. And however, the short-term and the long-term restenosis is comparatively less than the conventional closure. Use of a shunt, there is no significant benefit. Except the cranial nerve injuries. Coexisting of the carotid and the coronary disease, this publication has mentioned there is no significant difference, but if a patient is asymptomatic, one has to prioritize the CE then compared to the CABG. So these are some of the cases that were treated. One point I want to mention is that whenever there is a thrombus in the carotid artery, one has to avoid a stenting procedure, because if you put a stent, the patient will have a thrombus stent. And this is again like whenever there is as I mentioned again, one has to identify the thrombus and be careful while selecting the option to the patient for the patient. So in conclusion, C is a stroke preventing procedure that helps improve the patient's health and the subsequent quality of life. And the surgical treatment in the patients, the moderate to severe carotid disease, significantly decrease the stroke and improve the overall survival rate. Thank you.
Thank you, Dr. Diora, for your talk. Next, I invite Dr. B.K. Misra for his talk on vascular bypass for complex aneurysms.
Thank you.
Yeah, thank you. There's a very nice demonstration by Batuk, the carotid endarterectomy, which is, I think, one of the few surgeries which has stood the test of science and test of time. Before I go, again, I invite you to this meeting in 2026, the 9th Masin and International Conference of Cerebral Vascular Surgery in Mumbai. Please block your dates. The bypasses historically, the first probably bypass was the first saphenous bypass graft in 1953. And of course, Professor Yasser Gil, we all know that, 1967. And the first direct high flow bypass was in India done by us when I was in Sri Chitra on 15 June 1994. And fortunately, that bypass survived. And that's how our interest continued with this procedure. So this is still necessary in spite of all the advances of the endovascular surgery in some of these complex intracranial aneurysms, and this is how we define complex intracranial aneurysms. I'll give you some example. This is on my personal experience of about 49 bypasses in 49 patients where I was in Hinduja. So they presented, these are the different types of presentations. The location of the aneurysm where we did the bypass, the commonest was cavernous carotid, which the numbers have significantly reduced with the advent of the flow diverters, and they're being preferentially treated by that, and I think appropriately by the flow diverters. ECIC bypass in 46, high flow in 30, and STMs in 16, and in situ in 3 cases. I'll show you some cases where the endovascular still is not possible. This is a gentleman with Moyama disease who had the classical Moyama, also had aneurysm, presented with subarachnoid hemorrhage from a P1, P2 aneurysm. So we clipped that, and the same sitting we did a STMC anastomosis, again something which still cannot be managed by endovascular means. This is a gentleman with progressive visual loss on the left side. He was almost blind functionally blind on the left eye. He had this heavily thrombosed giant aneurysm of the proximal ICA along with an AVM, which was incidental finding. So we trapped the ICA and put an STMC anastomosis, and we are just following it up. He remains asymptomatic other than the blindness, which of course did not improve. This is a lady who was referred to me, this probably 20 years back now, when I was in Hinduja on this CT scan as a sphenoiding meningioma. Of course, it was not. It was a giant cavernous carotid high flow aneurysm, and this is where we used to, most of the time, you do a balloon occlusion test, and this was done. Critical thing is not the cross circulation in the arterial phase. See the capillary phase and the venous delay. The capillary delay is the critical thing. So even if the patient is not symptomatic with a balloon occlusion that time, the capillary delay would suggest they are at risk of having an ischemic insult even in the later time. So it's better to do a high flow bypass when you're doing the occlusion of the carotid. So this was done as a radial artery bypass graft. In my practice, first 5 cases, 2 cases were done in Sri Chitra and the rest were all in Hinduja. First 5 were saphenous vein, and then I switched to radial artery, and all of them were radial artery. So this was a high flow radial artery bypass graft. This is a gentleman with all his vessels disease, pan-dolichocephalic I would call it. The right side, the left side, the vertebrovascular circulation, everything was dolichocephalic. Patient presented to us with progressive visual compromise, worsening of mainly the right eye, and we were not sure how best to manage it. You see, this is the angiogram, but you see the MRI, there's a significant mass effect because of thrombus and calcium there. We waited about a year till he almost forced us to do something, which we again did the same thing, high flow radial artery bypass graft. We ligated the carotid in the neck. I think we bought him some time. He's lost to follow. He might be dead for some other thing by now. Now, this is a gentleman from Kerala who had presented to another unit in Kerala with acute coma, had a decompressive craniectomy from acute subdural hematoma, survived and was sent to us for definitive management. His right ICA was completely diseased, blown out. This had burst and produced the subdural hematoma. The time he came to us, he also had an unruptured basilar top. He was almost normal. So we advised surgery, bypass. He ran away, not unusual in our practice. To come back after a year to progressive hemiparesis and significant headache. So where we did a bypass, this is the largest aneurysm in my practice, about 8 centimeter, and the radial artery graft was not enough for the bypass. So we had to open the aneurysm in the middle fossa, decompressed it, and did the high flow bypass graft and trapped the artery. And then send the patient for endovascular treatment, which failed because the PCA could not be separated. This was again about 15 years back, could not be separated, and so they sent back the patient to us. I'll skip the video. So we did in the second stage, we did the clipping of the basilar top. And he continues to follow up with me, and he continues to remain asymptomatic without any neurologic deficit. This is a doctor who had some transient severe headache while weightlifting in the gym. A young doctor from Mumbai, and he came to us. When he came to us, he was asymptomatic, but the imaging shows this aneurysm, and this was aneurysm close to the sphenoid sinus. Again, there's a lot of discussion whether to offer any treatment, not to do anything, because they're very proximal, so there's no question of subarachnoid hemorrhage. So we had he took multiple opinions. We discussed in many meetings, and actually Dr. Spexler advised that he should be operated. He said as it grows, it may rupture into the sphenoid sinus and it can bleed to death. So we finally did a high flow bypass, and that was in 2008. And he's abroad now, so every year once he comes in. So last he followed me up with 23. So this is the angiogram which I have in my computer. This is how many years? 13 years. So the angiogram, the patency of the radial artery graft can be very, very long, and we have now 15 years follow-up on this patient with a patent radial artery bypass. And the similar, another patient, again, very proximal ICA aneurysm is a 10-year follow-up, patent radial artery bypass graft. So radial artery graft, once it takes up, it stays for good. Now, this is a gentleman who had this heavily thrombosed aneurysm of the ICA, distal ICA, which had bled. You see there is some calcium there, there's bleed, there's heavily thrombosed, there's very small circulating component. And so we operated microsurgically, and there was a temporary clapping time for a long time, which we didn't realize that was problem, because we didn't give any heparin that time. And when we did the ICG, you saw that when we did the ICG, there was a clot inside. So we opened up the artery before we came out. We put a pursing suture on the artery, and then you put a nick there, and to back bleed, that clot was removed by the back bleed. And once that temporary clip was removed, the back bleed was there. I think we'll see that bleed a little bit. We have the pursing suture there, so I'm not concerned about the worry. So I open the temporary clip. There is a temporary occlusion in the carotid in the neck, and then we of course stitched it back. And then we see the IC, so that's a good circulation there. So be careful when your temporary occlusion time is long. There is a risk of this vessel getting occluded during your procedure. This is a lady who presented to our neurophysician with a stroke. I don't have the other pictures here, but she presented with the left side, very distal. This is a M4 artery stroke, and she presented with dysphasia. And fortunately, this was investigated further, and they found there is a small aneurysm there, which the artery was thrombosed. There is a clot there, M4. So we have left one artery. We have temporary clips on the proximal and distal to maintain some circulation in that. We opened up, that clot was removed, and then once we removed that clot, you can see the back bleed there. And then once we see that there is some bleed there, now we put a temporary clip on the other artery, and then we occluded, we closed that artery with the patency by 10O sutures, and over a period of time. This was interesting. This patient presented to me, this was about 13 years back, presented to me last year with a head injury and remains intact, otherwise his speech is normal. So you have problems. So this is a lady, we had this 62-year-old lady with painful ophthalmoplegia on the right side. We did a high flow bypass graft, and those times we used to take down, we didn't have the ICG, I think it's more than 15 years now. We used to take down for doing an angiogram to check the patency before we would occlude or balloon occlude the internal carotid artery. The bypass was preferentially feeling. That's a good sign that the bypass is good, in spite of the fact that internal carotid is not blocked. So that's a good sign. So we're very happy. We occluded the carotid. Unfortunately, over the next 3 days, she deteriorated, developed a hemiparesis. We took down the patient, and we found in the angiogram the graft was not patent. She subsequently deteriorated. We had to do a decompressive craniotomy. She survived, but during the decompressive craniotomy, we found that the artery is pulsating, the radial artery, which is very, very unusual, actually never been described in the literature. The radial artery goes, it comes back. This is the CT angio before discharge. So probably we could have done something to open up that artery. Our endovascular colleagues, of course, were appropriately, they were kind of concerned that it's a fresh bypass, so they didn't want to do anything with the risk of rupture. So currently the proximal carotid arteries are mostly flow diverters, but it's not always without problem. Now this is a patient who had multiple flow diverter, came with some visual compromise, went back. It's another center with hemiplegia and bed bound. So this is a more recent patient. This is a 62-year-old male who had been treated in 2019 in another center because of a compromised vision on one side because of this aneurysm. And what happened? The flow diverter, the vision on the right side went down, and then he started reducing the vision on the left eye. So they put another flow diverter, and then after a few months, he became blind. 2020. He presented to us 2022, referred by another endovascular colleague because nothing could be done anymore. The aneurysm is growing, this big thrombus there, and it's a big mass effect, but he started now having epistaxis, where a very small circulating component, where we almost do a semi-emergency. I think I don't have time to show this video, I'll just skip it. But we did a high flow bypass graft, and this was in Journal Neurosurgery. This is another patient which again traumatic pseudoaneurysm. I sent to my colleague. Patient presented with hemiparesis, blind on the right eye, and altered sensorium. We thought endovascular would be the best way to go. The aneurysm was very proximal. They couldn't do it because there was a fracture segment in the aneurysm itself. There is a bone fracture fragment there, and Dr. Karapurkar, who actually the endovascular colleague whom I had referred, said that the artery will give way if I put the flow diverter. So he sent back this patient to me to do a bypass. This is essential steps. Again, I think many people are doing it. So this is another example where the endovascular inspired. This is more recent patient. This is in Neurology India, has been published there. So this is our results over the period of years. We had 2 patients who had died. One was from sepsis and one from infarct, and the 2 had morbidity. So 2 points to ponder for the young neurosurgeons there is a flawed STMC trial killed ECIC bypass. Generation of neurosurgeons never learned it. Fortunately, I trained just before this article was published in New England Journal of Medicine. I finished my training in 1983, so I had already trained that. But because of that, many young neurosurgeons never trained in STMC. A flawed ISAT, to my mind, young neurosurgeon will not clip hundreds of patients with suboptimal treatment and false sense of security, especially in our country where there is no audit, no follow-up, will continue to have this risk of having an aneurysm which will bleed. And you saw that very nice presentation by Batuk. And I think in spite of one study, just give me 50 seconds, one study that ISAT changed complete paradigm of the aneurysm treatment all over the world. And we have multiple studies showing CEA is carotid endarterectomy better than carotid artery stenting and is better than medical management. We still continue to have multiple trials. Why? Because industry driven. They want to show that it is not inferior. I think this is not the appropriate way to go for medicine. So final slide, cerebral bypass is a proven thing. It's a low risk, excellent results. It's a promising, there are endovascular and robot assisted will probably take over, but till that time you have the facility, go back and train in the lab to do this procedure. Thank you very much for your attention.
Thank you, Dr. Misra, for your talk. For the last talk of the session, I would like to invite Dr. Dwarakanath Srinivas for his talk on ECA-MCA bypass for Moya-Moya disease and its outcome.
Thank you, sir. That was a wonderful talk. And so what I'll do is I'll speak on low flow bypasses, context to Moya-Moya and any other pathologies. So moya, we know all this. We know the theory quite well. Progressive stenosis of the terminal ICS, more common in females, but can present with either with ischemic symptoms or with hemorrhagic symptoms. One interesting finding is it gets precipitated in children with exertion or hyperventilation. So generally, if a child with moya cries, he might have an attack. So again, you have to differentiate between disease and syndrome. A syndrome is basically with an underlying etiology, either radiation or sickle cell, etc. Clinical presentation, 3.2 ischemic stroke per year, symptomatic around 10 to 13% ischemic strokes per year. Again, we have the Suzuki grading. I'll not go into the details because it's quite well known now. So coming to the treatment, what types of treatment do we have? We have the indirect revascularization, multiple forms, and direct revascularization. So what are the, can I have a pointer? So what are the indirect vascularization? You have the myosyngangiosis, the dural synangiosis, the duroangiosynangiosis, and duroangiomyosynangiosis. So basically, it means here you are revascularizing only with the muscle, with the dura and the artery with the dura overlying it, and with all the three over here. Apart from that, there has been the omental transposition. You need a venous and an arterial bypass for that. And multiple cranial burr-holes have also been used historically, and still it's continuing to be used, and it's quite effective. The main disadvantage of indirect revascularization is the slow revascularization. If the patient has presented with multiple episodes of acute stroke, then probably a delayed revascularization might not benefit the patient much because he is still at the risk of perioperative strokes. So this is where direct revascularization come. Again, we know the history. Yassar was the first to do it in 72. There have been multiple variants. So I'll just go, there have been two main variants. One is the single barrel versus the double barrel. The double barrel is when you use both the branches of the STA and connect it to the multiple M3 trunks, M4 trunks, M4 branches. The difference is not much, except that the double barrel stroke is used if there's an extensive vascular territory to be revascularized immediately, but otherwise a single barrel bypass is generally quite effective in moya. So what are the investigations? One is the first line evaluation of CT stroke, CT MRI, DSA. We do SPECT or PET with acetazolamide challenge and MR perfusion. Basically, one is to select the site and other is to predict the outcomes. So when do we do it? We generally do it prior to development of cerebral infarction. Avoiding the acute period, we give aspirin, a preoperative neuropsych and the entire thing. What we do is avoid hyperventilation, use volume expansion, and use slight hypothermia during surgery. I don't use heparin. So the procedure is standard. We use a linear incision after marking preoperatively the STA and see which is the more prominent branch, and then open the incision accordingly. So I'll just show you a short video. So this is the superficial dissection in which we are dissecting out the STA. If you can see the STA, it's over here. So once the STA is dissected, you need to go below it, go in the subfacial plane, take out the muzzle, expose the bone, and this is how it looks. You can see the STA along with the two branches. Then I do 3 burr holes. And then use a high-speed craniotome to do the craniotomy. You have to be very careful about not avulsing the MCA which you have carefully dissected, otherwise your entire surgery is going to go waste. This is the craniotomy, and then this is the dural opening, which you're going to do the dural opening. Dural opening, again, preserve as much the branches as possible. Then you select which of the branches are good for the bypass. So here we have identified this cortical M4 segment as the recipient. So then we are preparing the donor site. Then you have the incision. You make you fishtail it, and you make sure that the opening is wide enough. Generally, thumb rule is that the opening has to be 1.5 times the diameter of the vessel in which you are going to anastomose. So here we have done the fishtailing. And then I'm going to dilate it with heparinized saline so that it doesn't go into spasm. And now we are going to prepare the graft site completely. So the graft site, you basically select a graft which has a nice diameter as well as has the minimum number of branches. So once the graft site is, then you put the 2 temporary clips. So then what I do is I generally take a small 10 or I use either a 11 suture or a 10 suture to take a bite on the vessel wall, then lift it up, and then use a micro scissors to do the opening. I found this more useful rather than using a diamond knife, so I have switched over to this method of opening the vessel wall. Generally, like I said, the diameter is around 1.5 times the diameter of the vessel wall. This is the opening now. I had forgotten to put the rubber dam, so I'm putting it now. Basically, to give a good contrast to the blue color of the suture material which is being used. This is the methylene blue. And then you go according to procedure. So you have basically a toe stitch, you have the heel stitch, and then you have the sides. So first to go is the heel stitch, because once you start suturing the others, it gets hidden. So this is the stitch which you have to do it the first. You do the heel stitch. So I prefer nowadays to use 11-0, but the problem with 11-0 is, one, it's not available, and the second thing, it's quite expensive. It's almost 6,000 to 8,000 per suture pack. So you need at least 3, so it almost comes from to around 20,000. 10-0 is available at our hospital, so it goes for free of cost to the patient. But if the patient is affordable, we get 11-0 and do it. Otherwise, we use 10-0, 3-3-1-3, 10-0 proline. So after you do the heel stitch, then you go into the toe stitch. So this is the toe stitch being done. Then you have the option, because usually the distal side is done. Again, this is because the graft is going to hide your distal side. So you do the distal side anastomosis and you do the easiest side the last. So you would have noticed that for the resident especially, that you do the suturing at a high magnification and you do the suture tying at a low magnification. So you're passing the suture at a high magnification and then you're de-zooming it and doing it at a lower zoom. So then you do the suturing of the distal side. So generally, I used to do the single intractor sutures, but after working with Professor Laligam Shekhar, we switched over to the horse figure of 8 sutures. So figure of 8 takes 2 continuous sutures and then suturing them so that it goes out in the figure of 8. In my hands, that the suturing time, the bypass time has come down to around 25 minutes with this method. So even though we have the same number of bites, the number of ties is less. So then we do the distal side first. Once the distal side is done, so these are this is the distal side. I'll just, for want of time, I'll just quickly run through it. Then we turn over. You can see the vessel walls now, and I'll just go and show you the last tie. You can see the vessel walls beautifully. This is the graft. This is the vessel wall, and so I'll quickly run through it. So this is how it looks finally, and this is how it looks finally. There might be a little leak, but usually it stops even without much of hemostats. Then you remove the clips. This is how it looks after the anastomosis is complete. And then we do the ICG to check the patency. You can see the flow coming, and this is the end of the anastomosis. So this is the end of the anastomosis. So you could do EDAMS, which actually gives you good revascularization. You could do the STA-MCA bypass, which gives almost immediate revascularization, very good. STA-MCA bypass also has good results. For example, this is the aneurysm, thrombosed aneurysm of one of the MCA trunks of the superior trunk, in which we blocked it and did an STA-MCA bypass to the superior trunk, while the inferior trunk was continued to be filled by the ICA. Again, you could do an MCA here. You could do a rescue bypass. For example, in this patient, aneurysm, we found that the clip was slipping towards the ICA, so we did a protective bypass and low flow bypass and clipped the aneurysm. So this is a protective bypass. I will not go through high flow bypass because sir has already spoken to it about in detail. But some of the cases we have done, this is a high flow bypass for a giant MCA aneurysm. This is for a giant ICA cavernous aneurysm. These are for complex aneurysms in which we have done bilateral. This is a bilateral cavernous calcified aneurysm with bilateral vision loss. Again, high flow bypass, unruptured giant ICA with blindness, high flow bypass, serpentine aneurysms, high flow bypass. Another rarely used, just 2 minutes, I'll just finish it. You could use an intermediate bypass in which you could implant one MCA trunk on the other MCA trunk if you are unable to, if you have not saved the STA while harvesting it. So complications, there's one complication which I'd like to mention, is the hyperperfusion injuries which can occur after after low flow bypass. The treatment is just hydrate the patient and give minocycline, and the patient usually comes out of the hyperperfusion syndrome. Regarding evolution literature, there is not much differences between long-term outcomes of bypass and non-bypass, indirect revascularization, but the immediate stroke rates are much less with direct bypass. So what would I do? I prefer to do a combined, that is a direct bypass whenever possible. The whole determinant, we go with the plan of a bypass. If the recipient vessel or if the donor vessel is not good, then we convert it into EDAMS and come out. So I'll end here. Thank you.
Thank you, Dr. Srinivas, for your talk. Now I invite the moderator, Dr. Matthew Abraham, to share his insights.
I think we had a great session here. Professor Mishra is around? He has left. Okay. I think we had a wonderful session. And this is one point where the neurosurgeon can be proud that he has an edge over the interventionist. And some role for anastomos will always remain, since it is going to be a very difficult task to do it by intervention. Now, the first talk by Dr. Batuk. Batuk, we know, does both intervention and can operates also difficult cases. And so when he talks about the endarterectomy, certainly he's speaking from his soul. Now I have a, Batuk is around? Yeah. I have a question. How often do you get a marginal mandibular palsy? Carotid endarterectomy involves prolonged retraction of the uppermost.
Yeah.
How often do you get a marginal mandibular from facial?
I have not seen.
You do not get?
No.
Okay. So, stent, do you think a stent will be useful in some circumstances?
See, when I presented my work, I have selected those high-risk patients when I know whenever there is a bifurcation is higher up, and it will be difficult for me to reach the upper end of the stenosis. So that's why I divided them into two groups. One group was classical routine risk for a carotid surgery, and one group was having a high risk for a carotid surgery. And those selected patients I gone for the carotid stenting procedures. So when I think like it's a higher bifurcation or the short neck and will be difficult for me to reach to the, I select for the, I go for the carotid stenting procedure.
Okay. Now, awake. How often do you do an awake?
No, I don't do awake.
Do you think
I
there is an
always do
advantage
under
with awake?
general anesthesia.
There are many leading surgeons, many leading centers who always do a endarterectomy under awake. They feel that it is safer, and you may get a patient, you can escape from some surprises if you consistently do awake.
Yeah, many a times compliance of the patient is very important, because any untoward events during the surgical procedure can be very difficult for surgeon to manage like.
Okay.
So the patient's compliance is very important, but I have not done any procedure under local anesthesia.
Okay.
Yeah, many people are doing under local anesthesia. Yeah.
Finally, one existential question. Do you think it is the vascular surgeon who is more ideally suited to do a carotid endarterectomy, or is the neurosurgeon?
So that is a problem. Actually, neurosurgeons are not interested in this sort of a relatively easy surgery. Because as a neurosurgeon, we are doing a most complex surgery. This is not a difficult surgery. So it's all about the training and learning about this thing.
Thank you. That is very good, actually. Very encouraging for the younger neurosurgeons. Regarding the bypass, Dr. Misra Professor Misra, I think, has left. It is a great demonstration. It showed that you can quickly transform from the routine conventional method into a salvage mode. The one pertinent question is, what is your threshold to? What is someone's threshold to change over to a bypass when you're tackling a large and difficult aneurysm? And whether all decisions are made pre-operative or whether an intraoperative decision is done. Now, my take overall is that whenever a large aneurysm is taken up, it may be, the surgeon may be mentally prepared to go ahead with a high volume bypass. And maybe it may be good to harvest, or at least initiate the process of harvesting a radial artery when you're going for a difficult, thick-walled, deformed aneurysm. Any comments on that? Please.
So we have done almost some 54 high-flow bypasses for aneurysms. The threshold actually is less. So if I feel that the anatomy is going to be unfavorable intraop, so what we do is we just drape the radial and keep it ready, keep everything ready. Also keep the STA safe, because one of the most thing is when you're doing the terional, the STA gets injured. So specifically instruct the residents to keep harvest the STA and keep it. It can be kept in the skin flap itself. We can always harvest it, not like a moya harvest. We can always harvest it in a different way. We can go subcuticular and harvest it also, even if it is cut distally. So that is not an issue, but the stem should not be cut. So that is what is important. So if we feel that we can get away with the low flow bypass, then I do the low flow bypass first and then go about dissecting the aneurysm. It's only in a high flow bypass that actually we dissect the aneurysm and see whether it's clippable, and then if not, we do the high flow bypass.
Do you have any experience of anastomosing across two vessels with a small piece?
No.
Intracranial?
No. I haven't done that. So either it's have been reimplantations of one MCA onto the other MCA, or low flow or a high flow bypass.
This regarding moya anastomosis, do you think a surgeon who is doing at a frequency of something like 3 to 4 a year should practice in a lab? Your fluid movements and your success at the anastomosis looks, you have made it look very simple. Or do you think somebody who is doing a lesser number, maybe once in 3 months, should practice in a frequency of maybe once in 2 weeks?
Frankly, Matthew, everybody should practice in a lab. I practice in the lab.
How often do you practice? How often do you practice?
Now not much, because we do it on patients almost every week. So there is at least one bypass a week for us. But generally, I mean, we encourage our residents to do the practice animal models or even glove pieces and do it. In fact, there's a very nice article from Seattle from Dr. Shekhar on a homemade bypass kit. So I think if any of the residents are interested, they can just Google it by Shekhar and Ellen Bogan. And it's a very nice way of setting up anastomosis table at your house itself.
Yeah, I have asked Dr. Shekhar this question. I have assisted him long back. He says he does it on a weekly basis, and he has a system at home. When he gets free time, he does it. Now, my question is, at what is the younger stage when you will choose for anastomosis for a moya moya?
The youngest patient we have done is around 3 to 4 years. But on an average, if you ask me, anybody above 5 years is suitable for a bypass. For people who are above 5 years, the only reason why we don't do is if on table we find out the
technical difficulty. Now, suppose you are finding very small vessels. It's a small child. Would you take the risk of doing it on an M2? Or would you take the small risk of a stroke in the intermittent period?
For moya moya?
For moya moya.
Like I said, the long-term results in literature
It's not different.
There's no difference. There's no difference. Absolutely no difference. The perioperative stroke rates in direct bypasses are less than indirect vascularization. Apart from that, there is no other difference in the long-term outcomes.
Okay, so choosing an M2 for a moya moya may not be a great idea. As I also share that opinion.
And the other thing which I would like to mention, if the patient has multiple or extensive infarcts and you want to do a revascularization procedure, it's preferable to do an indirect revascularization than do a bypass in these patients.
My suggestion for the younger people around here would be to advance to the next level where you can do bypasses inside the cranium across 2 divisions of the MCA or maybe across 2 A2s. It is at that level that you will have a clear edge over anybody else, any other specialist. Probably it will be an effort of years, and maybe people like us may be already too old to start such an effort. It may be good if we can start at a young age. Thank you very much.
Thank you, Dr. Abraham, for your insights. Before we head off for a 10-minute tea break, we will have the prize distribution for the poster and flash presentation.
Dr. Kuntal is here? Kuntal? Okay. Can I ask Dr. Atul Goel to come here? Sir, these are the names. You are the poster. I have not brought my glasses, you know. The winners of the poster presentations, the first presentation goes to Dr. Sagar Mago. Is he here? The second to Dr. Achinta A. Not here. Please come. Hey, Pranab, guys. And the third prize to Dr. Mahesh M. Can I call Dr. Andre, please? Ranjita. And? Okay. For the microvascular anastomosis, the prizes goes to Dr. Ranjita. Dr. Mukund Vora. Not available? Is not available. So we'll have a 10 minutes tea break and we'll come back because everybody has to catch the flight. So please come back with exactly after 10 minutes.
फॉरवर्ड के लिए बैकवर्ड के लिए पॉइंट करना है कुछ
पर वो पॉइंटर भी रहेगा ना
यस
अगर वीडियो चलाना है देन आई जस्ट ब्रिंग इट हियर एंड क्लिक ओके
सजेस्ट कि आप ये पॉइंटर यूज़ करो तो क्या है कि जो ऑनलाइन देख रहे हैं उनको भी समझ में आए कि कहाँ पे आप पॉइंट आउट करना है
ओके ठीक है जो बस हमको खाली ये और ये वाला में पॉइंटर
Hello. Okay. Welcome back. We will now start off with the last two sessions on CV junction and subaxial cervical spine and spine unbound. I would like to invite Dr. Rajendra Prasad for his talk on SI joint and lumbar facet pain as major cause of back pain after spine instrumentation, with emphasis on diagnosis and management.
Thank you, Dr. Ghosh, Dr. Pandey. We've had such a wonderful 3 days. And after all that talk on these complex brain surgeries, I want to bring you to the mundane of chronic back pain. And like Professor Mishra and other seniors here, I've been doing this for 40 years, but only in the last 20 years did I actually examine patients by touching their spine. And that's when in the last 20 years I realized that without touching the patient, you cannot pick up sacroiliac pain. You cannot do that. So today, summary, we'll talk about lumbar facet and SI following lumbar surgery only. And I'll talk about my 400 patients. And how do you diagnose sacroiliac and facet pain? Because the patient has had surgery and he'll point to his back and you still have to figure out. And then what does the literature say? And so SI pain was really well described in the early 20th century. And then when Mixter and Barr, they brought attention to degenerative disc disease. It wasn't, even then it was still there, SI joint. But then MRI came along and everything moved to disc. And then fusion came along and then there were more screws and there was more SI pain, but we were not diagnosing it. And even now, back pain underdiagnosed. Like if you Google, if you do ChatGPT and ask what is the commonest cause of back pain, they'll say 50% is coming from facet and SI. And yet our treatment is not 50%. So we are treating the remaining 50%, but not treating the 50%. And so if you end up with screws like this, and you've heard of adjacent segment degeneration, obviously it will affect the facet joint, and obviously it will affect the distal. So if you see this image here, is that on the right, distal adjacent segment has already started. This is in the canal, but in the facet and the SI, it will already get affected. And if you look at the average incidence of sacroiliac, it's called dysfunction. It's not sacroiliitis, it's sacroiliac dysfunction. It happens in up to 6 to 75%, as the literature says. It's us who miss that out. Now, how do you diagnose it? The finger pointing test I found that is. So it's the posterior inferior iliac spine, but it can go down a little more. So, and then you call the patient's family and say, Dekho, he's not pointing at his spine where we operated, but he's pointing to the sides. And the Patrick test, which is so easy to do, is the Faber, flexion, abduction, external rotation. So just these two tests, I found enough. And unlike all the other stuff we've heard, the X-ray will be normal, most cases. The CT will be normal, MRI will be normal, isotope. All these may be normal and is in most cases. So how do you make a 100% diagnosis? Now, after having done it for 20 years, it's all in the history. So he'll say, I've had lumbar surgery. I say, oh, I know, it's SI joint. Or they're obese, they have osteoarthritis of the knees, and they walk badly, and it affects the SI joint. Bad posture affects the SI joint. So this pain is continuous on weight bearing. And then when you say, which is the worst time, they said, the nights are the worst. Because when they are turning in bed, so this 4 millimeter joint is when it gets twisted. And of course, so when I started with artificial disc replacement 20 years ago, one of the first to start in the country, one of the first. And then it was easy to do discography. So we did discography and said, disc replacement. What I found that sacroiliac joint, like you see over there, it's rarely abnormal. And this one is TB of the SI joint, so it's there. The other is, you've done surgery. 1 month later, he comes with sciatica, and you say, oh shit, he's had a recurrent disc. But many a time it won't be a recurrent disc, and you'll say, oh, thank God. But then you have to give him a solution, because if he has narrow foramen, which many of them have, you have to save the patient recurrent surgery for foramenotomy. When his pain is coming from the SI joint, you'll have one more failed surgery. So I went through this phase between 2007 and 16, when I really didn't know what to do with back pain. So it's either we were doing artificial disc replacement, or in that 250 series, I said, let me look back. Some were disc replacement, some were dynamic stabilizations, as you can see, Coflex. Some were being fused. And then gradually I was realizing that facet and SI. So if you are overweight and you have knee pain, it's just as likely or more likely that your facets have not taken your weight or the SI joint has not. So gradually, having done all of that, I'm really surprised, and I wonder with later Sumit can also tell me, why am I not found a case of disc replacement in the last 10 years? It's because I've found SI joint and that. Now, what can you do? Lots of medicine you can do. You can do physiotherapy. And we all say chiropractor is a bad thing for most neck things. But for SI joint, if you've fallen and you've had an injury and your SI joint has just moved slightly, a chiropractor, a good chiropractor can put it back. The other is you say belt pehno, but it's not any lumbar belt. SI belt is a low belt, it's a narrow belt, and it has to be worn tightly around the SI joint. A lumbar high belt is not going to work. And if the guy wears it at night, he's not going to have pain when he turns. So what about intervention? So if you've done all that, so when they come to me, they've done all of that. They've done physio, they've done medicine. So then you do a block. But just remember, and I found, for me, lumbar facet tenderness is the single most lumbar facet and SI, that's finger pointing. But remember that the nerve, the facet joint of L5 will get its nerve supply also from L4, median branch of L4 and L3 in some cases. So even if you find it's SI joint, you still have SI joint also gets lumbar nerve, L5 median branch. After that, this figure on the right is radio frequency. So the people will ask, how long will the block last? The block won't last long. If you go to a dentist and ask for a block, the pain is not, your dental pain is not going to last forever. So it's going to last for a little while. You add steroids, the facet block will last a bit longer. In SI joint, it may last for 3 weeks, and then you have to repeat it. So that's where radio frequency rhizotomy has come in, which in my own thing, I've seen it lasts up to 2 years, and you repeat it. But people who have repeated problems, then you need to put SI screws. Now, so in the last 400 odd cases, and how do you know that it's worked? And then you move to RF. So normally there's an interval. I do the injection, and then as you go back, tell me when it's better. Then I'll do radio frequency. But can you put the volume up? Can you put the volume? I feel like running a Tanzanian pain. Are you in pain? No. Okay. Are you getting all that? Turn now. Turn. Were you able to do this before? No. I was not able to use my. So here's a lady who came on a wheelchair, not able. Go ahead, Mama. If you're not sure, we can wait for 10 days. So shall we go ahead with radio frequency? Do you have 10 days? She said, no, I'm so sure that my pain is better. So let's go back. So then I looked at these 400 cases. Where did they come from? 104 of them were post-op. They all had surgery. So I said, let me look at what kind of surgery. So in lumbar surgery, most of these, 50% had fusion. But even after microdiscectomy, you can get SI pain. And after laminectomy. So half of them were fusions, other half, I thought every case will be fusion. That's not the case. Then the level of fusion. The literature says the more level you fuse, the more chances of sacroiliac pain. That wasn't the case in mine. Most of them were 2 levels. Then, okay, you've done your fusion, and if you have adjacent, how long will it take for the pain to come? Well, if you have missed it on the first time, then this less than 1 year, that was there all along and you missed it. But I've had cases even after 15 years of lumbar surgery that they said, you know, this has been going on for a while. So don't worry, you've done your good surgery, micro disc, whatever, but remember, when they come back, don't show them an X-ray and say, "Maine to sab screw theek kar diya. I've put the screws, everything is fine." But what next? And immediately, this is MODI, Auspice Tree Disability Index score. Immediately, everything goes away. Now, just a couple of examples. Like this patient came from somewhere else, had dynamic stabilization. Still patient had pain. And so we had to remove all of these screws, and all she needed was twice she's had radiofrequency rhizotomy for facet pain, which didn't go away. Now, this is my star patient since 2009, 130 kilo guy. So I put a discography. The dye went into the L4 vertebra. So because he was 130 kilos, I did anterior posterior fusion. But look at the figures. Every year he was coming back with SI pain. SI block got better. RF got better for a year. Now the last time he's been okay for 1 year. So there's a lot of literature you can find in pain medicine of SI pain. Lots of literature after fusion. Lots of literature after simple discectomy. You can get that pain. So now we need to ask ourselves, last 1 minute, do we really need to put screws? Now a lot of orthopedic surgeons now screws. A simple discectomy, put in screws. It's not required. Look at this guy. He first had an artificial disc replacement. Then he said, no, I'm sorry, it's not from disc, it's from SI. Then they put SI screws. And the one on the right, one after the other, screws, screws, screws everywhere. So what I've done now, I try to diagnose it at the time. So you've got a disc problem or you've got listhesis, but you also have this. Do you want me to block it first and then show you? And then if you're not better, we will go ahead. Or at the time of surgery, you do your decompression, then you block the SI joint. So try and do it. So in summary, SI joint and facet is a potential pain source after lumbar surgery. And it's one of the causes, I won't say failed back, but it can follow that. And it should be considered as an adjacent segment degeneration. And as the number of spinal fusion surgeries will increase, so will these will increase. So don't, my own practice, unless there's a demonstrable instability, just because it's a disc or a L4-5 stenosis doesn't mean it needs screws, but standard all over India, that's being practiced. It's not good. And let's diagnose it pre-op. So I tell my patients, kid, listen, don't worry, you've had surgery, but it is possible in 2 weeks or 3 weeks you will come back with some pain, but we can sort it out. So I won't show this, but I just want to say, suggest, sir, this is a wonderful course you've designed, but the next time we can do something on pain, we can do a bit of workshop, because everybody doesn't have what we have as pain management people. So if you can do that, that'll be good. And a little bit about rehab. So we've spoken, you can go blind, you can go hemiplegic, but what do the young neurosurgeons do after that? Because they seek our advice about what to do next. So I would love if we had a little talk about rehab. And now it's assistive technology. Just 1 second. Now he was talking about blindness. I've identified 60 blind people, given them smartphone education with IIT Delhi. Their life has changed. They're saying we are ordering Zomato, we are ordering our cab, they're doing all of that. So I need people to be aware that when we produce disability or following head injury, what do we do next and where should they go? Thank you, sir.
Thank you, Dr. Prasad, for your talk. Next, I invite Dr. Junho Lee for his talk on evidentiary factors for predicting pseudoarthrosis after ACDF, which will be followed by his next talk on biomechanical considerations for next generation cervical arthropathy.
Well, thank you, Dr. Ghosh, and all the organizing committee for this wonderful meeting of 8th World Dentist Society. I've been here for the 7th World Dentist Society a few years ago in the city of Jaipur, and I had a very wonderful, admiring vision there with the pink city. So I will talk about two talks in series. I'll first talk about what the pseudoarthrosis are causing in terms of ACDF surgery. So this is a 54-year-old male patient, had a very decent myelopathy, had a good surgery, decompression, and after 18 months, you see the very good solid fusion achievement. But that was not the same story for the same 54-year-old female patient, operate on the same week, see how it goes. Same myelopathy, immediately after 6, there can be a subsidence. You see the crack between the end place and the cages, and eventually this patient has to be revised. So what would be the definition of this non-union pseudoarthrosis? There's a lot of past literature and references have some consensus finding that these pseudoarthrosis in most cases are asymptomatic, and almost 80% are occurring at the most inferior part of the construct. And the thing is that what is the real reason, etiology of this pseudoarthrosis is unknown, unclear. Probably the impaired vascularity, decreased stability, or some input of enough stress through the fusion site might matter. So how do you gonna diagnose whether this patient has a non-union or not? Still controversial. You just cannot be quite sure. Radiologically, some instability, how many angles. So Dan Yu from the New York, former president of CSRS in the United States, has partially responded to this definition that any movement less than 1 millimeter in terms of interspinous movement, or that exceeds more than 4 millimeter on supraadjacent level, gives a clue that the patient has a non-union. So still, we probably have to rely on the CT scan, so we cannot discard the finding. NAS coverage recommendation has that when the patient should be diagnosed with pseudoarthrosis, they need to meet these 4 criteria. The patient was initially improved after surgery, but now has a pain back, and that pain has to be coordinated with the level of the non-union. And CT or X-ray should define that there's any non-finding that there's a crossing bond between the fusion construct. So these 4 criteria is what the NAS has been suspended. What is the problem with this non-union is that it's very costly. The average amount of the initial primary surgery might be in between $14,000 US, but it's exponentially increasing more than 6 to 10 times when you develop and had a revised on these non-union operations. And this interesting retrospective review on the incidence of pseudoarthrosis investigation performed by Dr. James Harrop, also the former president of CSRS, using the National Health Claim database, had that males with the opioid substance uses with a lot of comorbidity and anterior surgery with a multiple level construct tends to show higher chance for developing this non-union. So average rate of the pseudoarthrosis is about 3.3% by 2 years, but for the patient with the real subsequent surgery rate is about 14%, which is very high, getting more than 4 times increases. So the subsequent rate for those who had a non-union or without any non-union was only 1.5%, so it's almost 10 times higher. So these are the challenges when you are doing the fusion surgery in the spine. The challenges comes from the patient or from the operating site. Unfortunately, we surgeons are getting all the claims and criticism and blame for this non-union because the challenges comes from the procedure. Patients attribute that because the patient or the operating site is reversible or unmodifiable. So how to do a surgery is a critical issue. So this interesting paper from Brazil using self-locking standalone cage showed that as you increase the number of constructs from 1 level to 3 level, the amount of ossification rate, what is called fusion rate, is rapidly decreasing by 10%, like shown here. So the pseudoarthrosis rate was about 16% among their whole construct, but the thing is that only the 1/3 of those non-union patients had undergone revision surgery. That's clue. This is the list of all the osteobiologics in the US FDA requiring US FDA clearance. Among them, BMP2 and P15 I factor still needs pre-market approval. That means that it's still off-label use. But in reality, even in the United States, the number 2 osteobiologics for use in reality is infused, BMP2. So majority of US surgeons are still using this BMP2 in cervical spine despite its off-label. Some of the reports coming from also states that low dose BMP, like less than 0.5 milligram, might be safer. But but usually all these big inflammation in the prevertebral sheath, all the swellings and dysphagia causing. So Nancy Epstein has warned about these issues. So last year, AO Spine had submitted a guideline, which is called AOGO, about broadening up these 12 topics regarding this osteobiological implementation during the ACDF surgery, regardless whether it's going to be autograft, allograft, or BMP2, it's still conditional recommendation based on very low certainty evidences. So what Dr. Zorika Buzo or Hans Mayl has referred to that we surgeons are not still seeing the forest for the tree. That's the common issue with the osteobiologics. What about the cage design and material matters, whether it's going to matter? Actually, we cannot modify the surgical technique of the ACDF. We still have to go with the Smith-Robinson approach. So the more recent improvements are emphasizing or centering on the manipulating the material, shape, and capability of these cages using the procedure. There can be carbon fiber, titanium, or PEEK. Before we start with the biomaterial thing, we should know the definition between strength and stiffness. Strength means it's irreversible, it's a fracture. Stiffness means it's irreversible, and it means elasticity. And this is a very well-known biomechanical curve, which is called Young modulus, with the point of wild yielding point. The reason that I'm emphasizing this definition of stiffness is that when the inserted cages and end plates are in proper harmony or exact match in terms of stiffness, there can be no subsidence. That means lower implant stiffness may decrease the subsidence and increase the stress shielding. That's the important, and that's what the major companies are trying to build up their cages, to modify them to match exactly in terms of stiffness with the patient's contacting end plates. That's the key. So one of the illustrative cases for the 54-year-old also, male physician, said he cannot lift his right stethoscope in his treating room because she's developed C5 soft shoulder palsy. And the operation went pretty well with the decompression. This is the cage that I used. It's very ugly in shape with some windows. It looks like what you are using in the kitchen. This is what is called 3D printed biomimetic surface titanium cages. And there's a report about comparing its usage adoption in terms of between 2 levels and more than 3 levels. Up to 6 months, there seems to be more higher fusion rate for the less than 2 levels, but actually the significance is lost at 6 months. Problem is that these 3D biomimetic surface titanium cages are very vulnerable for the crack propagation because its fatigue strength is less than 50% compared to the solid titanium. And these partially melted particles of titanium during its production are incurring some of the inflammations. And these French bioengineers has reported about experimental analysis and some numerical fatigue-like prediction using these 3D printing cages that it was previously suggested that main factor for failure of a medical implant is the initiation and propagation of crack due to cyclic loading, which is called as a fatigue damage. But these are for the experiment. It doesn't apply in reality to the real patient. And this, in addition, there's a non-homogeneous porosity and rough surface due to partial melting of some particles might be propagating, creating notches with stress concentration. It's developing further weakness of these cages. Cage can broken. And this report from Germany said, actually compared this titanium to the PEEK cages, the incidence of subsidence was not statistically different between the two groups. So but they concluded cage material and its modulus of elasticity represent only one of the many physical properties of the graft. Design, shape, size, surface architecture of cage, as well as bone density of the patient, and preparation, and applied discretionary surgery need to be further considered. So surgical technique might matter more than the material. What about the cage conformity to the concavity of the contacting end plate, so-called as an adequate or inadequate coverage? This is an ADR device that I inserted in, and you still see that there's a radiolucent gap between the contacting plate and end plate of the bone. This is called what is called inadequate coverage. If the contacting point is less than 94%, according to this literature, there will be more higher chance for the development of HO as well as immobility created even after ADR surgery. So in the history of the design evolution of interbody cages used in ACDF, starting from Claude Doe all the way down to the Bailey, Beckley, only strut, I think nobody in this room is using this end plate manipulating this type of material, I think. Yeah, nobody's using that ever. We are just concentrating and just are implementing all these Smith-Robinson rectangular cages. But do you have any question for that? Because there can be threaded or non-threaded cages as well. And we all know that threaded cages are much better in terms of fusion rate, achievement, as well as lower complication rate. This is a photograph of the lumbar spine. And the red triangle means where the osteobiologics inside the cages. And the yellow dot means that's the empty space. So that cage is not in full contact with the end plate concavity. So when you infuse some dye contrast inside, the whole area around the cage is filled with this contrast dye. So this mismatch between the stock device and vertebral end plate creates significant gap, can even affect spinal alignment. So traditional devices are not fully integrated into the overall alignment or does it vary with minimal corrections, while this customized cage, by fitting into the patient unique anatomy, provide more diverse corrections, and this end plate matched implant increased surface contact area might optimize the environment of fusion. Interesting biomechanical report using FM analysis doing a sham imaginary surgery at the level of C4-5 using whether commercial, customized, and bone cages. And there seems to be immobility creating after fusion. But see where the stress goes. It is the inferior end plate of the contacting vertebrae. See, you see a lot of red spot where the highly concentrated stress is located in the portion for the commercial cages. Same phenomena for the superior end plates. You see the high dot. What is more blue, evenly distributed stresses for the customized cages or the bone cages. What about the cage itself? The cage is under very high stresses for these rectangular non-contacting cages. So that means that customized design provides more uniform stress distribution over the intervertebral fusion cages while avoiding high stress concentration on end plates and therefore reducing the amount of subsidence. What about the screws and plates? This is, you all know the synthesis product of the 0P, and there's a report about failures. See, I think the initial surgeon did a very wide deconversion posteriorly, probably the reason for this failure after surgery. The reason why we are putting the plate and screws over the cages is about the stress shielding, I'm telling you. Without the cage support, all the 100% of the body weight or neck weight will go transferred over the plate and screws, which will ultimately lead to the failure. While if you're with the cage, then the stress distribution occurs between 1 to 4. 20 or 30% stress will be shifted only to the plate and screws. One big principle is that the technique of using shorter plates with longer angulated screws results in a significantly reduced incidence of development of ASD. That's the non-changeable principle. So there's some acclamation that ACDF with plate material science is a clearly step toward perfection. And Dan New and Dr. Zuckerman, also from the AO Spine and CSR Society, had recommended we need to use a very longer screws that covers more than 75% of the length of the end plate in order to provide very firm construct and rigidity. This is also a biomechanical experiment using also FM model. They did sham surgery at the level C5-6. They measured discal pressure or the facet pressures, everything. The reason that I like this paper is they only cite my papers published in Spine in the year of 2016. I also did a similar experiment with this using this construct. The thing is that they also measure the stresses on the plate and cage and screws also. See, except the primary immediately after operation during the extension movement, where there can be some high concentrated level of stress distribution, after the achievement of the fusion, more than 3 or 6 months, everything is blue. The whole stress has been gone. So the thing is that stress on the surface of the implant, screws and plates has been significantly decreased or has been disappeared after solid fusion achievement. So there can be also, with this achievement, the facet contact forces are always being lowered down. So achieving a good fusion might reduce enough stresses on the plate and screws. What about the surgery? There can be some issues about where you put the graft in, smaller graft to end plate surface ratio. There can be excessive end plate removal. You do a very aggressive surgery. And graft height, you do over-distraction. These are the matters. There is some controversy and skepticism that we are doing all foraminal decompression during the ACDF surgery. You do a wide resection of the uncinate process on either side. And this might be vulnerable to develop some more surgical-related instability despite we are doing surgery. So my colleague in neurosurgery in Korea has said that we are not allowed to resect more than 30% of the uncinate process. Otherwise, it will be an instability-related subsidence development. But this report has been refuted by our orthopedists that it has nothing to do with the uncinate process resection and pseudoarthrosis, because when you do the enough uncinate process resection, that's good for the patient improving radiculopathy, as well as improving the chance for the good solid fusion on the ACDF construct. So, Philadelphia group, led by Dr. Schroeder and Alexander Vaccaro, in Thomas Jefferson said, in their series over the 18 years, there was about 52% development of more than 2 millimeter subsidence after the ACDF. The thing is that even though the number is high for this subsidence, these patients had a very lack of chance to go under revision surgery. So developing subsidence does not necessarily mean that you're going to revise the surgery. Same report was reported by Dr. Sebastian, also from European group, that actually measured how many millimeter, in terms of millimeter number, the subsidence developing, and they categorized that more than 4 millimeter subsidence will be the worst subsidence, as they termed it. So these worst subsidence are occurring most at the inferior level of the construct, most inferior level, over 94%. And what is causing this inferior level worst subsidence? It is related to what is called screw tip and vertebral height ratio. As depicted here, yellow versus red line ratio might be matter. So if you have a decreased length of working, decreased number of the ratio, you have a very higher chance for the development of subsidence. So I told you, the majority of the subsidence, if you have a more than 4 millimeter, are called worst subsidence. And it is always happening at the most inferior caudal level of the multi-construct. So the most likely explanation for this finding is related to the biomechanical principle, what is called working length. What is working length? The left side is the short working length, and the right side is the elongated working length. If you have a very long working length, that means you have a very higher chance for decreased construct rigidity. So always try to put your screws nearby the cages to decrease the working length when you're doing multi-level construct. Once again, subsidence does not mean that you are going to have a revision surgery. But if you have a more than 4 millimeter, it's going to have a chance for the higher revision rate. So what is that this pseudoarthrosis or non-union is also predictable? Important report from Dr. Lee is that 67% of cases with the pseudoarthrosis happen or detected at 2 years will ultimately and consequently 100% lead to the pseudoarthrosis, non-union, and 5 year. Also means a revision surgery. And some of the report also coming from Italy or some European group said this might be related to the infection. But for me, I didn't have any kind of such kind of microbiology detected so far after the revision surgery. So concluded, is the osteobiology matter? I think the safety is the priority. So you should try to refrain from the off-label products still, like BMP or I factors. Does the cage design of material or mechanical property matters? It's very controversial. I'm telling you, stiffness might have to be in harmony with the contact bony end plate. If you're using too hard stuffs, then it's naturally going to lead to subsidence. Does the end plate conformity matters? It might be, but it's still a new product, so still requires further investigation. What about the plate and screws? Longer screws with the shorter plates and shorter working lengths might be better, but you have to put the priority on the cage first. What about the surgery? That's the most key. You have to do a very good surgery, not to avoid any endoplate manipulation. Do not do any over distraction, and be careful with the osteoporotic friable bones. Thank you.
We'll now go for his next talk on biomechanical considerations for next generation cervical arthropathy.
Okay, then my next talk will be not just about diffusion. This is about the mobility, about the biomechanical consideration for the next generation cervical arthroplasty. So before the start of this topic, I should say there is always two sides of every story. There can be my story, my version, and there can be the real truth. So viewer discretion is advised. So this is the historical time flow of the older US FDA approved arthroplasty in the spine field, starting with the lumbar Charité 21 years ago. Now it's going to be simplified in 2021. In the past 2 decades, over the past 2 decades, there has been only one or two couple more lumbar arthroplasty has been adopted and approved in the US history. While it's completely different story for cervical, 8 devices. So why it's not working in lumbar? Probably these kind of problems. I think the lumbar arthroplasty is fraught with a lot of issues. So these are the 8 devices with the FDA, US FDA clearance so far, starting with the Prestige all the way down to the Simplify. And these 3 devices has been approved for 2-level adoptions. So formerly, it was like plate and screws and something like mimicking the ACDF version of the arthroplasty so far, with a lot of kills and stability provision. Nowadays, these arthroplasty devices are elaborated to mimic the inherent nature of the natural cervical disc. It's more like getting more biologic. So the question is, we have an ACDF. It's a very successful surgery. So do we need a better surgery? Why should we do the motion preservation when the ACDF is so far is working so fast? Why is it? Is it about preserving the motion, or does it provide some faster prompt recovery? Or is it about what the literature is concentrating about, less ASD development? Nowadays, actually, same in India, patients are giving the advice. Yeah, everyone's giving. Like a very big celebrity like Elon Musk. He had an arthroplasty surgery 7 years ago. He said it was like a game changer. It took my pain level from AS9 down to the 4. So Rick Sasso was a former president of CSR about 11 years ago from Indiana, published 2 years ago, 20-year clinical outcome with the cervical arthroplasty with a follow-up rate 91.3%. It's amazing. Despite 20-year follow-up with 91% still in pursuit. Clinical improvement, statistically very significantly, still remaining with a marked improvement even after 20 years, and it's compared to the ACDF, it's very comparable. So nowadays, in terms of adoption of the ADR device for the cervical radiculopathy or myopathy, it's called level 1 evidence. What about the 2-level? Same group, also level 1 evidences. It cannot be reversible so far in my knowledge. So what we have learned so far is over 20 years that it works for cervical, not for the lumbar. It really does work compared to ACDF. Even for the 2-level, it's working more better than 2-level ACDF. And we are not fixating with any plate and screws and kills. So we are trying to mimic the inherent property of the natural cervical disc inside human body. So this is like being marketing driver with this phenomena. It's predicted to attain revenue of about 3.3 billion last year, and 80% of this, like 2.5 billion was covered by cervical arthroplasty. It's a very huge number. So this, we are talking about these articulated implants, which is always consist of interlocking parts. Interlocking part is always fraught with frictions. It's always coupled with the frictions. So like myself or other orthopedists or other spine surgeons have some skepticism or some opinion whether we are really trying to fuse the joint. It is always questionable. There are some of the devices that actually came to the market and spontaneously disappeared, like Blackstone. I don't know whether you heard about these devices, like Blackstone, Kineflex, discovered from the Johnson & Johnson DP. Actually, the DP had almost complete their investigation, but suddenly dropped out. And the product is only sold outside the United States, countries like China. So probably they have a reason. And Kern Singh and Frank Phillips in Chicago, Rush, have a detailed systematic review of the literatures and has suggested this Rush arthroplasty failure classification system categorized in 6 terms, starting from stenosis all the way down to the wear debris. The most common reason for the failure of arthroplasty is not about the devices. It's related to surgeons' inadequate decompression. Number 1, stenosis is the most common reason. Majority of surgeons are just emphasizing on putting the device properly instead of doing a decompression beforehand. We should know about this. So inadequate decompression is the primary reason for the failure of cervical arthroplasty. So there can be question, are there any some sizing or material or mechanical differences favoring one specific implant over others? Or there's like, which implant might work better or which implant might fail more? So what will be the most ideal, best implant among all this 20-year history of the cervical arthroplasty? Very interesting publication from Australia presented in Melbourne 2 years ago in the Spine Week meeting. The first long-term follow-up result of the M6 devices, which is called viscoelastic cervical arthroplasty. 11 years follow-up. And surprisingly, 44% of these device implanted developed osteolysis. These are the grade of osteolysis so far reported in M6 uses. You see these pictures of after explantation. It's very ugly. Fortunately, there was no bacterial infection overlapped. See, this 9 years, this is very ugly pictures that I have shown. So we said 20-year result is very desirable and very good. So why this is happening? Because the current focus on the literature and publication is focused on what the implants are currently being marketed inside the United States. All the implants that have been approved inside the United States seems to be good, while it doesn't work in Australia, I should say. So we are like playing around the campfire. M6 caused a lot of problem. Even the long-time approved devices like a Mobi-C is caught with the issues about hypermobility. So these are the recurring theme of occurrence. So key to success is that we need to have some knowledge in terms of biomaterial kind of aspect of these devices. There can be some biomaterial and then some biomechanic aspect. So I'll start with the biomaterial. So I'm telling you, 2-year result of M6, 5-year, and now I work as an associate editor and major reviewer for the Spine Journal for like past 11 years. This is their 7-year report. Submitted to me for the peer review about a couple of months ago. I rejected it because I know the problem with the M6. One more thing is that these are the post-operative MRI after the implementation of ADR devices. And the patient reason why they brought this MRI after their discharge for a couple of months later, I have improvement on my clinical symptoms after ADR switch. Now I heard that from the local surgeon. Now I have a myelopathy. These are the post-operative MRI. Can you see any myelopathy in these MRIs? I cannot see a thing because it is all related to the metallic artifact. So what if we change the biomaterial into these pictures? This seems to be very good, yeah. So I made a transit when people coming to this wilderness. I made a transit at the Chennai airport to the Mysore. And these Indian engineers had published a very important review about the application of PIC in total disc arthroplasty. They work in Chennai. This is very important. These consist of a PIC plate with the aluminum ceramic core, which is nickel-free to avoid any wear debris. And they start with not just from the 5 millimeter as the US surgeon did, they start with the 4 millimeter to provide high choices for appropriate fit without any over distractions. And they have a superior teeth as well as the lower side has an inferior fins to provide immediate fixations. And they have a convexity to match the conformity of the contacting end plate. This is what's called anatomic fit. This is called the simplified disc. In the first US FDA ID investigational device exemption trial, they recruited the candidates, about more than thousands of them. And among these candidates, 83% of the candidates had less than 4 millimeter preoperative disc height. Eventually, that leads to that they're using 4 millimeter height of devices was dominate more than 50%. So this is how it looks. Yeah, we don't have a myelopathy anymore. Yeah, this is quite a wrong diagnosis. Yeah, we have a very good MRI profile. And physiological motion seems to be pretty well. So it provides properties kind of increase in terms of anatomy. It pertains natural motion of the human spine. And it has no MR artifact. And since there's biology, there's a nickel-free, there's no wear debris. This is what the Simplify is for. This is ideal aspect, what the company guys are telling us. But look at this publication also from Matthew Scott Young. He's the president of the ISAS meeting next week in Miami. I'm going to meet him in Miami next week. This is the osteolytic report of the M6 devices, as well as other devices, including the Simplify. 30% of their subjects developed osteolysis after using the M6 devices, but it's not just limited to the M6. 12% of their patients group developed osteolysis. Why is it? It's a PIC. PIC has a very high tendency to develop halo compared to titanium. We all know that, yeah. This is in reality, it doesn't reflect what this ideal suggestion from the engineer comes from. That's the reality. What about the surfaces? There's some questions about does design variation ADR device influence cervical biomechanics? This is then be some ball and core spherical shape or oval shape can be placed in the either ventral or posterior side. And with this difference investigation using FM model, probably the design plays a significant role in facet loading, resultant implant stresses, and angular motions. It's not just about the experiment in vivo, in real patient, comparing these three devices. Brian tend to be kyphotic, while the ProDisc was lordotic. Synergy showed that some significant increase in lordosis. These are all the reports coming from the reality. What about the biomechanics? Requirement for the ideal artificial disc so far is defined as high congruence of mating surface for low contact stress. It has to protect the facet joint. And the center of rotation should be located posteriorly. And surgical technique should be safe, is mostly consistent, and the longevity matter. When we are thinking about restoring the normal cervical motion, there's a two aspect. It's the quantity as a quality of the motion. Quantity of the motion is measured by range of motion, while the quality of motion has a two aspect, where the location of center of rotation is, and how to replicate the kinematic signature. What is kinematic signature? Is this ellipsoidal type of graph. There's a 0 point starting with the extension and flexion. And the 0 point means a neutral zone. The Y is so non-linear in terms of applied moment. Why does it have such kind of some graded resistance? It comes from the disc, facet joint, or attached ligament. So it shows a very ellipsoidal way of curve. So difference between flexion and extension curve is called neutral zone or high flexibility zone. How to restore that high flexibility zone or neutral zone is the key for the ADL devices. So if you do the laminectomy or facet resection or posterior foraminotomy when you're doing simple surgery, it can be destabilizing cervical spine. And how that kinematic signature is changing, the slope of the resistance is going down, like in blue curve here. Can you follow me? If you're inputting very ideal cervical devices into C5, 6 level, it completely mimics the route, the trail of the kinematic signature of the normal human aspect. That would be the ideal ADL devices. And how many degree of freedom is also termed to how you're going to define the constraint of each devices. There can be 3 translation and 3 angular motions. So that determines how many degree of freedom determines whether the device is constrained, semi-constrained, and unconstrained. This is very important. Constrained means it means intermittently stable, while semi means intermittently unstable, while you have an unconstrained device, it's completely undetermined. You never know where the motion goes. It's completely unstable. So constraint, I told you, how many degree of freedom means that it determines the type of constraint for each device. That moves independently. So there's three translations and 3 angular motions in 3D spaces. So in terms of semi-constrained devices, usually have a 3 degree of freedom. It lacks translation. It only has angular motions. While we have some unconstrained, completely undetermined devices like Brian, you have a 5 degree of freedom, including 2 translations, except vertical translation. This is very important. The thing is that these ADL devices has a passive kinematics. I'm telling you, the motion is determined by the geometry of the ball and socket bearing surfaces, and central rotation is consequently determined by this geometry. So I'm telling you, unconstrained 5 degree freedom, Mobisi and Brian, while semi, like a ProDisc and Prestige, you all heard of it, 3 degree freedom. So this is what the unconstrained device looks like. It has a spherical superplate device and has very planar inferior plate. Superplate convexity allows angular motions, while this planar inferior plate allows translation. It is coupled. Once the angulation happens, it translates about 1 to 2 millimeters ventrally. So that's the coupled motion. I'm telling you, it depends 5 degree freedom. Look at where the center of rotation is. This is for the case of lumbar. There's a healthy, it's a very senile degenerative disc here. See that healthy patient, center of rotation remains constant. It doesn't move. It doesn't change its coordinates. See? While in the severe degenerative disc, center of rotation still keep on moving fast and forward. So where is the center of rotation for the cervical spine? Very famous orthopedist who never did surgery in his life, dedicated his whole life doing this research, is Dr. Optic in Arkansas. He said center of rotation might be located in the upper mid portion of the body, in the upper cervical level, while it might be very close to the inferior portion of disc space in lower subaxial, like 667. That was his hypothesis, and that has been verified with diverse FEM biomechanical experiment, Dr. Switzerland, Anders and Jung. So in each motion, see, when you do the flex extension, these are the instantaneous axis of rotations. It's just like a full motion is expressed in a continuum of IAR. And the median green dot, it might be the mean axis of rotation, is the hypothetical axis of rotation that will displace the vertebra from a position from extensive flexion to the extensive extension. So there has been numerous investigation and elaboration researches trying to find the center of rotation for surgeons as well as engineers. Where is this location might be in real patient? And its correlation with the clinical outcomes. Interesting paper from China. They recruited 700 asymptomatic subjects. They are not patients. I don't know how ethically it was approved in Chinese study. Divided their recruited candidate among their ages from 20 to 80s. So what they found out is that degenerative changes produce more anterior and superior translation of this instant center of rotation, which was significantly correlated with these loss. So I'm telling you, mean center of rotation is influenced by spine aging, and degenerative senile changes introduce more anterior and superior translation of the mean center of rotation. So when you are doing the arthroplasty, it should be optimized and attempting ICL location more posturally and downwardly instead of a uniform position. You following what I'm saying? You have to translate that coordinate once again back to its original location by posterior and inferior side. I myself have a lot of publication elaborated for spending past few years doing these researches. And this is what it looks like. This is a center rotation before the operation. After a switch, it profoundly goes dorsally and downwardly. It's related to clinical success. Patient's very happy. Same coordinate for the center rotation on the other patient. Even after 2-level switch, doesn't change much. It's still, it means it's clinically unsuccessful. What about the core itself, whether it's going to be fixed or mobile, if you have a geometry of a ball and socket here, and you do the flexion, the facet will be more stressed as you go the extension flexions, and it can be under impingement. The more, if you ignore this and you do more flexions, stress goes to the ball and socket itself. If you keep going on flexing, then eventually the both sides will fail. So this happens with the fixed core, but if you provide more vulnerability or flexibility to the core itself by providing some motion inside the core, facet will not be restored in the original location. See, that's the limit of the fixed core because it has a reduced mobility and motion is dictated by processes sufficient and physiological. Sternum rotation determined by implant geometry and positioning. Fixed core has a very limited motion, so it has a very higher chance for over-distraction or impingement of facet. So when you replicate this kinematic signature using fixed core type of devices, the slope of the stiffness is rapidly increasing with these devices. But if you provide the mobile center rotation devices, as you insert this into the flexion, it translates, and the facet stress is under recovery. If you put more fully mobile center rotation, this translation is more exaggerated over 22 millimeters. So mobile core allows about a couple of millimeter AP or medial lateral translation. So it's more natural, and it's a motion guided by the, not just by the cassette. I think the surgery is more important. The difference between ADR surgery and ACDF, the key difference is that you just have to put more emphasis on putting more endoplate and native architecture preservation. And you have to precisely put the implant in center of the anatomy. This is how you do the surgery. You do the distraction, you test per pin, but sometimes it's like skewed in this way. So if you, the whole operative field is now blocked by the component disturbance there. So you do the white decompression there, and that's naturally leading to the kyphosis. And this has been reported with coupled with a lot of failure for the ADR devices using Mobi-C. Without parallel alignment of end plate, unconstrained ACDR device might be vulnerable to symptomatic segmental kyphosis. And this, look at here, there's a gap. 1 month, 7 months, there's coverage of bone. And 2 years, there's HO development. That's called inadequate coverage. I told you in prior lecture. 90% of the end plate should be in contact with the plate of the devices. So I told you about degree of freedom and stiffness kinematic signatures. But in my part, surgery is more matter. So choosing the right patient is a highlight for the optimal success. Thank you.
Thank you, Dr. Lee, for your talk. Next, I invite Dr. Apurva Prasad for his talk on surgery for OPLL from only decompression to only fixation.
Good afternoon, everyone. I thank Professor Ghosh and Professor Pandey for the kind opportunity. So we have had very wonderful talks in the spine session, and I request you all to hear my talk with an open mind because it's going to be a bit different from what we have heard till now. Can I have it? Yeah. So I want to, just get an opinion as to what exactly is evolution. Does it always have to follow a linear path, or is there a chance for parallel offshoots and a different and an alternate form of thinking? And in my slides, I only have my patients and their data to show to see if another form of a treatment and a philosophy is acceptable. So this is my talk. These are my teachers. I continue to work and learn with them. And I'm very glad that my mentor is sitting right here. And most of this is a culmination of his work, what he has taught us over the years. So I hope the presentation is a bit absurd to you and to your ears, so that I am hopeful so that it may, inculcate some more thought. So spine surgery always has been result-oriented. We see it. As far as the patient is good, we have no problem. And if we have a good scan and a bad patient, that is when the problem starts. So the WFNS guidelines were published in 2019, it's 6 years ago, for the cervical spondylotic myelopathy. And till now, the consensus is that the index point is disc degeneration and disc bulge, and all the factors are secondary to it, and therefore they have to be treated. If compression is taken as the cause, decompression is the treatment. There is no doubt about it. So when compression was the cause, we came up with many procedures, anterior and posterior, to decompress the spine. But then as we grew in our experience and we became more intelligent, we understood there was a concept of iatrogenic instability. So along with decompression, fixation was put as the standard treatment option, either before or after decompression was an individual choice. What we want to propose is if we can become a bit more wise, a bit wiser, and go a step ahead and really see if decompression is really required or not. Now, in all my presentations and slides, we have not done decompression in any of the patients of OPLL, and if we take as the facetal instability as the index point of genesis of all these problems, there is no scope for any decompression requirement in these patients. This is the entire spine in its glory, the cervical spine. The facets and the subfacetal bone is the strongest bone of the spine. It forms the axis for the weight transmission. And all the other parts of the body, the vertebrae, the spinous processes, all are not as strong as compared to the facets. The orientation of the facets in the C1, C2 and the subaxial cervical spine is very, very different. If we see these facet joints, the orientation of C2, C3 is quite different from the subaxial cervical facets below. And this anatomy is very, very important when we are dealing with these patients. Now, the need for no decompression will be illustrated more. Now, the concept of a transarticular fixation, why? We are all very happy with the lateral mass fixations. We are all doing it. I was also doing it. The problem with lateral mass fixations is even if we have a very, very good construct, 2 points of motion are always there. One is between the screw and the polyaxial neck interface. The second is between the ine and the rods. These movements are always there as micro movements. Any construct is never going to be truly immobilize the joint. When we do a transfacetal fixation, the screw goes through the joint. It's a physics principle. Any implant going through the joint is going to immobilize it in the best way possible. That is why now we have completely stopped using lateral mass techniques and we are only doing transfacetal fixation in all the given indications. 2 techniques have been described for the transarticular fixation, an oblique and a perpendicular one. We follow the oblique technique of Del Canto. Now, when I started my practice, these patients used to come to me and I did a decompression, and Professor Goel was very unhappy with me. So in these initial patients, I did a decompression and a transarticular fixation, and I was happy because the patient, this patient was a driver. So within a period of, So this patient recovered in the initial 1 month with a mild grade C5 palsy. Then he improved completely, and he was back to work within a period of 3 months. And this was another patient. She was a staff at the hospital, and if you can see, I would like to, I can't move it. Her legs were very, very spastic. You can see her hands, you can see the spine, a big OPLL. Again, in this patient, I did a decompression with a fixation, and the patient did improve. Over a period of 3 months, she was able to walk, and I was quite content with the amount of recovery I was getting in these patients. But this was the patient which actually changed my concept and changed my thinking about the way these patients should be handled. Unfortunately, I cannot fast forward the video, but I like to this is a patient of Professor Goel, and I would like you to focus on the legs of these patients. They were like logs of wood. We all know patients with these bad OPLLs, they have spastic quadriplegic, they have gallbladder involvement. Now, as the patient was being positioned on the trolley to be taken inside the theater, I just want you to have a look at the legs of the patient. They were so stiff that we could not bend them. His leg got stuck in the key of the bed, which had to be removed by this attendant, and he had literally to be lifted and put on the bed. And this is a video, I'll skip it, it's a clinical video. And this is the patient who came walking to us after 2.5 months of surgery. So this was the patient which made me completely convinced that decompression is not required. You can see the post-op scan. The lamina is completely intact, and this patient came walking to us within a period of 3 months. And from this point of time, we never looked back. I have never done decompression again. You see, this was the pre-op of the patient, the post-op. Yes, there seems to be some neural compression. Yes, there seems to be OPLL, but the patient is completely all right. After that, we had many such patients, and we have been fortunate that we have had a huge experience of OPLL now. And all these patients have been treated with the technique of only transarticular facetal fixation without any form of decompression. We all know that these patients are very, very difficult to treat. We have all treated these patients and landed into very, very bad surgical outcomes, even reaching up to tracheostomy and a bad neurological recovery. But with the current technique which we follow, now this was the patient whom I operated around 1 month back. The first video is on post-operative day 1. The second video is of post-op day 3. And the patient went back to his village, and he sent me this video around 3.5 weeks later from surgery when he had started walking independently. This patient was completely bedridden before surgery. Another patient, bad OPLL, the philosophy and the fixation treatment remains the same. Now this patient, he was doing a somersault. He was a heavy individual at the airport security doing a somersault. Now I want you to focus on the stripping of this PLL. It was definitely, there was some bony osteophyte changes and body compression, but there was a stripping of this PLL. So I did a fixation. Now which levels to fix? Why was a 4-level fixation done for this seemingly single level disc prolapse which could have done with ACDF? It has been published. We have put our paper in our papers what levels to fix, which levels should be fused so that the incidence of ASD does not recur. And this was the patient who came to me in my follow-up OPD after 2 weeks. Another patient, this was a nurse, and she had stopped assisting in surgeries, severe neck pain, not able to walk, treated with the same philosophy. She has resumed her work after around 2 months of surgery, and 2 weeks back I was in her hometown. She came to meet me in the hospital, which is now almost 2 years after surgery. And all these patients get back to their normal life within the period of 3 months. This patient again was a nurse at the hospital. You can see the clawing in her hands before surgery. And you can see her hands immediately after surgery on post-op day 1. This was the same patient. She came to me after 6 months with this MRI. I could see a good CSF flow all around, no compression, and a good fixation construct with no decompression at all. Patients do very, very well. Now, when we do a multiple level fixation without decompression, there's always an element of the compromise in the neck mobility. So this was a patient, we get these patients very, very commonly. He was a very heavy patient, around 100 kgs, young patient, around 42 years of age. Now, what do we do for this patient? We can't do a decompression and leave him. We can't do an anterior corpectomy and leave him. So only a fixation was done without any decompression. And I want you to show the obvious, the first one is the pre-op and the second one is the post-op video. There is hardly any restriction of neck movement. So the doubt of a compromise in the neck mobility is actually not that severe. Patients do continue to have, and this is almost 4 months after surgery, seems to be as happy as ever. Now this patient was one of the recent patients, 120 kgs, bad OPLL. We do a corpectomy, we land into many, many problems which all of us are aware. I only did a 3-level fixation. He sent me this video from Agra around 6 months of surgery. So later, we have many, now this patient was done hardly 10 days back, Professor Goel knows, and he did this surgery, and this a bad OPLL. You see this patient, on one side the father is holding the patient, on the other hand the wife is holding the patient, cannot walk. You can see the clawing in his index finger in the left hand, in a very, very bad state. Now again, this is the video on day 1 of surgery, post-op day 1. This was when he started walking after 5 days, and this is at the time of discharge after stitch removal on day 11. The same fixation construct without any form of decompression. Again, a similar patient of OPLL, and when we see a 3D reconstruction, we can see the changes in the facet joints. We can see the lipping, the osteophyte formation, everything has been reported, everything has been published. These osteophyte formations, these overlapping of the joints, these are not stable joints, and this is where the pathology lies. So this needs to be seen and examined. Another patient done very, very recently, bad OPLL. You can see the right hand before surgery, severe clawing, severe spastic right hand, and this is the patient and his hand immediately around 24 hours after surgery, where he had a good opening of the right hand, and he's now started walking in the ward. I got this video around 3 days back. So there is a huge potential for us to understand that decompression is not the answer for these pathologies. We are not treating the radiology. Radiology does not determine our surgical approach, and it should not, because had compression been the cause, none of these patients could have ever improved, because we are not doing decompression at all. And why we are now proposing not to decompress, because this patient was operated outside. The X-ray looks very, very good. Someone had done a 2-level cage fixation. Scans look good. The patient was on the bed for 2 months, pumped up with steroids. This was the hospital staff again. And if you see, when we see the axial scans, we see that the implants are impinging into the spinal canal. And the patient was in a very, very bad state. She could not walk at all. And if you see the cord edema, it has increased actually. So I discussed it with professor. He said, don't remove the implants anteriorly, the dura is intact, just do a fixation. This was the patient after 3 weeks of surgery. She's back to her work now. Another patient, single level ECDF done outside, and the patient has increased myelomalacia. Now we have many such patients who have been treated with corpectomies, who have been treated with multi-level, this patient had been treated with 3-level ACDF, continued to worsen. Only did a fixation posteriorly, and the patient was walking in the ward after 4 to 5 days. So even the WNS guidelines say that there is a 30% risk of CSF leak if we go anteriorly. There is a 20% risk of a neurological compromise in these patients if we go anteriorly. More than 2 level, 3 level is always debated. So, and the literature is flooded. If you see the publications, Dr. Goel has a seminal work in this field. We have multiple publications, and the futility of decompression. Is decompression really required? It's not the neural deformation or the compression, but it's actually the instability. So if we can stabilize with the technique which we follow, believing that that is the strongest and the most stable construct, we can give actually a very, very good life to these patients post-operatively. And if we take that facetal instability as the index point, the same philosophy can be used for patients of a Hirayama disease or for patients of a degenerative cervical myelopathy. So the principle remains the same, the applications always vary. And now we just published this last year. Now our series of OPLL is more than 150 patients. We have had very, very good response in all of these patients. None of them have worsened. We have follow-up of even now more than 10 years in the first patient done around in 2012 or 13. So this is a small surgical video. I will just forward it in the want of time. So what we are saying is, if we can unlearn what we have learned, that compression is the cause and decompression only can be the treatment, and if we can pave way for some lateral offshoots in the linear progression of evolution, how we have progressed in spine is from the open surgery to loops to microscopes to the tubes, now to the endoscopes, to the fully endoscopic system, then to the UBE. It's a fairly linear progression what we are seeing. So what a humble attempt is, can there be a lateral thinking as well? Do we have a scope for a lateral thinking? The presentation, thank you.
Thank you, Dr. Prasad, for your talk. Next, I would like to invite Dr. Atul Goel for his talk on C1, C2 stabilization.
Let him put in my चलेगा? लैपटॉप लोड किया तुमने मौके? Okay.
Another lateral thinking, another revolution. Be ready and be steady. And tighten your seat belts with craniovertebral junction. Complete revolution. There is no partial revolution or half revolution. Complete revolution in craniovertebral junction surgery. The concept of central or axial, atlantoaxial instability. So whole spine, you see all our muscles, human standing two-leg position, all our muscles are focused on the facets. Facetal instability is the issue. Facet is the fulcrum of all movements. All muscles are focused on facets, none on the body and none on the disc. This is, if these muscles become weak, facets, there is an instability. So this concept, I'm not going to talk on subaxial spine, which is of course a huge different subject. Craniovertebral junction, there can be central or axial, atlantoaxial instability. And it may not be recognized on conventional dynamic imaging. And this is a new concept, and this has expanded the horizons of craniovertebral junctions treatment. In the subaxial spine, the same concept is on the facets when they have vertical facetal instability. This is also a complete revolution which Dr. Apur was mentioning. We cannot see this vertical facetal instability on dynamic imaging, but osteophyte presence, ligamentum flavum buckling, reduction of disc space, and all those things indicate the presence of vertical instability. They indicate the need for stabilization. All the compressive agents are secondary. All the compressive agents like osteophytes, buckling, ligamentum flavum, bulging disc are secondary. They are protective. And they are reversible. They indicate unstable spine and they indicate the need for stabilization. In craniovertebral junction, facetal instability, the only parameter to determine instability in craniovertebral junction is atlantodental interval. There is no other validated parameter to indicate atlantoaxial instability. In 1999, we said this facetal listhesis is the problem. Instability is the issue. All these patients were treated by transoral decompression for decades. Instability is the issue and stabilization is the treatment. So this problem is solved. Now the problem is this one. There is no atlantodental interval instability. There is basilar invagination. There is Chiari. There is syrinx. There is no problem here. But there is a retrolisthesis of facet.
This indicates unstable spine. This indicates the need for stabilization, and that is the treatment. Any kind of decompression, which currently the whole world does, is a negative operation in the presence of unstable spine. Even when the facets are in alignment, even when there is no atlantodental interval disturbance, presence of Chiari, presence of syrinx, presence of assimilation of atlas, presence of platybasia are all indicative of unstable C1, C2, and C1, C2 stabilization is the treatment. When there is no atlantodental interval disturbance like in type 2 and type 3, we call it CAAD, or central or axial atlantoaxial instability. CAD may be present in craniovertebral junction related issue like Chiari, syrinx, assimilation of atlas and things like that. CAD may be present in association with subaxial issues, and CAD may be present without any craniovertebral or subaxial issues. So we have divided it into 3 groups. So my concept is clear. Now there is no, if somebody discusses with me, I have no hesitation to say, don't discuss, take it. Chronic atlantoaxial instability, instability for 10 years, 15 years, 20 years. This is the father. This is the point of genesis. This is the initiator and propeller of all these issues that you see, like basilar invagination, syringomyelia, Chiari malformation, C2-3 fusion, Klippel file, platybasia, kyphoscoliosis, torticollis, bifid C1, C2, os odontoideum, and you see so many issues which I am saying are currently, whole world treats them by decompression, and I am saying that all these things are not to be treated, they are naturally protective, they are reversible, potentially or manifestly. The issue is atlantoaxial instability and the treatment is stabilization. So this is a huge concept. So now there is Chiari and syrinx. Today, at least 95% people in the world will treat this by decompression. We are saying, don't worry about this. Don't even worry about this. This Chiari and syrinx are secondary to chronic atlantoaxial instability. Do C1, C2 stabilization and magic. Magic will be the clinical result, and radiological reduction of syrinx is 100% of cases. And we have got now several hundred cases for anyone to argue and discuss this. There is no room left for all that. The whole world will still treat this by decompression or syringostomy and things like that. There is no problem here. There is some little problem here, but there is no question C1, C2 stabilization is the treatment. Decompression in the presence of an unstable spine is not only not good, it is bad. And magic is the clinical result, and we have got hundreds and hundreds of patients like this. No problem here, some little problem here, Chiari, syrinx, no decompression, stabilization is the treatment. So recently we wrote about this, and if you see, Chiari formation, I don't call it malformation because it is secondary, it is protective. Mal means bad, formation means good. Syringomyelia, idiopathic syrinx, basilar invagination, Klippel file. All these things which currently are treated by decompression by the whole world, I am saying that this is not the issue. The issue is atlantoaxial instability, assimilation of atlas, basilar invagination, Chiari syrinx. This, you know, everybody knows that what is the treatment? Decompression. It is not the treatment. It is a negative operation. C1, C2 stabilization is the treatment. Tonsillar herniation, look at the facets. Facets may be highly unstable. Stabilization is the treatment. Chiari syrinx, look at the facets. Even when the facets are in alignment, it does not say that. Now we have got some new parameters which I am going to publish very soon. I don't want to talk about situation where I have not published, but facetal malalignment, stabilization is the treatment. And you have to just believe magic is the clinical result. So basilar invagination, syringomyelia, Chiari malformation are all secondary to atlantoaxial instability. So when I wrote this paper, there was a huge controversy in the world of spine and craniovertebral junction, but this controversy is slowly but surely and definitely dying down. And basilar invagination, both group A and group B need atlantoaxial stabilization. This paper we wrote about 6 or 7 years ago, 388 cases. You please read this paper because there are too many fantastic things in this paper which state that what needs to be done. Syringomyelia, other thing which I want to say is when Chiari is present with syrinx, or Chiari is present with basilar invagination, or basilar invagination is present alone, it indicates unstable atlantoaxial joint. So discretely or in cohort, they are all indicators of atlantoaxial instability. So when syringomyelia is present with basilar invagination, of course C1, C2. But syringomyelia is present alone, that also is an idiopathic syrinx. Nobody in the world knows what to do with this. Some people will do shunt and all those things, which is a negative operation. Syringomyelia is one of the children of atlantoaxial instability. So this father has too many children and quite a smart father. Cervical fusions like Klippel file, C1 assimilation, C2-3 fusion, and so many other kinds of fusion are all protective. They are all indicators of unstable spine, and they are all potentially reversible. See, there is no compression here. The world of spine is focused on compression. The world of spine wants to treat compression. For this patient, there is no compression, so there is no treatment in the world of spine. But compression means nothing. See at the unstable spine. This girl, a daughter of a very famous publishing newspaper man, she was not able to breathe, and immediately she was starting having a new life, a magic. Bifid is secondary. The whole world thinks that it is embryological disturbance, segmental error and things like that. It is not. This kind of bifid is secondary. It is protective. So when you see fusions, it indicates atlantoaxial instability. When you see bifid, it indicates atlantoaxial instability. Compression or not compression is not the issue. Similarly, we said os odontoideum is secondary to chronic atlantoaxial instability, and atlantoaxial stabilization is the treatment. Short neck, torticollis, in children like this, torticollis, short neck. In the evening of operation, you will have this problem. There may not be any other issue, but these are like scoliosis in disc, indicator of unstable C1, C2, and C1, C2 stabilization is the treatment. Central instability may be the cause of kyphoscoliosis. And these kind of kyphoscoliosis you treat by 10 screws or 100 screws and big rods and all those things are negative. You have to identify. Here, of course, there is Chiari and syrinx. There is no question you will treat by C1, C2. But even in the absence of Chiari and syrinx, this kind of kyphoscoliosis may be associated with atlantoaxial instability, and that is the treatment. Chiari, this central or axial instability may be discrete presentation. So this is syringomyelia, no problem here, no problem. What do you do for this? Bifid, there is no other issue, no compression. What do you do for this? These are secondary to chronic atlantoaxial instability, and they need stabilization. So quickly I will go through some subaxial things. When we talk of spinal degeneration, nobody talks of craniovertebral junction. Have you heard anybody saying multi-level? They talk of C5-6, C4-5, never C1, C2. So C1, C2 instability is very frequently associated in multisegmental degeneration. Particularly, you see multisegmental, patient comes in a severe, they heart, not much compression. You see this unstable C1, C2 facet. This patient needs multisegmental stabilization that includes atlantoaxial stabilization. OPLL, as you have just heard, no question in my mind. You do decompression, negative operation. Anterior corpectomy, if you may know, that oblique corpectomy was described by me long time ago. But that was history, and that chemistry has changed now. OPLL needs one treatment. It is OPLL is a manifestation of chronic unstable facetal vertical instability, and only stabilization is the treatment. I presented this article about 10 or 7, 8 years ago, but now my experience is quite huge and my concept and convictions are quite solid. So this kind of thing, no decompression from front. Don't worry about the compression. Don't fixate your thoughts on compression and compression. Stabilize, and that is the treatment. And atlantoaxial instability is very frequently present in OPLL. So I think I should stop, because if you keep on, if I go on, I will just go on. But what I want to tell you is, this is a complete revolution in subaxial spine, in craniovertebral junction, and this is the future. Thank you very much.
Thank you, Dr. Goel, for your talk. Next, I would like to invite Dr. Sumit Sinha for his talk on total en bloc spondylectomy for vertebral tumors.
So, what an eye-opener. Again, what a talk. Hearing Professor Goel is always a treat. Well, taking you across the other spectrum of the spine, very much away from C1, C2, is this topic that I've been interested for speak on for the next 10 minutes or maybe 11 minutes. So, well, this may not be the common operation that we do it every day, but when we do it, we need to know as to how it needs to be done. And I thank Professor Ghosh and Dr. Anil Pandey to give me an opportunity to be in this event, and wonderful destination, wonderful conference, long time to be cherished. Thank you so much. Well, I would rather not like to go into the details of oncologic planning. These all my talks and everything is on my YouTube channel. You can very well search it. You can read on the internet regarding this. But I would like to show you the operative video, because I think at the end of 2.5 days, everyone is tired and theory is not, anyone is interested in. But anyway, I would like to quickly summarize this as to how to do the oncologic planning in these tumors. One is the Tokuhashi scoring. There are several scoring systems available by which we can assess the need for surgical operation in these patients. And one is the Tokuhashi scoring. These are based on several criteria, as you can read here. And and then you can decide based on the scoring systems whether the patient needs a palliative surgery depending on his tentative estimated period of survival, or whether he needs an excisional surgery if the score is more than 12. Tomita scoring system also must be knowing, most of you, and this is what it says. If the patient has 2 to 3 points and it needs a wide or marginal excision, if he is 6 or 7 points on this scoring system, it's a palliative surgery. Surgery is of course not indicated if these are the factors with the patient. The survival is less than 6 months for GC, of course. These are all common sense. There are other staging systems as well, like the Anaking staging, where we stage that lesion according to its extent, whether it is confined to the vertebral body or it has transgressed its tumor capsule. So, based on this, now this is specifically for malignant tumors. Based on this, for the low-grade tumors confined to the vertebra, we can have a wide en bloc excision, whereas the high-grade tumors, which are confined to the vertebra, but they have infiltrated the pseudocapsule, the tumor capsule, then wide en bloc excision, and of course supported with adjuvant therapy, be it radiation or chemotherapy. So, Other classification systems also are in vogue, but out of several classifications, one of this is very, very essential and crucial in the oncologic planning, which is the WBB staging, which is the Weinstein-Buriani-Piagni system, in which we divide the vertebra into 12 sectors from 1 to 12 clockwise, as you can see in this illustration. And from inside to outside, there are 5 compartments from the extraosseous soft tissue to intraosseous, superficial, deep, extraosseous, and then extraosseous intradural. So you demarcate this lesion as to which compartment this lesion is encroaching upon, and then you take out that if you are considering a en bloc resection. So this is a very, very important system in order to plan your surgery as to what type of surgery you will do. So for example, if the tumor is located from here to here in the posterior elements, as you can see here, then the vertebrectomy, the marginal or wide en bloc excision of the vertebral body is to be done when the tumor is confined to zones 4 to 8 or 5 to 9, 4 to 8 or 5 to 9. And the sagittal resection or the en bloc resection of the combined body and the part of the posterior arch when the tumor is confined to the zones 3 to 5 or 8 to 10, and the resection of the posterior arch only if the tumor is confined to the posterior elements. So this is in brief about the WBB system, which is the very effective system. There are other systems as well, and due to lack of time, I would not be able to go into the details like the NORMS system and other systems. What I would be more interested in showing this operative video about this L2 chordoma for which en bloc spondy was planned, and this is the CT scan. As you can see, there is a solitary lesion over there in the L2 vertebral body, which is inside confined to this. This you can see in the bony cuts of the CT scan. This is the T1 weighted MRI of this patient, and this is the T2 MRI, and this is what it is. It is confined. You can see this is confined more or less to the vertebral body, and what you need is to remove this vertebral body. So this is an ideal, according to the WBB, this is ideal for a combined anterior and posterior en bloc spondylectomy. So there are 2 ways of doing en bloc spondy. Some people do it completely from posteriorly, which is a bit of a difficult procedure without handling of the spinal cord. But I personally like to do it in 2 stages combined into one operation. One is the posterior approach, which is the first approach, where you remove the lamina, remove the posterior elements, cut the pedicles, and free the vertebral body from the posterior elements completely. And then in the next stage, which happens in the same operation, you approach the vertebral body from the lateral side, and then you remove the vertebral body entirely without damaging its capsule or its outer cortex, and then you take out the body from anterolaterally. So let's see as to what happens in the posterior approach. And before you plan on this posterior approach, needless to say, the fixation, the pedicle screws have already been put in, and the stage has been set to detach the posterior elements from the anterior elements. So this is what has been done. As you can see, these screws have already been put into the vertebral pedicles. And what I'm doing is the L2 laminectomy and part of the L1 and L3 laminectomy as well. So just to cut it short, this is entirely under neuromonitoring and image guidance system. Now you see that now what I'm doing is exposing the L2 pedicles on both the sides and isolating them on both the sides, so that this is the L2 pedicle on the patient is prone, and this is on the right side of the patient, and this is on the left side pedicle. I'm isolating this pedicle, and this entire posterior element of the L2 vertebral body has been completely detached from the anterior aspect. So you can see this neuromonitoring. You can check this is the root, and this is the pedicle on the right side. So once you have done this procedure on the posterior side, then what you do is you detach the bodies superiorly and inferiorly by making cuts into the disc spaces as much as you can from the posterior side. So this is what I'm doing right now. This is the discectomy L1 and 2. This is the L2-3 discectomy, making an incision and making space for future mobilization of the L2 body when I go from the front. So the purpose is to make the L2 body as much mobile and as much disconnected when you go anteriorly. You have to do lesser of the efforts in order to make it completely free. Now the third stage is the lateral dissection from the posterior side. So this is as much as possible, should try to dissect it laterally. Now this is similar to the LECA, lateral extracavitary approach, which we often do it, and as much as possible try to go on the sides and detach the muscular attachments on the sides of the vertebral body. And you use this, get lifted up in this deverse retractor, and this is the spinal cord. You see the vertebral bodies over here, and this is the area of interest, the L2 body that you need to take out. So the dissection of the soft tissue from the vertebral bodies is now underway, and you have demarcated this L2 vertebral body. This has to be taken out. This is the L1-2 disc space. This is the L2-3 disc space over here. Soft tissue dissection over the L2 body, and then the discectomies further help in disengaging this L2 vertebral body from the nearby structures. And all through this, the effort is to disengage this en masse in totality without damaging the vertebral body cortical surface, because once this is done, I mean, if you damage or breach the cortex of this vertebral body, the entire purpose of this long operation is lost, because the oncologic seedling will happen and unnecessary, the patient will upstage and may jeopardize the long-term outcome of or the survival of the patient or the tumor-free progression survival of the patient. You see the spinal cord over there, and then effort is being made to remove the disc space completely, and then disengage this vertebral body. And once all the, now this body is being only attached anteriorly now through some of the soft tissue. Rest of it entirely has you can see is all in your hand. So it will be patient, because on the right side there's the inferior vena cava and the left side the aorta are there. So you have to be very, very cautious. No pulling around, no use of cautery on the anterior surface. Now this spoon is very, very useful, which you can protect the great vessels from anteriorly and apply it so that your cautery or your instrument or your osteotome does not inadvertently hit the great vessels of the body. So this is almost about to come, and as you can see, the entire body is now will be there in any moment. So this is how you do it, and then once you do it, you check for any breach that you have inadvertently made, and just 15 seconds more maybe. And then what you do is the reconstruction. Of course, this is some of the remnants of the disc up and down. They will be removed, and the fitting of the cage. This is an expendable cage, and then this is done. Now this is the specimen, which you can see the entire thing, the chordoma in the middle, and this is the post-op X-ray, which is 2 years, and this is 1 year follow-up MRI. This chordoma, this patient received the proton beam radiation as well after the surgery, and you see this is 3 years follow-up MRI, and there is no recurrence. And this patient, I met her. She's a quite young lady, and I met her about 3 days back in my outpatient clinic, which is perfectly fine and without any recurrence till now. And because chordoma is a very treacherous tumor, and you all know that chordoma, they have a tendency to come back again and again, and the only chance of pure success is complete en bloc tumor removal, complete en block vertebrectomy. That is what. And this is the patient 3 years after the surgery, and that is it. Thank you so much.
Thank you, Dr. Sinha, for your talk. Next, I would like to invite Dr. Ankur Bajaj for his talk on mastering the art of CVJ anomaly, surgery, tips and tricks for surgical excellence.
Good afternoon to one and all. I take this opportunity to thank you, Ghosh sir and Pandey sir, for giving me opportunity to talk about this surgical aspect, and always mesmerized by listening to Atul Goyal sir. So as we all see, starting from C1, C2 anatomy, this is the most important step one should always learn and look for any pathology, especially in atlantoaxial dislocation, to look for what is the joint, 3D recon of the joint. If I see, I always keep on getting it on the DICOM images of the CT angiography, looking for various angle of C1, C2, especially in sagittal and coronal planes, and looking for vertebral artery. If I see reconstructing the 3D images and looking it on, it's typically shown that it's type 1 facetal dislocation as described by Goyal sir. Okay, and the vertebral artery is moving from normal anatomical position. We should always know, as a youngster, you should know about the C2 anatomy. As we know, the pedicle is very small. The C2, the vertebral transverse foramina, is just close to the body. So while reaching the transverse foramina, it is just subfacetal. Few of the time they are high riding vertebral artery. We should be very careful about reading it. So while putting this patient, I always try to do awake intubation by my neuroanesthetic. The awake intubation helps to stabilize that there is no inadvertent movement of spine, inadvertent movement of AAD and causes injury. And before I put a Gardner well traction, it's a very good traction. And before positioning it, the trick is you should always push slightly before, so that there is no chance of any dislocation, any injury causing while positioning of the patient. We have learned that the positioning can cause even dangerous effect on the surgery. While positioning, I will always place the patient in such a position that abdomen is relaxed, so that there is no intra-abdominal raise pressure causing venous congestion. A slight Trendelenburg position is very helpful. And this is what I would like to show, that I always used to put additional cotton. This is a very good thing which I have learned. Before scrubbing the patient, putting this cotton, the scrub get it wet, then removing this cotton will help me up. This putting the cotton over here before scrubbing, then scrub the patient, pain drape the patient, and then removing this cotton. Because I have seen in my practice that if the cotton get wet, then after the surgery you get a maceration of the skin due to if the surgery is prolonged. Always putting an incision, which one should always avoid the incision over the inion. The inion should be because after surgery, especially if we cut the C2 nerve root, there's a hypoesthesia of the back of the neck, nape of the neck, and especially while putting any Philadelphia collar and post-op hot collar, there can be a bed sore over the occiput. So this is a case I used to, while exploring the C1, C2 joint, the main is denuding the cartilage. Removing the cartilage fully is the main point. While putting the cartilage and denuding it, one should always make it a pressure over the spinous process, so there is no inadvertent movement of the AAD and causing the injury to the cord. Then again, this way I'm always now preserving wherever possible preserving the C2 nerve root and creating the space and cutting rigorously the venous plexus and coagulating and cutting it and preparing it. Removing the whole of the cartilage and denuding the joint. Then after it, there is another practice, as told by seniors also, to slide drill the C1 posterior arch. This inadvertently make the axis of C1 lateral mass much more better. So drilling the posterior arch of the atlas, now it's definite. We are seeing the C1 lateral mass and C2 screw point, C2 lateral mass, C2 parts and pedicle. Then making it coagulate and so that there is no venous plexus injury. I always drill the entry point. Drilling of the entry point is must so that we can get a strong and good catch. I always do the bicortical purchase. Before putting the screw, one should always drill it. One should always drill and tab. Tab is a must so that the screw can pass easily and in a right position wherever you want. So bicortical screw purchase and tabbing is one of the key factor. So after this rod and construct, the rod can be put easily. If I, this is a rod and construct. So this is the other thing, while exposing the joint, earlier I used to do a monopolar, now I start to do a colloidal needle. This needle has a pinpoint monopolar technique. This helps in a very smooth way of distracting the soft tissue and exposing the joint. So in my earlier practice, I used to monopolar or bipolar. Now I start using a colloidal needle for it. If there is, if we are not able to see the joint, we can put a traction and detect it. And now we have to such exposing, we have to do a comprehensive drilling of a joint. It's a periosteal osteotomy has to be done to see the joint, to denude the joint, to make it flat so that the atlantoaxial dislocation can be reduced. Now, comprehensive reducing or drilling of the joint need practice. One has to be careful regarding not going laterally because venous channels are much more prone laterally, and you had an inward bleeding. And don't, if you get a bleeding of the venous channel, just put a Surgicel or gel form, the bleeding will stop by itself. Sometimes there is no place to, after doing a atlantoaxial dislocation, there is no place to put a rod. Then the drilling of the occiput to fix the rod is a critical step. One should know if number of times the screws are so much close that the rods are unable to fix it. So there's another trick which can be done and easily fix the screw and get the correction right. So there's the atlantoaxial dislocation, there's a post-op images which I get. The other thing is if we do not get parts or pedicle screw purchase, okay, we can go laminar screw, translaminar screw. These are as strong as the parts screw and works very well. So this can the reduction can be achieved. Even some salvage technique which Goel sir has been said that inferior facetal screw can also be purchased. So complications are certain venous bleeding, especially the medial epidural plexus, the lateral paravertebral venous plexus that are around C2 ganglion. We should be aware of it, just coagulate it and put a Surgicel or patty, it will work. Cord injury, that pushing C2 or joint manipulation, one should be very cautious that there should be no inadvertent movement of C1, C2 while performing surgery, while positioning also. So we should put a tremendous pressure over the C1, over the C2, or put a holder LEs C1 at the LEs to the C1 so that there is no inadvertent movement between C1 and C2. I thank you. These are the few tricks which I have learned for this atlantoaxial dislocation. I think this will be find it comfortable or can be usable few of the tricks by the juniors and all. Thank you.
Thank you, Dr. Bajaj, for your talk. Next, I would like to invite Dr. Niti Kumar Patel for his talk on transcambine endoscopic fusion case selection techniques.
Good afternoon, and probably I'm the last one standing in lunch and end of the conference. So I thank my teachers, beloved teachers, Professor Ghosh sir and Dr. Anil Pandey sir. It's an actually very emotional moment to come and speak on the stage among the giants. Probably I will be the junior most in the faculties here. Anyways, just want to tell everyone that when we have heard about endoscopic surgeries in spine, we have a lot of things in the minds that there is a lot of debates. We feel about the limitations that probably it is limited to only disc, but it is not so. We can, you give me anything and I can do, like disc, stenosis, listhesis, degeneration, whatever. So today I will just show one of the technique that is the transcambine endoscopic fusion case selection. So as we know, there are multiple ways to do the lumbar interbody fusion. So why transcambine rather than making talking bad about other techniques? So I just want to say that transcambine is a natural transmuscular corridor through intervertebral foramen, which is a natural space. And once you reach the disc space, you get all you're done. You don't have to deal with any neural structures. You don't have to do any muscle dissection, remove the bone. Or like other techniques like ALIF and OLIF, you don't have to deal with any critical abdominal structures. So this is very simple, reproducible technique which can be learned very fast, and it's very efficient. So basically, technically, it is a transforaminal lumbar interbody fusion, but we just come in posterior, lateral, oblique trajectory, and we, rather than removing the facet, we just make the utility of the limited space in the intervertebral foramen through the cambine safety triangle. So it's a facet sparing approach, and of late probably those who are into endoscopic technique, OLLIF is the word used very extensively. So a case selection, yes, the case indications has to be right, but basically all your indications where you need lumbar interbody fusions, you can very well do it with transcambine technique. And as we saw previously with Dr. Goel's talk, that he is not believing in probably any decompression. Yes, but if you feel you want to do decompression, probably you can do additional posterior approach. Although I avoid those cases where I need posterior decompression, I am still like using the balanced rational approach. So just we'll show you with the case examples how we do it. Like this is a 46-year-old gentleman who came with chronic low back pain and was avoiding surgery with this scan for many years because of the fear of spine surgery. He has L4, L5 lytic listhesis, which was increasing flexion, and on MRI we can see that he has predominantly only foraminal stenosis, both side, right and left side, and axial we can see that there is no central thecal sac compression. So if I can just do the fusion, fix it and restore the foraminal height, that's without disturbing this, that will be the ideal approach for this patient. And let's see how to do it. So it is done in prone position in same way as any posterior approach. So these are the critical instruments. Just want to highlight a few. This is the long spinal needle, 18 gauge and 20 centimeter long about, and 0.9 millimeter guide wire, and over that we railroad this dilator, and through which we pass this cannula, which is about 8 millimeter. So these are the instrument for use for access through the foramen area to the disc space, and these are the further mechanical instruments for faster disc removal. And the cage is little specially designed. It has one tapered smooth end on one end. So, and along with that we need transforaminal endoscopic system, but many orthopedic friends are doing it without doing visualization. So just will show you as we go.
So my steps, I do it under epidural analgesias. Patients are very comfortable, but just like for any awake cranial surgery, we do as a pre-op assessment and counsel the patient, so we can just do that thing. It is otherwise patients are really very comfortable. And I start the case with MIS pedicle screws fixation first, and then remaining work is through the intravertebral foramen for discectomy and disc preparation. Of late, I have added one foraminoplasty just to increase my comfort, and will show you how it makes a difference. So screws have been put on opposite side, and say ipsilateral side just K-wire has been just secured. And now understanding of this critical figure. Cambin's safety triangle is the key to have success in this surgery, and the only structure which we are worried about risking the injury is that exiting nerve root and dorsal root ganglion. While we are working on this, especially when we pass any instrument or bigger instrument through this area. So as I was mentioning, foraminoplasty means where we remove the non-articulating vertical part of the superior articulating process. That will just make the job very easy, reduce the risk of injury to exiting root, and we can put up front larger size of cage without need of expandable cage. So another important point for this surgery is the perfect needle positioning. We need to remove the maximum disc in these cases, so we need to position it in the center of the disc in both AP and lateral. When you have just to extend it, when we want to do only disc in transforaminal discectomy, where our herniated fragment lies near the canal or posterior annulus, we try to dock it so flat. So this is the key difference between transforaminal discectomy and the cases where we want to do radical discectomy for fusion. So once that needle has been positioned in the center of the disc, we replace it with the guide wire, and over that we pass this dilator, which is about 7 millimeter, over which we pass the cannula, and the further work is done with the endoscope, which is working channel. We can pass the instrument through it, and it has 30-degree angle vision, and it's done under constant irrigation. So just a few addendum, like when those who are not actually aware of endoscopic surgery, they get confused about lots of terms and lots of similar, but principally trans SAP or foraminoplasty or whatever you name it, basically we widen the foramen, so our access to Cambin's safety triangle, we get little more space, and so that's we can do it either percutaneously with reamer, just in orthopedic style. It is very quick, easy, and safe. And otherwise we can just start our endoscopic work from here outside, and we can do it with the drill under endoscopic vision. But advantage is that it is very quick, fast, and when we use the serial reamer, the same reamer I pass percutaneously inside the disc space, and which helps me removing the disc material very fast. So it's very efficient and faster way to do the surgery. And another challenge is like when disc space is very severely collapsed, listhesis, then you find sometimes difficulty in positioning your needle in first. So in these cases, putting the screws is of advantage. If you distract it probably, and with listhesis reduction, you get little extra space, and sometimes if one side screws are not working, you can put bilateral and put distraction. This will give additional distraction, and which will make the further work very easy. And you can see from just 1 or 2 millimeter space to 7 millimeter dilator is positioned very easily. And also why I secure the access to the pedicle first, because I want to obtain the bone marrow for the allograft packing. So once I have position and position my cannula, the further work is done under endoscopic vision, and whatever remaining disc is there, we can remove it. And this is the stage of the cartilaginous end plate removal. You can see how clearly we can see inside the disc space and do the preparation under our vision. We are doing the surgery from the left side, so this is the cranial vertebra, L4 lower end plate, and this is the caudal end plate. And you can see we have removed the large disc material. We have reached up to entry annulus, which we can confirm it on the X-ray. And end plates are not damaged, so and there is good potential bleeding. So this is very good for fusion. As we come out, we show the posterior epidural space. That is the whole thing which we have exposed to the neural structures, and then we can just remove the scope and can peg the allograft. This is the one disadvantage. We don't get any autograft, but we have now good biologics and allografts which we mix with the bone marrow, and we can peg the maximum amount as anterior as possible for better fusion. And I can tell that fusion rates have really become so fast. Patients are have done good follow-up of in 2-3 months time we start seeing the fusion. So this is how the allografts being packed through the same cannula, and then we leave the guide wire inside, and then we pass this endo cage. So cage insertion is just percutaneous over this guide wire. It has a special tapered design. So once it engages, pass through the foramen and engages in the end plates, we remove the guide wire and just hammer it down till its position. So as it reaches the foramen, we just remove it and then hammer it down. And patient is awake. This is the one stage where we have to be very quick. We don't have to we should not spend a lot of time around foramen, so to avoid any irritation to exiting nerve root. So this is the inspection after cage insertion. We can see that it's placed deeply, but after cage insertion, once the scope is out, you can not see a lot of structures very clearly, but this is the posterior epidural space near that, and we can see that fat around the exiting route here. So means exiting route is totally safe, and patient is under epidural, can give me live feedback, and this is the post-op, this is after the both AP and lateral final positioning. And patient got very good relief, 2 months scan after. These are the skin scars. Multi-level cases can also be done in similar way, and just we have to plan it. We have to understand the foraminal anatomy, study it well, and levels are not the restrictions. And to have an additional this expandable cages are available, so which can be expanded from 8 millimeter to 14 millimeters. So this will avoid this will make our surgeries further safer and avoid the risk of injury to exiting route. So there are, I think my message is very clear. I don't need to repeatedly say it. It is the least invasive, uses the natural corridor, very quick recovery, and those who are interested in learning this endoscopic, we have just a practical manual for full endoscopic spine surgery released last month. There are we see lots of message about WhatsApp University, but these are quite useful. Spine surgery, endoscopic spine surgery does not require extensive training like skull-based surgery or other part of neurosurgery. You get lot of mentors here and get useful information. I thank you. Thank you so much once again.
Thank you, Dr. Patel, for your talk. Coming to the last talk of the session, we have a virtual talk by Dr. Sarat Chandra on C1, C2 stabilization.
So good afternoon. Am I audible and visible?
Yes, sir.
Okay. So I would be speaking about, there is some echo there. I hope my audio is okay.
It's okay, sir.
Okay, thank you. So today I will be speaking about how to align C1 and C2, particularly in severe basilar invagination and atlantoaxial dislocation. We all know the seminal work done by Professor Atul Goyal. So the question is, if we end up getting pathologies like this, how do we treat these pathologies? Okay. So we have developed the DCR technique. It's registered with the US patent as mentioned here. And we are also in the process of developing a universal reducer. So we have to understand that the cranium is balanced more delicately on the head than the planet Earth being on the shoulders of Atlas. And it took us almost 4 or 5 decades to understand that the key is the joints. So I have got 2 videos which I will show you. The first video is that of a C1, C2 fixation in a child with Down syndrome. Now Down syndromes, they have extremely mobile C1, C2. So it is very important that they undergo very good fixation. And the only kind of fixation I prefer is a C1, C2 fixation. If that doesn't work, I try to use a translaminar screw, and I will not recommend an occipito-cervical fusion in these cases. So that's a C2 and C1. So this is an avascular surgery. One has to know and understand and how to tackle the blood vessels. So we have exposed, now we are cutting the C2 ganglia that has been cut with sharp dissection. And then exposing the joint on the left side. So once we expose the joint, the cartilage should be completely taken away so that there is no opposing cartilages. Then exposing the joint on the opposite side. Then I prefer to put in a periosteal elevator and mobilize the joint. Now using for spacers in such conditions where we do only a C1, C2, I prefer to take autologous bone from the C2 and C3 spine and use it, because that's very simple. And then putting the screws. So the C2 power screws goes from the medial edge and the lateral edge. So you don't need a C-arm in order to visualize putting a C2 power screw. You have to visualize as if you're drilling a tunnel under the road going up to the C2 joint. And then I prefer to use a tap, but don't use the full length of the tap. And then inserting, sorry about this. So that is C1 and C2. Now when applying screws in C1 lateral mass, one needs to apply counter traction, because you don't want to push the C1. You can push the C2, but not the C1. And then tapping the C1 lateral mass. So there's no need to use a C-arm. One needs to only calculate the length of the screws, which can be easily done using a CT scan. And I never use a C-arm for putting the screws. It just takes about. Now when inserting the rod, it is very important to insert the rod and tighten the screw for C1 first, so that the C1 is, so that the C2 is pushed forwards. So this kind of lever mechanism creation is very, very important. So this is a very, very simple procedure. Finally tighten and we'll put some bone graft. Now let me show you more complex procedures. So this has got an audio. I hope you can hear the audio.
An extension view.
Are you able to hear the
CT
audio?
scan with cerebral reconstruction. 3D CT with angiogram.
Are you able to hear the audio?
Yes. Yes, sir.
CT scan with cerebral reconstruction. 3D CT with angiogram. MRI is showing severe compression. This slide briefly explains the concept of pseudojoint. So the surgery which was done was a DCR technique, which stands for distraction, compression, extension, and reduction, where the spacers are used as pivots to reduce both atlantoaxial dislocation and the residual bacilli invagination. DCR is indicated in cases which are congenital, where the C1 is hospitalized, especially those associated with severe bacillar invagination and atlantoaxial dislocation. We prefer a 3-point fixation, which includes occiput, C2 or C3, and C3 or C4. These are some of our brief publications. DCR makes a plumb line correction, as it can be seen here. We even demonstrated in our studies. Surgery is performed with patient prone on a horseshoe. Generally, I don't prefer a traction, but if at all traction is required, we can place the patient in a Gardner's traction, more for stabilization rather than for the use of traction with perhaps 2 kilograms of weight. We perform a standard exposure from occiput to C4. The following video shows exposure of the left joint, where we are drilling a bit of C1 arch to create more space, and we are exposing the left C2 ganglion. In this case, we were able to preserve the C2 ganglion, and this shows exposure of the left side joint. Now we are exposing the right side. We are now performing the foramen magnum drilling. In this case, it can be seen that the foramen magnum was very deep, and we drill about 2 to 2.5 centimeters. It's important to also remove the fibrotic bands to release the cord posteriorly adequately. Here I'm showing the exposure of the right side joint. As you can see, I prefer using a variable impedance bipolar, especially from Sutter, which allows me to very nicely and adequately coagulate all the venous plexus. It's very important for us to disarticulate the joints completely. So here we're disarticulating the joint on the left side, and in this case, I prefer to use a periosteal elevator and turn it right angle. And following this, we do joint remodeling and denuding the articular cartilage using a diamond drill. Once the joint is ready, we are introducing the spacer. So since the basilar invagination and aid is very severe here, I start off with a spacer which is 11 millimeters on the left side and 10 millimeters on the right side to allow me correction, which is on the coronal sections. So these are the special spacers which have been designed by us, which are biconvex spacers, which allow the spacers to be converted into pivots while performing the technique of DCR. So now both the spacers are in situ. Here we make place lateral mass screws in C3 and C2 power screw, so as to allow us to provide C3 3-point fixation. The following diagram shows the universal reducer, which we are developing in collaboration with Medtronics. It consists of a reduction system, which has a C2 translator system, as well as a cable wire reduction, which is made of braided stainless steel, which is much more stronger than the usual titanium cable. And it is attached to a special tensioner device. In this case, we have used only a wire compression, as the posterior listhesis of C2 was not significant. So in this technique, we are first placing a temporary occipital plate. In this case, I prefer to place 2 occipital plates in order to provide me a long length traction of the wire. Now we take the specially prepared braided stainless steel cable, which is glued around the C2 spine and then passed along the holes of the occipital plates. Now this is then passed to a provisional crimp, and now we use the special cable tensioner. So when we tighten the cable, this leads to compression, that is very good impaction between OC1 and C2, and the spacers get impacted very nicely. Continued compression leads to extension at the OC1 and C2 joint, as it can be seen here. So here the spacers, both the spacers, they act like pivots, leading to a complete reduction of basilar invagination and AAD. The specially designed nature of the spacers allow adequate reduction. Now in this case, using 10 and 11 millimeter spacers, we were not able to achieve enough reduction, which was expected, but I always start off with the smaller size spacers and then slowly increase the height of the spacers. So now I remove the earlier spacers, and now I'm using the final size spacers, which are 18 millimeters on the left side and 16 millimeters on the right side. Generally, the large size spacers are very difficult to introduce, so I use a special railroading technique using the periosteal elevator. So we have to understand that increasing the height of spacer provides us the additional liver advantage. So in case we are not able to achieve optimum reduction, by increasing the height of spacers, we will be able to provide that additional advantage, which will allow us to reduce both the AAD and BI satisfactorily. So the left spacer is now in C2, and now we are introducing the right side spacer. And you can see how their spacers are hammered inside. And now we repeat the cable compression again as shown earlier. And this again, you can see will lead to moments of compression followed by extension at the OC1 joints. And this time we have achieved adequate reduction as it can be seen on the OM image. Also note the adequate correction of cervical hyperlexis. Now you can compare this with pre-op scans, and there has been a very good and a significant reduction. At this point, we fashion the rods in order to perform the standard 3-point fixation, which includes an occipital cervical fixation. Placing adequate bone graft mixed with hydroxyapatite ensures good bone effusion. Post-operative CT scan shows very good reduction. This is another short example just to show the use of a C2 translator. So this is an 8-year-old boy with severe spastic quadriparesis, short neck. And in this case, you can see that there was a severe basilar invagination, AAD, presence of a pseudojoint, and there is also a backward movement or a listhesis of C2, which leads to severe angulation of the dens backwards. So the patient also had a posterior fossa dermoid, and we reported such rare instances in neurosurgery way back. So we have to understand that when the basilar invagination and AAD becomes severe, there is also an additional motion of backward listhesis of C2 over OC1. And in such cases, we prefer to use the C2 translator. So we place the standard occipital plate. The spaces are already in C2. In this case, you can see we're providing a special C2 clamp, which I generally prefer using it in pediatric patients in order to prevent the slipping. Now, we place the C2 translator with the pivot on the occipital plate. A screw is now passed through the hole. And now we can see that we are providing simultaneous movement reduction with the cable tensioner as well as the screwdriver. So the cable tensioner provides compression and extension, whereas the screwdriver here pushes the C2 forward, leading us to a very optimal reduction of the listhesis between OC1 and C2. This is a 3D OM image. And we have designed the special spacers which could be connected to a rod by a connecting rod, which we have placed in this case, and you can see it's a very satisfactory reduction. The dermoid was also removed in the same setting. Both patients improved in the spasticity and power and were walking at rates. Thank you very much.
Thank you, Dr. Chandra, for your talk. We will now have a simulation surgery on bypass by Dr. Andre Giovanni.
It's on? Can you hear me? Okay. So I will try to, because the time is too advanced, I will try to go quite fast here. So I will try to demonstrate terminolateral bypass on this model. Actually, it's the first time that I use this kind of silicon model, but let's see what we can do. So first, before you... Yes? Okay, now it's coming. So before you put the clips in a regular bypass, you should prepare it first. And preparation means a lot of small steps. First of all, you need a rubber dam underneath, so that when you come with your needle will not get stuck in here or something. Underneath the rubber dam, it is better that you place here some very small tube, silicone suction tube, because otherwise the field will keep filling with CSF and blood, and it will not be good for your work. Actually, you should be quite expeditive, quite fast in doing the bypass. So once you put the clips, you should try to maintain a pace of 1 stitch per minute. Sometimes you need to use more than 20 stitches. So sometimes it will get more than 20 minutes. Stop this now, okay? Okay, so now what you see, I cut the vessel, and now I will do a fish mouth in the donor. So let's consider this is our donor artery, like SCTA, and this is our recipient artery. Some gauze or something here, please. It will fall on me, okay? Okay, so now in the donor artery, we need to do this fish mouth, which is done like this. I think this length will be enough. Maybe it's a little bit too long, but we will see. And next we have to cut a hole in the recipient artery. Actually, this material is it should be much more thin than it is now. It will be quite difficult, probably. I have 10-0 sutures, and probably they can break with this, but let's see. So you should also always check to see if this matches this one, yes? Okay. Now I will prepare maybe 10-0 you have? I'll take this. I will prepare an 11-0 suture. Wait, what? No, I need, so I have 2 needles actually, I only need 1. This one I can. And always, you will have the tendency in the beginning to take all the thread, but you don't need a thread that is very long. It will be quite difficult for you. So what I advise you, that you keep the thread shorter. I need some gauze here, please. I asked before. Or some napkin or gauze or something. Okay. So I trimmed it a little bit. Okay, and now how we should start a bypass. Always there are 2 stitches that should be positioned first. One heel stitch, it will be this one, or toe stitch, excuse me, and one heel stitch here. I like to start by placing this one. You are not allowed to squeeze. So if you close this instrument too much on the vessel, the vessel will will thrombose or you will break the tissue. So now I think I will take it in 2 movements because this material is too tough for my needle. And I have to reposition here. Also, I get this tremor because I don't have an armrest and my hands stay in the air. It's not normal also. And I will try to use some separate stitches. So when you make the loop should not be, the segment should not be very long. When you make the loop, you come with this movement from up, down. Just a moment. The material is very this knot will not stay here. I'll try a double knot and let's see if it is better. You see it comes out. Can you find me some other thread? Can you open some other thread for me? Some 10-0? Okay, you keep it there for me, just a moment. Now I will try to position the other. You can work with both hands. One hand can stay inside the vessel. And we have a problem here because wait a little. So maybe this orientation is a little bit better. The problem is these vessels are too elastic and they will not come when I want to do this, to rotate. But I hope it will be okay like this. Yes, give some instrument from there, I don't know. It is quite a big problem because this type of silicone will not keep the, once I do the knot, once I tie the knot will not stay there. And this will never happen in a normal situation. You see? I tie the knot and it comes out. Let's see, maybe now it's better. Okay, so now I can go on doing a continuous stitch on this side, and then I'll throw a continuous stitch on the other side. Yes?
I think, probably we should have thought of that arm support for you. But probably if you can put another 2 stay switches, I think we'll call it a day. Because
It takes too long? Just wait. Yes, I think I can complete it. Don't worry. Yeah, maybe it took too long because the material is a big problem.
The material, it's not ideal, no?
Yes, yes, it's very, yes. Support is not there also, yes.
Do more on the sides and then you just...
Yes, whatever you want. Yes, I will finish this part. No, I will finish this part because it's quite fast and then we can stop. You see, when you have clips, it is very important not to waste too much time because this one can go into the clip, the thread, and there you will have a big problem. Okay. One more and I'm done on this side, and very fast I will do on the other side as well. Wait, don't move, no, don't move everything too much. Can somebody take this water away?
Is it fine?
Yes, fine, it's better. Okay. Just with some gauze, please, with some napkin. Yes, so now I'm done with the first side. No, give it to me. And I will go on with the other side. No, you can go, it's okay. When you go with the other side, a little bit you should rotate the vessel here. And also make sure you're on the inside of the vessel. All the time when you pass the needle, you should be able to see the lumen in between. Yes. I will not place too many stitches. Usually in a length like this, you should place like 10 or something on every side, but I will just demonstrate a few stitches more. Okay. It's flowing. Stop this. You can stop this. I thought if I put a clip there, it would stop by default, but it's not like this.
Flow is stopped, but this is a different vessel.
That is a different vessel?
Yeah.
No, I thought it should come. When you are not able to see the lumen very clearly, what you should do is you take the bite into, it's very electrified this. You should take the bite in 2 steps. So 1 step on this side, and then you rotate your needle, increase the magnification a little bit, and go and search for the other wall, for the other side. Here is the other side. Wait, don't worry. Stop. Can you stop this vessel? It keeps coming on this one. Okay. So a slight problem was there. So I now, because I cut that old suture, I now use the new one, and I should tighten them together immediately. It's better at lower magnification for this one. Yes, so depending on the material, the suture will stay or it will not stay there. The kind of material is very important, because if you work on real arteries, on animals or human or whatever, you will not ever have this problem of your knot opening after you did it. So your knot will be there. Just a moment. You see, now I tie the knot and it opens. This is not what you will encounter in real life. So we just cut this, cut this. And only a few more stitches to do. Increase the magnification a little bit. You always have to do this game with magnification. This microscope cannot move, right? It can move? Wait a little. Maybe I will move the artery because yes, and what happened? Okay, I think I will stop here because it takes too long. This material is quite impossible for this. Okay, thank you. No, maybe I should have used the chicken wing because in that model I know and it goes perfect.
So I thank Apollo Hospitals, I thank
so
all
much.
the sponsors, I thank our brilliant team, Dr. Pranav, Sopernica, all those who have managed this thing without professional event managers, and it has been a better show than them. I thank doctors, and of course, last I would really thank Tianilla, because with her quiet efficiency, she definitely managed all the scientific sessions exceedingly well. So I thank one and all of you. Thank you so much.